Cornea and Refractive Faculty from RP Center, AIMS.
Good morning, Tushar sir. Very good morning, sir.
Dr.
Ma'am, we
Tushar,
are live.
unmute yourself.
Good morning, sir.
Ma'am, we are live.
Doesn't come to the picture very frequently, but he's a very eminent and giant personality of Cornea and Refractive Faculty
Ji,
from
ma'am.
RP Center, AIMS.
Dr. Bharti, we are live.
Okay. So, good morning, all of you. It's a pleasure and honor for Jharkhand Ophthalmological Society to welcome all the esteemed guest faculties across India of national and international fame. We have selected array of top 9 stalwarts as judges, 16 national stalwarts as speakers across India who are heading their subspecialty in this part 1 online 22nd midterm conference of Jharkhand Ophthalmological Society. We have kept innovative sessions, then case presentation session to keep PGs involved and motivated, RP Tandon oration session, guest lecture sessions, and in second part, we have kept international hero session and JHOS potpourri session. JHOS is a small society, but its impact has been always felt nationally. For the second time, JHOS, our society, has been recognized at annual conference of AIOS in Kolkata for being the best state society in the category of 100 to 500 members. This was given to us for best CME activities and PG teaching projects and public awareness campaigns, which we conduct throughout the year. In 2019, AIOS ARC JHOS Se JHOS Jalao campaign for diabetic retinopathy screening, we provided the maximum data across India, and the society was felicitated also by AIOS president in the annual conference. So with this, I'm ending. The society is small, but its impact is bigger. So now I request our president, Jharkhand Ophthalmological Society, Dr. Nandita Agrawal, to address all the viewers and inaugurate the 22nd midterm online conference of Jharkhand Ophthalmological Society. Over to Madam.
Thank you, Dr. Bharti. Good morning to our esteemed judges, learned speakers, and eager and enthusiastic participants. Ladies and gentlemen, to this 22nd Jharkhand midterm conference and this very new session which has been added due to the untiring efforts by our chairman scientific committee, Dr. Bharti, who is constantly thinking of providing new platforms for our young ophthalmologists. It also makes the conference interesting and fresh. It is due to her untiring sustained efforts and encouragement that Jharkhand state has won a national award for 2 consecutive years as the best state, and that is a great achievement. And I take this opportunity to acknowledge her efforts and congratulate everybody who made this possible. I am convinced that JHOS will continue to grow and its ophthalmologists will go on to bring more glory and the awards for the state. Jharkhand also won the maximum contribution by an ophthalmologist at the national level, which was Dr. Vibhuti. Congratulations, Dr. Vibhuti. Best of luck to all participants, and may JHOS continue to grow and bloom. I declare this conference the open and hand over the mic to Dr. Bharti.
Thank you, madam. And I highly appreciate your presence because she has recently suffered from very severe stroke and she has still participated. So thank you, madam. And now, before handing over to our secretary, Jharkhand Ophthalmological Society, Dr. S.K. Mitra, to introduce our esteemed judges, I'm going to introduce chairpersons. So we have Dr. B.N. Gupta as one of the chairperson. He's ex-president Isaac, and he's the past president of JHOS also. Dr. B.N. Gupta, sir, good morning. Then we have Dr. Deepak Lakra as one of the chairperson. I have already introduced him. Dr. Suja Samanta is here. He is the best organizer of our annual conferences. Dr. Mala Verma is here. He is the best oculoplasty surgeon Jharkhand has. Hello, Dr. Malay. Dr. Ajay Gupta is the secretary, Jamshedpur Ophthalmological Society. Dr. Atma Prakash is the secretary, Dhanbad Ophthalmological Society. Dr. Jahid Siddiqui is the secretary, Bokaro Ophthalmological Society, and he's a very good organizer of the conferences as well. We have session coordinators who all are set to coordinate this very important session. Dr. B.P. Kashyap, he is the past president of Jharkhand Ophthalmological Society and takes keen interest in all the academic activities of JHOS. Dr. Sunil Kumar, I already introduced. He is the chief of the Rio RIMS, the largest medical college of Jharkhand. And Dr. Rahul Prasad, he is the senior faculty of Rio RIMS, Ranchi. So now over to the session coordinators who are going to coordinate, and then we will announce the result after the second session. The first award is 15,000, the second is 10,000, and the third award is financial award is there, 5,000, and the NTOD has sponsored it. And after the second session, that is the in extramural oration, RP Tandon oration, we will announce the result. So stay there till second session, all the innovators. And over to session coordinators, Dr. B.P. Kashyap, Dr. Sunil Kumar, and Dr. Rahul. So all my stage is yours.
Good morning, everybody. Lahane sir.
Oh no, excuse me. First, Dr. Secretary, Dr. S.K. Mitra has to introduce the judges, honorable judges.
Excuse granted.
We welcome our secretary, Dr. S.K. Mitra. He's a very renowned ophthalmic surgeon from Jamshedpur. Dr. Mitra, hello. Please unmute yourself. Suno.
Hi, Dr. Ranjit. Good morning, everybody. Dr. Lahane.
Dr. Mitra, are you having any technical problem? Please unmute yourself. Premata ko bulao.
Ankita,
Can we share the judges' slides from here?
unmute.
I'm telling Dr. Mitra to unmute himself. Dr. Mitra,
He is not visible.
you are visible, but you are not audible. Slide show कर दो इधर से. Judges का slide show करो.
Hello,
Yes.
am I audible?
Yes.
Yeah, good morning, everyone. Happy Dussehra to all of you. I just have introduced a few, our 5 judges. First of all, I am introducing Dr. Ranjit Maniar. Can I have the slide, please? Can you share the slide?
आपको स्लाइड कल दे दिया गया था ना. आपको कल स्लाइड दे दिया गया है.
Yeah, slide I am having, but can you share it in the screen?
हेलो, स्लाइड शेयर करने बोलो. डॉक्टर मनियार का शेयर करो. पहले डॉक्टर लहाने सर का शेयर करो. अरे पहले से बताया नहीं ना. चलो.
Should I go ahead?
Please introduce Dr. Lahane sir, Padam Shri first.
Yeah.
क्या किया है? सब.
start reading from your laptop, Subrata.
No, he's not doing. We are doing.
Okay.
Yes, please start.
Yeah, Dr. P.P. Lahane sir is an awardee of Padma Shri by Honorable President of India. He is the ex-director of Medical Education Maharashtra, ex-dean Grant Medical College Mumbai, underwent kidney transplant on 22nd February 1995. Mother Anjanbai donated him her kidney, but he is very, very vigilant and very, very energetic still now. Organized 693 eye camps, out of which 192 was operative camps, and he has treated about 5 lakhs patients. He has personally operated 177,000 cataracts and 32,000 other surgeries. Total 209,000 surgeries.
नाश्ता कराई.
He has upgraded department of Sir JJ Hospital to Tertiary Care Regional Institute. Because of him, cashless is banned in Mumbai. Because of his effort, there is not a single case in consumer against ophthalmologist of Mumbai. He was awarded Padma Shri in 2008. He has more than 400 awards to his credit. He delivered more than 300 lectures in different conferences. He has demonstrated live surgeries in 207 different conferences. We welcome you, sir, to this 22nd midterm conference of JHOS and want to hear so many things from you.
Thank you, sir. Thank you very much.
Yes, sir. Next, Dr. Ranjit Maniar, sir. Dr. Ranjit Maniar, sir, graduated from Lokmanya Tilak Municipal Medical College and Hospital in private practice since 1982. Keen interest in cataract and glaucoma. Ex-PG teacher at Sadguru Netra Chikitsalaya Chitrakut. Winner of CS Resme Award of JHOS. Awarded the Sadguru Gold Medal and BOA International Master Award. Represented India at WOC Paper Session, Sao Paulo. Co-editor of IGO with 2 editorials. Organizing Secretary of iAdvance Conference since 1996. Numerous presentations in India and abroad. Co-authored the Constitution of JHOS and FBS. And he specializes as a system analyst of hospitals to improve service delivery, efficiency, cost effectiveness, etc. Welcome you, sir, to this 22nd JHOS Midterm Conference.
Thank you. It's an honor.
Dr. Kanud Dada is an MD FRCS, Professor of Ophthalmology and Head of Glaucoma Services, RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi, Board of Governors, World Glaucoma Association, Board of Directors, Asia Pacific Glaucoma Society, Executive Committee, International Society, Glaucoma Society, Surgery, Associate Editor of Journal of Glaucoma, Editorial Board, American Journal of Ophthalmology, Chaired Scientific Session, World Glaucoma Congress 2025, the Asia Pacific Glaucoma Congress of 2026, over 350 index publications and 5 glaucoma textbooks. Our other judge, welcome you, sir, also to this 22nd midterm conference of JHOS. Dr. Tushar Agarwal is an MD of Ophthalmology, Professor of Ophthalmology in AIMS, New Delhi, Chairman, National Ophthalmic Surgical Skill Development Center at RP Center, AIMS, New Delhi, also serving as Officer in Charge of the National Eye Bank. He oversees the collection and transplantation over 2,000 corneas every year at AIMS, currently pursuing research in an area of advanced cataract surgery, iris repair, reconstruction technique, pterygium and new technique of lamellar corneal surgery. He has published more than 175 peer-reviewed scientific articles to the national and international books, authored a textbook of ophthalmology, awarded the Indian National Science Academy Young Scientist Medal for 2004, recipient of Achievement Award, the Senior Achievement Award, and Best of Show Award by the American Academy of Ophthalmology, awarded the ESCRS and Alcohol Prize by the European Society of Cataract and Refractive Surgery. Welcome, sir. Welcome, Dr. Tushar Agarwal, sir, Tanuj Dada, sir, Dr. T.P. Lahane, sir, and Ranjit Maniar, sir, to this 22nd midterm conference of JHOS. Over to the session coordinator.
Dr. Bharti, let me say at the outset that it's an honor to be here. And in fact, I am a little afraid of the presenters who are top-notch people in their own right. And I feel a little small judging such stalwarts in ophthalmology. I'd also like to commend the Jharkhand Ophthalmic for such an innovative program. With that, all the best to you, ma'am. Please go ahead.
Thank you and good morning, everybody, sir. So our first speaker will be Dr. Jagdeep Kakaria, Bhavnagar-based ophthalmologist. He's a solo practitioner since 1989 in Bhavnagar. He had done a lot of cataract surgery, more than 65,000, glaucoma surgeries, more than 55,000, and many anterior segment surgeries, which is processed in thousands. He has done keratoplasties also. He names them as a dropless keratoplasty and dropless cataract surgeries. He has also developed custom LASIK, that is exclusive surface ablation, and the number is more than 10,000. He has received a lot of awards. He has received Dr. Daljit Singh Innovation Award in 2023 by SICS. He has received the prestigious Iron Mathematician Award in 2023. Newton in Ophthalmology Award, that is Think Under the Apple Tree Award in 2019. And he has got many state orations awards, more than 10. We can call it innovations thy name. So you have done a lot of innovations. Hats off to you. The few of them is autofocus pro IOL, that is ringless progressive IOL. OmniGlow, that is stereo coaxial illumination device. UV Glow, that is UV device for C3R skin. The OmniShow, that is anti-glaucoma retrobulbar drainage device. OmniPro Supra, that is supracoidal shunt for glaucoma drainage. Terigo, a special large BCL for suture and glue-free pterygium surgeries. StellaFlow, that is autoclavable and reusable cassette for tubing and for Bosch and non-stellaris. MaxiGlow, a device to really see presence of moxifloxacin in the eye. And LaserX, that is laser-based storic axis marker. VideoGlow, that is contains hardware, firmware, and software to record, store, categorize, and retrieve and edit surgical video, and many more to them. And he keeps on doing innovations. Hats off to you, sir. You are a real man of innovations. Our next speaker, Dr. Narendra Singh Verma, is a comprehensive ophthalmologist. He is based in Surendranagar, Gujarat. He specializes in cataract and refractive surgery. He has been former resident at the Venu Eye Institute, New Delhi, which is known for his innovations. Conducted IO camps on the Lifeline Express across the multiple regions in the country. There was a Lifeline Express, it went from one station to the other, and it involved a lot of local eye places, and the very good, very meticulous, very clean surgery were done. I was also a part of it. He was awarded first prize in innovative competition, that is Think Under the Apple Tree at ARC during AIOS 2024 annual conference. He is a recipient of Best Paper Section Award at APACRS 2024 in Chengdu, China, and multiple presentations in national and international arena. He has interest in literature. And he is known as a good and popular. He is about popular Gujarati literature, and he was instrumental in saving lakhs and lakhs of cows from dying due to lumpy skin diseases. He has done extensive work, and he was instrumental in saving people against COVID, especially by webinars on UV lights and methylene blue against the COVID-19. Some of the innovations are LED-based indigenous topographer. It analyzes 600 data points in the 9mm synchronous zone. Provide keratometry in 3, 5, and 7mm zones and heat map and NI-DUT. Like image guided system assists in axial alignment and realignment of body IOL after the operation. Our third to my introduce is next is Dr. Santan Gopal. He is our ex-president. He's very young. It doesn't look like more than 50 years of age. He has worked very hard in CNC Vellore and then University Hospital in Nigeria. Worked as consultant in UK for 15 years after his start from St. George Hospital in London, UK. Worked as consultant in Middle East and now practicing in Bangalore. Some of his innovations are orthoptech works due to sequential stimulation of the both P cells and M cells attention in the peripheral cortex, both of which is in turn stimulates the 4C beta in 5-1. 5-1 acts as an image forwarding center to inferior temporal cortex, and the top-down impulses that is recognized as alpha and beta oscillators in EEG. Fast forward impulses across the blocked synapse to inferior temporal cortex, which is supposed to be one of the latest thing in case of treating amblyopia when the patient is not responding to your penalizing the eyes. And our next speaker is none other than Dr. Arvind Kumar Maurya. He is based in Hyderabad, additional professor and head of the cataract, glaucoma, refractive, pediatric surgery, and medical retina services. You can find him in each and every conference these days with his newer innovations, and people applaud for all his works done so meticulously and brings his samples of whatever he has done, like tube and etc. He is the first Indian to win a 100-star award at Amsterdam ESCRS 2021. It's no jokes, fantastic. AIOS International Hero Award for the year 2020, 21, 22, 23, and 24. First to receive AIOS Senior Academic Award in 2021. One more prestigious award, AIOS award, that was 3 Best Paper in Cataract and Refractive Surgery. RSI Gold Medal, Best Innovation, Best Cornea Video, and Best Free Paper Award. IFA JHOS Best Video Award. Heading many projects based on AI, on DR, diabetic retinopathy, and glaucoma. 600 international and national presentations, 100 international and national publications. He is associate editor for many things like UK JHOS, section editor IDO, editor board member EC Ophthalmology, WJCC, IDO VS, JHOS Times, and JHOS. He has been conferred 12 Orison Awards, Best Video Award and IDO Honor, Teachers of Tomorrow, Best Poster Award by AIOS, International Faculty and SSC, SSO, VOC, ICO, ESCRS, Social Enterprise of the Year 2023, Award by Ophthalmic Practice Development. I was lucky to have his company many a times. We have spent times together. He is a gem of a person.
Thank you, sir. Thank you so very much.
You're welcome, sir. So can we start with the first paper by Dr. Kakaria? He'll be talking on OmniGlow, the most cost-effective digital illumination system for operating microscope. Sir, please over to you.
Thank you very much, sir. I thank Jharkhand Ophthalmic Society in general and Dr. Bharati Kashyap in particular for inviting me to this prestigious conference. And I would like to share my screen.
Sir, you have to stick to the time. So now we are starting the time. It is 6 minutes.
Yeah, it is 6 minutes. Is my screen visible, ma'am?
So now the time started.
Hello, dear friend. It is visible. It is visible. Please start.
Introduce to you OmniGlow, which is a stereo coaxial illumination device having its own dual lights, which can be fitted at the bottom of any surgical microscope, which will convert it into a Lumira eye-like stereo coaxial illumination. It is quick and easy to attach and detach OmniGlow, and when fixed with a single bolt, it becomes integral part of the microscope. And OmniGlow is now complemented with VideoGlow, which is just a 50 grams matchbox size micro head full HD video camera, which is inserted directly into the beam splitter without any C mount or L mount or DSLR mount. It can record videos and photos in laptop and or desktop, and also can simultaneously live stream to multiple monitors inside the OT as well as outside the OT in conference or waiting room. It can also do live streaming on YouTube. With OmniGlow, omnipresent, homogeneous, and full red reflex with greatly enhanced stereopsis is 100% guaranteed in any position in the surgical field, in any tilt of eyeball. The glow is like a sunrise in eyes. With OmniGlow, we never need blue dye for capsular axis except for white mature cataracts. Not only we can see, but we can also record with VideoGlow what the surgeon sees in exact and in vivid and beautiful colors. In hydro procedures, fluid wave and golden ring reflex can be recorded so well. Glow is omnipresent even during the phaco-fragmentation procedures. OmniGlow also has enhanced stereopsis optics. Please notice that even in this 2D video, we can fairly well perceive the depth, the enhanced third dimension. Thanks to the optical phase contrast of OmniGlow, we can visualize every optical interface so well that surgery becomes a real pleasure. OmniGlow not only enhances glow, depth, and contrast, it also enhances surgeons' confidence and morale to handle tough cases. Please notice the amazing clarity of interface between the BSS and Visco. Also the clarity of diamond dusted tip of the aspiration handpiece. A beautiful view of cortical sheets, cortical fibers, and posterior cortical fibrils. With OmniGlow, we can see the anterior and mid-cavity vitreous so well. Even in 2D video, we can perceive the enhanced depth. Removal of cortical fibrils from the fornix as well as from the posterior capsule during the vacuum polishing of the PC as well as the star folds of the PC are all so well visible. Polishing of the anterior capsular rim is not only beautifully visible but also so well recordable with OmniGlow and VideoGlow camera. OmniGlow ensures full red glow even in small pupil, in any tilt of eyeball, in any position. OmniGlow name is derived from the fact that it gives omnipresent red glow, which the conventional illumination of normal or basic microscopes cannot give. Even in a nearly mature full cataract, we can still see some glow with OmniGlow, which gives us a nice confirmation that the vitreous behind is clear and that there is no posterior polar. Visco wash is not only clearly visible, it is so beautifully recordable, washing out debris in front as well as from behind the IOL. The combination of OmniGlow and Video Glow gives nice smileys, not only on patient's eyes and face, but also on surgeons and entire staff's face. The Space Tech ISRO or NASA level optics of OmniGlow and Video Glow allows us to see and record the capillary blood flow, the RBC clumps and plasma flowing in corneal venous vessels like a moving line of red ants or like a river on the planet Mars. Thank you very much for your kind attention.
Thank you, sir. Thank you very much.
Thank you, sir.
So these innovations you have made yourself, it seems that you have got a lot of tools to make these instruments and get the fittings of different microscopes. How do you do it, sir?
Sir, I now have a hold of one full workshop. So I have a team. I now have created a team of engineers who can design and do what I need. And I learned AutoCAD, so I make the designs myself, me and Dr. R.C. Shah is now present here. So Dr. Ramesh Shah gives me some idea that we should do like this, and then I start creating it first in the 3D AutoCAD, and then I give it to the mechanical engineers and optical engineers that you please make this device for us.
The mic is handed over to the judges. Any questions? You can please go ahead, sir.
Jagdeep, this is Dr. Lane.
Yes, sir.
I
Namaste.
really appreciate it's a very good device, and because of that, the microscope prices up. All the people are really gone down in this Zeiss microscope or other microscopes, and the simple microscope can work like an Lumira microscope. Very good it is. My one question is that every time when we are doing for the vitreous surgery, we will have to remove this device. Are you doing some innovation for that?
Yes, sir. In fact, I have made about 50 OmniGlows for a couple where husband is a intersegment surgeon and wife is a retina surgeon, or two partners where one is a retina surgeon and the other is a intersegment surgeon. So in place of biome, the OmniGlow can be fitted within half a minute. And whenever he needs biome, we can just shift the OmniGlow on the other side and the biome comes into the picture.
Very good. We have compared the OmniGlow and the Lumira Eye in thousand cases, and complication rate in OmniGlow is 0 as compared to 1 complication in 1000 cases in eye. It means it is better than eye also. Really congratulate.
Thank you, sir. Your blessings. Thank you very much, sir.
Jagdeep, can I question a few things about the illumination and the angles of the illumination that you have put in, which is what? You'll need to describe that.
Yes, sir. The illumination angle for the retroillumination is 0 degree to the right eye of the surgeon as well as 0 degree to the left eye of the surgeon.
Okay.
So each eye of the surgeon has a separate light source which is coming exact. So the line of sight and the line of light for the right eye of the surgeon as well as for the left eye of the surgeon is the same. As well as there is an oblique illumination which is coming from the 6 degrees. So now total there are 3 rays.
That's right. That's what I wanted to point out is that you have more than one source of more than one light beam entering the eye, and the source of illumination is.
And the source of illumination is halogen spectrum light emitting diode. It's a very specially made LEDs.
That is part of the OmniGlow. It's not being used as the microscope light, right?
Yes, so when we use OmniGlow, there is no need to switch on the microscope's light.
Then, and the other thing is the recording with the video glow.
Yes, sir.
What level of storage capacity do we have there?
So it depends on what hard drive we put it on our desktop or laptop. So like in my case, I have two hard drives, which is 4 TB each. So in my computer, I have created an 8 GB, 8 terabyte of recording storage. So we can store almost 5,000 surgeries.
So, the video glow itself.
Yes, the video glow itself.
Is just a camera. It's not a recording device. It's not a storage device, is it?
Yes, sir. So Video Glow is a camera as well as a software in the laptop or in desktop.
I'll leave you with a challenge. It is called AI on the edge.
Right, sir.
I'll leave you with just that, and I'll take you and RC on after a year and see where you have reached on AI on the edge.
Sure, sure, sir.
I'm
Thank
not
you.
going to elaborate at all on this.
Thank you very much, sir.
Thank you,
Thank you.
Jagdish. Thank
You have put a seed in our mind and we'll start growing that seed.
Absolutely.
Right. So thank you so much.
So thank you very much, sir. So our next speaker is Dr. Narendra Singh Verma. He'll be talking on LED-based indigenous topographer. So your time is 6 minutes and followed by discussion of 2 minutes. Dr. Narendra.
Okay. I will share my slides. Am I audible and visible?
Yes, sir.
My slides are visible?
Yes, sir.
Okay. Thank you, Jharkhand Ophthalmological Society, for by this presentation. Good morning, all of you. Good morning, Lahane sir, and all the judges. So this is the project I started in COVID time. So we are developing this. This is on the final stage. We are developing a topographer which is based on the LED. So if we see the problems, what are the problems? There was the ASCR survey 2 years before, which showed that the 95% of surgeons, they are agree that the cataract, at the time of cataract surgery, the astigmatism should be corrected. But only 20% of the patient are getting the toric lens. 30% of the surgeon, they think that they are not well trained to implant the toric lens. Many of the surgeons, they are having fear of the PCA, posterior cortical. They are having fear of the PCA, posterior corneal astigmatism. They don't know how to measure or calculate the PCA. If we see about the PCA, predicted PCA and measured PCA. Predicted, we are using the Barrett. We can use both predicted and measured. So predicted PCA by the Barrett is more accurate than measured PCA, which is measured by the IOL-master and Pentacam. It is shown by some studies. Some studies show that when we measure the PCA by different instruments like IOL-master 600, Cassia, and Pentacam, the results are significantly different. So no instrument is giving the perfect result. Some studies show that the measured PCA by IOL-master, so measured PCA and TK, whatever TK is IOL-master is giving us, if we use this value in place of the anterior keratometry, in the against the rule astigmatism, the results are better. So lot of
Voice is breaking.
How to measure the PCA, how to am I correct? The things that can guide me. And I'm audible.
Yes, Dr. Narendra, you are audible.
In
But you are
between-
not visible. Make your video on. Your face is not visible.
Your
Okay.
screen share got disconnected, sir.
Okay.
Sir, your screen is not visible, sir.
Now it is visible.
Yes, yes. Now it's visible.
Your screen is not visible, sir.
Video
Just
is
now
also
loaded,
visible.
sir. Just now it is loaded. Yes, sir.
It's visible. Make it full screen, Dr.
Okay.
Narendra.
Yeah. I made it full screen.
Yes, that's fine.
So the problem is that when we see the cornea is showing some degree of skewing of the axis, steep axis and flat axis, and we are measuring the steep axis of the cornea. And in the toric lens, the steep and flat axis both are perpendicular symmetrical, while in the cornea, the steep axis and flat axis, they are not perpendicular symmetrical. Say there is some skewing. So is there any way that we can measure the best fit toric axis and toric power? So when we measure this best axis and power, which is the best axis, which is perpendicular, best axis, flat axis, and steep axis, which are perpendicular, they show some degree of skewing, they show some degree of variation from the steep axis, 2 to 3 degrees. So the common problem which we faced, which gave us effective surprise in toric lens are, and preoperatively, that when we are measuring the magnitude of we are measuring the magnitude of astigmatism, we should use some good biometer, optical biometer. We should also know the nature of the astigmatism, because these optical biometer, they are measuring they are doing keratometry in less than 3 millimeter of the central zone. So in periphery, there may be some atresia or something else. We should know the basic, what is the status of the cornea for the whether there's dry eye or not. So at least we should measure the non-invasive breakup time. Intraoperatively, if you want to eliminate the error, we should make post-operatively. If there's any method that after 2 hours, I can take the photograph and know where is my lens is lying, at which axis it is lying, and how much it is deviated from the axis of alignment which I was supposed to put the lens. And I want, if there's refractive surprise, I want to know what is the realignment axis. For this, I want eye tracy, or I have to go on the different formulas, Barrett RX or estimatefish.com. So can it be make it for me? And there is refractive surprise. Why it video will work? So the SI is a problem since long.
Now, the next issue that I would like to talk about is surgically induced astigmatism. Well, this is a highly controversial issue, and unfortunately, I'm not going to give you here the right answers. Rather, I want to share with you some of my thoughts and dilemmas. So many of us tend just to use 0.5 diopters for our SIA, just arbitrarily. And the question is
with SIA,
it
the problem is
acceptable?
there. What should be the value of SIA? What is centroid SIA? Still there is problem whether we should use toric lenses, SICS, STRAB, or some. This is debatable. So the SIA and PCA, they are the common problem for the toric lens. So now I will give you this video presentation of my instrument, which is a topographer. Is the video audible?
Yes, the video is visible. You are audible. Your speech,
I will demonstrate this system using the following case. The system is an anterior surface topographer that uses 600 color LEDs, measuring the central 9 to 10
Yes,
millimeters
it
of
is
the
audible,
cornea.
audible.
Here are the results. The raw image shows a white-to-white measurement of 11.66 millimeters and an angle alpha of 0.45 millimeters. The anterior surface keratometry is measured in 3, 5, and 7 millimeter zones. In the 3 mm zone, there is a 1.1 diopter cylinder at 172 degrees. The steep axis shows no skewing of steep axis, indicating regular astigmatism and can be confirmed by the axial heat map. This is the manual image-guided module. The system automatically marks the steep axis at 172 degrees. In this topography image, identify 2 prominent limb ball structures and mark them as landmarks. On the right side, I have marked a pigmented spot at 179 degrees. On the left side, a whitish pigmented structure is marked at 23 degrees. These 2 landmarks serve as reference points. This method reduces errors from head tilt and cyclotorsion. If the patient moves their head during topography, the distance between the landmark points and the steep axis remains constant, unaffected by head movement or cyclotorsion when the patient is lying down. I will enter the data into the Barrett toric calculator to determine the axis of alignment, which is 176 degrees. Consequently, I will change axis of alignment from 170 to 176 degrees and save this image on a tablet, laptop, or mobile device. This image is displayed in the operating theater on the tablet or mobile device. The surgeon can easily identify the pigmented structure at 179 degrees on the nasal side and the white patch at 23 degrees on the temporal side, and will manually mark these points on the patient's eye. Mark 179 degrees and 23 degrees on the degree gauge. Align these marks with the corneal markings and mark the axis of alignment at 176 degrees. Postoperative day 3, the axis of the toric lens observed on the slit lamp is at 170 degrees, as confirmed by the retroillumination picture. The intended axis of alignment was 176 degrees, indicating a 6-degree misalignment of toric lens.
Now we are
Thank you for your
developing this
attention.
like image guided system. Our system is we have put this camera on the microscope. It can be fitted on any microscope. It will take the picture and it will measure the blood vessels from the topography picture, and it will put the data and it will provide you the line on the smart TV in front of you. The surgeon can see the line on which he has to implant the toric lens. So this is under development. So you will not able to see in the eyepiece the axis of alignment, but in front of on the TV you will able to see the axis of alignment. Then this is retroillumination mode. So we are developing this also. After 2 hours from the surgery, you can take a picture. It will also identify the blood vessel and will tell you at which axis the toric lens is lying. So then you can find out after 2 hours whether it is at the proper place or it is rotated. And this is our tear film breakup time. So when cornea will become dry, these wires they will distort, and we can tell you that in how much second first dry spot appears. And this is our infrared. So by infrared, we are measuring the P2, the reflection from the posterior surface of the cornea. So by measuring P1 and P2, we will able to find out the total corneal power based on the physiological reflection base, not on by the morphology like by JHOS OCT or synflux imaging. And the last is that we are putting the formulas. So when you will enter the data, it will tell you how much will be the realignment axis, which is better than the astigmatism fixed.com and nearly same that of the Barrett RX formula. In the extreme of eye, when the eye is very long or very small, the astigmatism fixed.com give very error in the realignment axis because they are based on the fixed IOL power, and Barrett RX is based on the ELP, effective lens power of the lens. So our realignment axis will be as that of the astigmatism and you have to enter less data as that of Barrett, and easy to use. It will be available on mobile also. And so this is all about my presentation. Thank you.
For all these speakers, let me tell you that there are marks given to you, and one of the marks is for the presentation and slides and time management. Over to you, judges. Please go ahead. Judges for their questions.
Oh, yes.
Please mention the time also, the session coordinators. Please mention the time because it is not showing on the TV. Please mention the time, whether they have completed it on time or not.
At the end of 5 minutes, maybe you could just ring a bell or something so that they know they have 1 minute left.
Yes, I have told them upstairs.
We will make allowance for the hanging of the PPT during the presentation and make allowance for that, of course. Now, Dr. Narendra, what inspired you to make this Indian innovation, please? Can you elaborate on that? Narendra, are you there? Dr. Narendra? Bharti, can you ensure that he starts sharing his video at least?
Dr. Narendra? I'm calling him.
In the interest of time, can we go on to the next speaker and take Dr. Narendra when he appears later?
Yes.
Dr. Narendra muted actually.
मैं कॉल कर रही हूँ. Dr. Narendra, please unmute yourself.
Yeah.
They are asking questions.
Okay, just.
Because time is less, we have to maintain the time also.
I will rejoin that there is net problem. I will rejoin with a few minutes.
So,
I'm out of my place.
Please take up the another presenter. He will join.
Yeah.
Please
Next move to the let's move to the next presentation.
Yeah, so our next presenter is none other than Dr. Santan Gopal, our past president AIOS. He'll be talking on orthoptic, cellular stimular, and novel therapy in amblyopia. He'll be talking for 6 minutes, followed by 2 minutes of discussion.
I start?
Timer start.
Okay. Shall I share this screen? Okay, just hold on 1 second. I'm going to talk about orthoptic.
Yes.
Just 1 second. I'll share the screen. Just 1 second. I need to look for that particular thing. It's not coming immediately. Stop in immediate defaults. Slideshow. Is seeing now?
No.
Can you see it?
No.
Shared it. Screen
Can
is
you
not
see it?
visible. No, it's not visible.
Not visible, doctor.
सर ये आपका पीपीटी है और ये वीडियो है.
No, it is on PPT on Google slide.
Sir, on the Zoom window, can you press the green button, share?
No, that I did.
It will have a pop-up, then press the blue button, which is share again.
Okay, hold on.
We will be taking Dr. Ramesh Shah after this because he is in Ahmedabad in the live surgery.
Okay. Now, let me just give me 1 minute. I'll keep talking in the meantime about the orthoptic. Orthoptic is an instrument devised by me about 4-5 years ago.
सर इसमें टाइमर सेट कर किया हुआ है तो आप क्या चाहते हैं टाइमर हम लोग ऑन कर लें?
नहीं, I'm trying to share the screen. It's not sharing it.
Sir, can we take Dr. Ramesh Shah in between because he is in live surgery in Ahmedabad?
Yes, ma'am, I think we should skip this for a minute for this one.
Hello?
Ma'am, we should skip the next speaker, then we'll come back to Dr. Santa.
Okay. Dr. Ramesh?
You go to the next speaker, I'll try and figure out sharing and then we'll tell you.
Okay, sir.
So,
Dr. Ramesh,
Be better. Next speaker, I think
Session coordinator, Dr. Rahul Prasad. Please introduce Dr. Ramesh C. Shah from Mumbai.
Yes,
Please show Dr. Ramesh Shah's slide.
hello.
Please show Ramesh Shah's intro slide.
Dr. Ramesh. Can you get the Dr. Ramesh slides, introduction slides, please?
Premlata is there?
Ma'am, we have not yet received sir's introduction slide, but I'd like to invite Dr. Ramesh C. Shah, sir, and sir is going to present on Terikio, new and novel scleral BCL for zero suture, no glue, no recurrent.
Join kariye. Please, we are inviting you. We have skipped. Please join. We are waiting.
Dr. Ramesh sir is muted, ma'am.
Sir, Dr. Ramesh, आप unmute करिए, वो लगाओ. He has joined or not? So बताइए.
He's joined, ma'am. He's joined. He's sharing the screen. He is muted though. Dr. Ramesh, can you unmute yourself, sir? Can the co-host or host unmute Dr. Ramesh? I think he was trying to speak.
तो बढ़िया है. रमेश सा.
So, sir, kindly start slides. You have 6 minutes for your presentation and 2 minutes for discussion, sir. So we are unable to hear you right now.
Please unmute.
Kindly unmute yourself, sir. So kindly unmute yourself. We are not getting any audio from your side.
Dr. Shah, unmute करिए खुद को.
Dr. Shah, we are unable to hear you. Can you just check your microphone, please?
I think someone needs to call him on his phone.
I am calling him, but he is not picking up.
Now, just now I spoke to him. He is unmuting himself.
So he is unmuted. इनका audio नहीं चालू हो रहा है. इनका audio connected नहीं है. Dr. Ramesh, can you please connect your audio, please? Can somebody please
start करें ना, फिर से कर देते हैं.
इनका audio connected नहीं है, ma'am. Dr. Ramesh needs to connect his audio on the bottom.
मैं क्या कॉल कर रही हूँ, is not receiving. आपने अपना ऑडियो कनेक्ट नहीं किया है ना? There is no.
यहाँ पे join audio भी किया है.
अभी आ रहा है. अभी I think he's connecting audio. Yes.
तो आप स्टार्टिंग से करिए. स्टार्टिंग से करिए.
Dr. Ramesh, can you please speak?
Restart your presentation, sir.
Restart your presentation, sir.
Restart your presentation once again.
Dr. Ramesh, one small request. When you share, bottom there will be a icon called share sound, share computer sound. Just check that in case the video, we are still not able to hear Dr. Ramesh.
Ma'am, Bharti ma'am, can I present on his behalf? His video is in my computer here in USA.
Dr. Jagdeep,
please present. Sir,
So,
judges. Sir,
please.
judges. Can you allow, please?
What will happen is Jagdeep will then vie for 2 first prizes.
Sir, not for prizes, but
Dr. Jagdeep, please आप करिए.
Please go ahead, Jagdeep. We have no issues with you presenting on behalf of Ramesh.
ठीक है. प्रिंट होता है उसके बाद डॉक्टर सुनील
We can see Dr. R.C. Shah there. R.C., can you hear us? If you can, just raise your finger.
So Dr. Jagdeep has taken up the responsibility to present his presentation. Dr. Ramesh is unable to present. So Dr. Jagdeep sir is presenting on it. Yeah, it is.
Dr. Jagdeep, one small request. Dr. Jagdeep,
Yes, sir.
can you please pause the presentation for a minute?
Yes, I paused.
On the floating bar, there are 3 dots. Just click on that. The Zoom floating bar, you will have a share sound option. Just check that. The sound will start coming. Alternatively, I'm stopping this for a minute. Can you just share the button once, Dr. Jagdeep?
Yeah.
Just press the share button once. Bottom, there will be an option called a share sound. Just check that box. सर साउंड एक बार चला के देख लीजिए साउंड नहीं आ रहा है हमारे को Can you please place, doctor?
Yes. Now, hello, dear friends and colleagues. Today we are very happy to introduce to you a novel and is the sound coming now?
Yes. Yes, perfect.
Innovative way of doing perfect pterygium surgery with zero recurrence and zero complications. Without using any glue, stitches, plasma or autologous blood. Using a specially designed large soft scleral bandage contact lens which we have fondly named Terrigo. We have no financial interest. Terrigo is a 21 mm diameter large soft lens made from high water hydrogel material impregnated with nanosilver ions. Please notice the difference between corneal bandage lens and the Terrigo, the scleral bandage lens. This is how the lens is made available in a wide mouth glass bottle which is sterilized by autoclaving at manufacturing. So the inner contents are already sterile. It is made by Silverline Laboratories, New Delhi, India. Up to the step of dissection of autologous conjunctival graft with limbal stem cells is same as our routine surgery, and then using a colibri and McPherson suture tying forceps, the flap is inverted so that the epithelial surface is now facing skywards or upwards or the frontwards, and the flap is brought and set into its sit or pit, always keeping the donor site limbus oriented to the recipient site limbus. And with McPherson forceps, a sort of multi-point acupressure therapy is given to the flap to make it to stick to scleral bed. After patiently waiting for more than a full minute for the surface to dry up and the natural thrombin and fibrin to form good adhesion, we now spray the cornea with BSS, preferably with 1/4 diluted moxifloxacin, to check for the reasonably good adhesion of the flap. This water jet test confirms that the flap is well stuck. If we had not waited enough, the flap may not have stuck well. It will fold or move in the water jet test like this. In such case, repose it and repeat the acupressure and wait for a little more time to dry and re-stick the flap. Now, with a wet cotton tip swab, we take out the Terrigo BCL from its bottle, which is then invertedly sprayed over the cornea and graft flap. It is like spreading a king-size big bed sheet, so we will need at least 3 or 4 hands to spread it. So the scrubbed assistant has to help the surgeon in this step. At this stage, if some air gets trapped under the Terrigo lens, Please don't worry, just a mild pressure with cotton pad will remove most of the air. And remaining few bubbles will get burped out from 12 o'clock position when the patient sits up. Now we put moxifloxacin drops over the BCL, and please notice that the graft margins, if has moved, can be nudged even through the BCL. BCL becomes more visible in the UV light because it absorbs and reflects UV rays, and then the speculum is gently removed, always under the direct and microscopic vision of the surgeon, so that we make sure that during speculum removal either the lens or the graft hasn't moved from in situ position. Please remove the drapes also under microscopic vision of the surgeon, just making sure that the graft and the BCL both are undisturbed and are in situ. If the surgery was under peribulbar, the leads are then taped and patched for 6 to 12 hours. In topical surgery, we can keep the eyes open right away because pterygo is there to protect the graft. This is the second day, 24 hours post-operative, and as we can see, the graft has already well healed and the lens is also in situ. Fine. This is 1 week post-op, and on slit lamp under proparacaine topical anesthesia, we gently remove the BCL with McPherson forceps, and as we can see, the graft is already well taken up and has healed so well. The pterygo BCL covers all the three sites, donor area, graft, as well as corneal epithelial defect, so there is almost no pain or foreign body sensation, and all three sites heal much faster under the shielded protection of the pterygo, and the surgery also becomes faster, usually taking only 5 to 10 minutes. In over 500 cases done so far in last 18 months by over 20 surgeons, no graft loss, no graft displacement, no chemosis or no infection. In the near future, pterygo will be with a central hole for easier insertion and for burping out the trapped air. We fondly call this as cut, paste and cover or cut, paste and shield surgery for pterygium. Pterygo lens is also very much useful in almost 15 other indications. Please scan these QR codes to see full-length videos about pterygo surgery and its 15 other indications. Pterygo BCL is available from Mr. Vikram Panchal. Thank you very much for your kind attention. Hello dear friends and colleagues.
Thank you, sir. Thank you for such a nice innovation. There remains certain questions when they say that pterygium without glue, without stitch, without PCL, and our judges will take over. Sir, judges, sir, please go ahead.
Hello, this is Dr. Agarwal here. Any special consideration for the graft sizing and the host, the disparity, or you would take a larger graft in these cases?
No, sir. The surgery remains as same. Only the main advantage of the pterygo lens is that we don't need to take sutures. We don't need autologous blood. We don't need fibrin glue. And because the pterygo lens protects all the three sites, the donor area, the corneal defect, as well as the graft, under the pterygo, within 2.5 days, the epithelialization takes place. So, and the comfort level for the patient is excellent, and it has it is impregnated with nanosilver ions, which in itself is a healing promoter, and which in itself is an antibacterial and anti-fungal. So, and the material is containing 80% water, and the decay value is 140. So this can be kept continuously for up to 4 to 6 months. And we have been using, Dr. Mesha and myself, we have been using this for so many of our keratoconus patients. And when we put this lens on, the astigmatism of the keratoconus patient gets corrected. And then the patient needs to wear only the spherical equivalent, I mean, only the residual spherical power. And now, after putting this lens, we take out what is the best acceptance of the spherical power. And then we make the pterygo lens for these keratoconus patients with power so that they get 6.9 or 6.6 very high quality vision, just having this lens inside the eye. And it needs to be changed only after 4 months or 5 months.
This is fantastic. Because
Dr. Kakaria, can you tell me how much it costs?
It said the MRP is 3,000, but
Okay.
1 plus 1 is given free. So effective price for the hospital is 1,500.
1,500. Okay, thank you.
1,500.
So, so in cases of trans PRK with C3R, when we do in keratoconus, trans PRK and then C3R, so if we apply these lenses, is there any chance of overcorrection? Because in trans PRK with when we do for the keratoconus patients, we take 2/3 of cylinder and half of the spherical. 50 micron ablation we do. So if we apply this pterygo lens after doing C3R also in keratoconus patient, trans PRK and C3R, then is there any chance of overcorrection, Dr. Kakaria?
No, the lens will not do any overcorrection. What it does is it has about 40 to 50 microns film, tear film between the cornea and the lens. So that takes care of all irregular astigmatism. It's not only for keratoconus, ma'am. Even for spheroidal corneal degeneration, when we put it, all the spheroids are within that 50 micron of water pool. It can be used for keratoplasties. We have been using this now even for the radial keratotomy, post-RK hyperopic shift, where we put this pterygo and the central flattening is taken care of by this lens. So anywhere, it's basically irregular astigmatism buster. So whenever there is an irregular astigmatism, we can use this lens. Okay. And it can be made not only plano, it can be made for powered also. So first
after
we
how
put
many days use we can assess the spherical power? 10 days or when we should?
No, next day.
Okay.
Next day.
Dr. Kakaria, will you please share the phone number of the person who is?
I think that can be sent to you later on.
Okay,
Because
sure.
Abhi, there is a competition. It's a competitive session, and we cannot have financial.
Can we just?
Have no financial interest. But this is very nice.
I just declare we don't have any financial interest.
Correct.
Just for the availability at the end of the session, I will share the number.
Okay.
Yes,
Okay.
thank you.
Whenever you permit, I'll share the number.
Sure,
Okay.
sure.
Or I'll share the number in the comments.
Okay. Now we are getting very much delayed. So please over to Dr. Santan Gopal.
Please, Bharti, I have a technical question here. Something that's quite relevant here because you said that there is a Dr. Santan, can you just hold on, please?
Yeah, sure.
Thank you. You said that this has been impregnated with nanoparticles. Now, what exactly is the difference in the manufacturing process here? Why did you select an Indian lab for that?
I'm sorry, sir. No, it's when the contact lens button is being manufactured, the liquid polymers are having a micronized nanosilver ions added to it. And nanosilver in itself is an excellent healing promoter, as well as it is an excellent antibacterial and antifungal.
So is this a technology that can be used for other soft lenses also?
Yes, sir, it can be. It can definitely be used for other soft lenses.
May I take up this question?
Can I just continue this question?
Dr. Moria is an authority on the nanosilver ion as preservative.
Yes, Dr. Moria.
Sir, good morning. So this nanosilver ion, we did the phase 1, phase 2, and phase 3 clinical trial. I'm associated with this Mankind. Lubimoist is available. So even the Pseudomonas, the fungus, the dreaded of all, they vanished within few hours. So we had done all the stringent laboratory tests. So these nanosilver ions, because previously, if you remember, in our older days, we used to eat in the silver this utensils. So this is the advantage of this nanosilver ions. So yes, of course, these BCL and whatever that can be impregnated. And if not, we can use these eye drops, which are using nanosilver ions as a preservative.
Thank you. Dr. Maurya, I have one more issue here. Dr. R.C. Shah has called me up and he'd like to add something to the presentation here. R.C., please go ahead.
Hello?
Unmute, RC, unmute yourself, please.
No,
please unmute.
किसको करना है अभी? संतन गोपाल सर को करना है, किसको करना है अभी?
Dr. R.C. Shah is talking through my phone.
Okay.
Okay, sorry.
I have done about 7 patients with RK and Terracotta sport. And the results are so good. Most of the patients have reduced vision from 636 to 69 with correction. And the longest period with the lens resting line in the eye is 6 months. He will not remove the lens for last 6 months. And now they are getting...
It is inaudible. Please raise your volume.
Hello?
Okay, what Dr. R.C. Shah is saying is that he has done a lot of keratoconus work on this also, and the results are very, very good and encouraging. Thank you, Dr. Bharti. Dr. Jagdeep, thank you for taking over for RC. Dr. Santan, please continue.
Yeah, the slides are with the admin. They can project it. I'll talk. The slides are with the admin. Hello? Can you hear me?
Admin, please share.
Sir, your slides are not visible. Sir, your slides are not visible.
No, that's with Bharti. Dr. Bharti must have the slides with her. I have sent, there, the third one. Yes. These slides. Can you see the slides now? Dr. Bharti, can you?
Yes, we can see.
Not yet.
Not yet. I normally use Google for this, but this Zoom is slightly more difficult for me to use. It's slightly different.
Open the presentation, please. Just double click what you have selected.
सर कर रहे हैं. Can you see the slide? Slide नहीं दिख रहा है.
No.
We are not able to see the slide because, of course, the part of the computer is being seen. It says that there are two contents, but then the slides are not there.
I have sent all the slides to them. They can directly project from there rather than from here because there seems to be some issue here, technical issue with the computer here. That's why I sent the slides. Can the admin open the slides and project it?
Yeah.
There we go. Now you got the slides.
अभी दिख रहा है. We are
दिख रहा है.
projecting. Okay, so we are doing it from our side. So now please start the timer.
Yeah.
Session coordinators, please start the timers.
Can you start? Okay. Next slide. Can you show the next slide? Go to the next slide. Yeah. See, we have been patching the eye for amblyopia for hundreds of years without actually realizing what is the problem with amblyopia, where is the problem with amblyopia, and what can be done instead of just patching this. Next slide. So I have invented what is called as orthoptic, which is a non-invasive, innovative treatment for amblyopia and related disorders, and it treats the amblyopia and related disorders in a short time of 2 to 6 weeks from age groups from 5 to 55. So it's not necessary that you can tell amblyopic patients who are older than 15, oh, nothing can be done. You have arrived late, very late to us. so you can go home and stay with the only one eye. So next slide, please. We have used this instrument for treating. Next slide. Can I move the slide? We have used this instrument to treat a number of conditions like anisometropic amblyopia, strabismic amblyopia, nystagmus of different types, fourth and sixth nerve palsies, dissociated vertical deviation, cerebral palsy, attention deficit disorders, and in all these patients, in from 2 to 6 weeks, it cures the amblyopia in 90 to 95% of the cases. But some cases they may need bit of surgery. Some cases may not need surgery. Next slide. Go to the next slide. So some have reported improvements in cases of optic atrophy and macular dystrophy. And Dr. Arvind, who is there, is an important user of orthopedic treatment for a number of conditions. And it's successful in a short time of 2 to 4 weeks, unlike patching, which goes on for years with no tangible benefits to the patients or the parents. Next slide, please. So the reason why orthopedic, go to the next slide. Next slide. Yeah, the reason you must understand that the different parts of the retina go to different parts of the brain. The peripheral retina goes to superoparietal cortex, and the central retina, that is particularly the fovea and parafovea, goes to the inferotemporal cortex for analysis. See, occipital cortex on its own cannot analyze anything. It is like Manmohan Singh. It just passes on the file to the higher authorities for management. And it just sits there not doing anything but takes the name as visual center. But it's not actually the visual center. The visual center is inferotemporal cortex and supraparietal cortex. Next slide, please. Move the slide. This is a very complicated pathway in the brain, which explains why orthoptic works so rapidly. Actually, the orthoptic works rapidly by release of nitric oxide in the brain, just like Viagra does. So I call it as ophthalmic Viagra because of the release of nitric oxide in the brain. That's why it also causes headaches during the early few days of use of this. Next slide, please. The problem in amblyopia is here. It's in the synapse in 4C beta in the occipital cortex, where the release of glutamate is obstructed or reduced, or the glutamate is absorbed so that it is not available for stimulation of the postsynaptic membrane, and therefore the vision does not improve in amblyopia. So by patching the normal eye, you are not doing anything to increase the amount of glutamate release in the brain. Whereas with orthoptech, we are increasing the amount of release of glutamate from the synapse, and also we are increasing the release of nitric oxide in the brain, which acts instead of glutamate, and therefore it works rapidly. Next slide, please. See, the primary problem, even though it is with the eye, in the brain problem is to start with primarily in V1, but then it affects all the areas of the brain in amblyopia. And just by patching the normal eye, you don't expect all these areas to improve automatically. It does not happen like that. Whereas orthoptech does that by improving the input from the peripheral retina into the central retina, and therefore the vision improves rapidly. Next slide, please. If you want, you can copy this slide. This is just to show that it's a child's play. Using the orthoptic is a child's play. Even a small child can recognize how to use it and can use it on its own after first exercise. These children do the exercise on their own. Next slide. Nobody has to supervise them. So orthoptic works due to a sequential stimulation of both P cell and M cell pathway, and this in turn stimulates the attention area and the parietal lobe, which in turn stimulates the 4C beta in V1, which only acts as the image forwarding center to the inferior temporal cortex. And this is what is blocked in amblyopia, and the top-down impulses stimulate the inferotemporal cortex release of information from occipital cortex to the inferotemporal cortex, and therefore the vision improves because the blockage is at the synapse of 4C beta, and therefore the inferotemporal cortex is not receiving the information. but the orthoptech facilitates the transfer of impulses across the blocked synapse, and therefore the vision improves rapidly. Next slide, please. This is my last slide. You can copy this QR code. It will give you all the details as to why orthoptech works so rapidly. And recently I found out that there is an increased release of nitric oxide in the nitric oxide, NO, in the brain by top-down impulses. And this nitric oxide is released from the arginine, which is present in the neuronal cytoplasm. And the release of nitric oxide acts as glutamate, and therefore the vision improves rapidly. Thank you. That should end the slide.
Chantan, can you take a question or two if you don't mind?
And I would like to know that, there are a lot of things involved into this. Number one, what is the present status? What should the present status of the vision so that the patient starts this treatment, whether it's up to 6/24 or PL present, PR present? What should be the status? Number one. And the number two is, what are the prerequisites? What are the requirements for the patient to start the treatment? He has to have a computer. He has to have a lot of things attached to it which does
No,
not.
no, he doesn't need anything. He just needs a laser pointer with which he points out the light which come on. Because the hand area is close to the frontal eye field area, the frontal eye field area stimulates the occipital cortex back via top-down impulses. So it's a very complicated neuronal pathway which which is responsible for this improvement of vision. But then it does improve in 2 to 6 weeks, depending on the age group. Younger patients and depending on the diagnosis.
And then can I ask questions to you, sir?
Good morning, sir. This is Dr. Shushruth. So I
Yeah.
just wanted to know how this orthoptech is different from the software that is already present in the market for the
No, no,
vision correction.
this is not a software. This actually patient has to sit in front of the machine and do the exercise. It
Is
works
there
on the
a special,
principle of
is there a special machine for that?
sorry?
So is there a special machine for that? We need to have a
Yes,
special machine.
yes.
Okay,
That
sir.
machine I showed you on the second slide, which the child was using that is a machine which is fixed onto the wall, and the patient sit in front of the machine, and first time he points out the lights which come out, and in the second program he counts the number of lights, red light particularly. I've changed the program in such a way that red light is in the periphery and green light is in the center for a specific physiological reason. I will not go into the details. I need one whole day to explain all these things.
Chantan, can I ask you one thing?
Yeah.
The stimulus that you are giving is with a fixed spot of light.
Yeah, 9 spots of light.
Yes, yes. Now, if you recall the Hedinger brushes,
No, no, Hedinger, this has got nothing to do with Hedinger pressures because,
listen to
no,
me.
no, let me tell you.
I have not finished the question.
Yeah.
Listen to me, then give me the answer. What I'm trying to tell you is that if the stimulus, instead of being a non-moving simple spot, if it could be a small revolving spot, maybe in color, would it make a difference? That is the question.
No, no, that would not make a difference because the Hedinger brushes are mainly centrally located.
Yes.
Mainly. But the problem in amblyopia is in the occipital cortex, level 4C beta. And whatever you amount of afferent impulses you send, they get blocked in 4C beta. But the magnocellular cells end in layer 4C alpha, which is different from 4C beta where the suppression is. Via 4C alpha, it comes back into 4C beta again.
Okay.
And also it go to the postsynaptic membrane. Because the top-down impulses not only stimulate before the synapse, but they also stimulate after the synapse by release of nitric oxide. This works. This obviously removes the blockage in the synapse.
Now,
The basic
second
problem is in the
question.
synapse of
I
4C
followed
beta.
what you're saying is you're using the alternate pathway to stimulate.
It's an alternative pathway which
Yes,
is normally present.
I followed that. Now, the second question here is a very, very, very relevant question for school age children. You mentioned attention deficit disorder.
Yes, very correct.
Can you now please go further into this so that you can pick it up in school and have these corrective measures available in the schools itself?
Yes.
This is a suggestion that I'm making to you.
It is possible. The attention deficit disorder is a serious problem in children who do not perform well in the classes.
Absolutely.
And therefore, we can sell it to the school. If they want to buy, I don't mind selling it.
No. It's not the selling part.
Huh.
It's starting a movement to educate the pediatricians and also the pediatric
Yes, very correct.
ophthalmology.
But as of now,
Yes,
pediatric
I'm
ophthalmologists
giving
themselves
you.
are they don't know much of brain, and they are refusing to use my instrument except a few of pediatric ophthalmologists who are convinced, and they are using it, including Dr. Arvind Kumar, who is using it, and he will vouch for it.
May I take up this question, sir?
Yeah.
Arvind, yes, please go ahead.
So that is a great pertinent question. So here we are working with the overt and the covert attention, to be very brief. Right, sir. So if a person is moving and we are able to follow it, so that is the thing. And the very pertinent question you pointed out, if we are fixating the fovea only, central. So both the overt and the covert attention, we are working on it using the frontal visual field area, and it is going into the V1 area. So that is top to down impulses. Yes. Now coming to the Ministry of India, we are in negotiation. So they are very much willing to make it necessary in the school. So let's see, and let's because it's already in the technical part. So if that is there, sir, then we will take permission of Santhan sir, and it will be taken forward.
Thank you, Dr. Maurya. That's a very encouraging thing. Thank you, Santhan. Thank you.
Thank you.
Good presentation and a very good innovation.
Thank you.
So our next speaker is Dr. Maurya. He'll be talking on all-in-one AI-based smartphone annotating and referral app for 15 common retinal disorders.
Thank you so very much, JOSCON, the scientific committee, especially Bharti ma'am, and everyone. Good morning, respected judges. So is my slide visible?
Yes.
Yeah.
Hello, everyone. Myself, and I will be speaking on smartphone.
Yes, audible. Arvind.
Yes, please go on.
Artificial intelligence in 15 common retinal disorders. There are AI algorithms which can predict patient survival in 85% of cases based on data obtained by measuring the heart's electrical activity. The rapid development in AI technology requires ophthalmologists and computer scientists to have a good mutual understanding of the technology and the clinical practice to improve ophthalmological care. So, we did a world's first AI smartphone-based multicentric study for annotation and screening app development for 15 common retinal disorders at 15 retinal centers in India with 50 retinal specialists, IIT engineers, and optometrists. We initially begin by asking doctors to annotate the images using online platforms, but faced some of the following issues. Volume of the data increased over time and less portability because of desktop sites. Long images loading time due to weak internet connections, ever-changing disease schema, and as we kept on receiving some new data from hospitals we could not upload to these tools as it may violate patient data privacy laws. This led us to develop our own in-house image annotation tool. As seen in the video, adding in annotations for an image is pretty easy. View the image, magnify and change the brightness, change the contrast as needed. Click on the relevant option, choose the extra details, and the annotation is saved. The analytics on the landing page shows the pending and completed images. The graph shows the maximum number of images stacked by the other users in real time, and gave the daily target settings. These imaging data sets are generally in the range of thousands and can be overwhelming for a single person. So we chunked them into sets, each containing 1,000 images or less, which a grader can complete in 2 weeks. The issues mentioned earlier were resolved as follows. For faster image loading, we resized images into smaller size thumbnails with smaller memory footprint and still maintaining the visual quality. We leveraged the asynchronous capabilities of the browser and didn't load just one but 3 images preemptively so that the grader doesn't need to wait for the next image to load. The initial interface was basic and evolved based on the grader feedback. It is now designed on a decision tree structure to render the nested sub-classification and extra options. Finally, on the developer's end, we managed to Dockerise the entire application and deploy it using the Kubernetes platform. To ensure the highest standards of data security and privacy, our application is designed with Docker and Kubernetes, which reinforce our commitment to safeguarding patient data. All patient information is identified before it enters our system, aligning with the stringent regulations of General Data Protection Regulation and Health Insurance Portability and Accountability Act. We utilize robust, encrypted cloud storage to further protect this data. We have seen a total behavioral change where on the online tools the grader used to work only on the weekends, but on our tool we have a logged usage on all days of the week. Average time taken to label a single image reduced substantially. We validated the AI algorithm developed using annotations on this tool on some new testing data sets and found them to have really high performance scores. This strengthens our hypothesis that this tool is no different than the desktop-based tools and with added benefits of being portable and flexible. On the basis of satisfactory levels of verifications and validations, we are developing a smartphone-based app on a binary system of referable or non-referable decision for the retinal disease. In our pursuits to bring advanced eye care to the most remote and geographically challenged areas, we have developed an AI-equipped offline handheld non-mydriatic fundus camera. This device, along with a smartphone attachment for slit lamps, is designed to be the most cost-effective solution for diagnosis, screening, and referral purposes. As part of the Government of India's Netrayantiyodaya project, our handheld retinal scanner and digital slit lamp system are set to revolutionize eye care by making it more accessible and affordable for everyone. On this unique convolutional neural network-based algorithm on feeding a retinal image, it undergoes multi-level screening to provide a diagnosis in less than a minute to decide whether referral is required or not. Our system further enhances diagnostic precision by addressing 15 common retinal disorders. Each disorder is carefully analyzed by our AI algorithms to provide accurate and timely assessments. Also, we've implemented a sophisticated color coding system specifically for glaucoma detection. This system uses a visual spectrum where green indicates a healthy optic disc, while red signals a potential abnormality, enabling rapid and intuitive referral interpretation by healthcare providers. We wish to introduce more gamification label optimization to be used in telemedicine. With some minor tweaks, this tool can be easily adapted to work for other domains as well, such as anterior segment telemedicine, radiology, dermatology, etc. Our initial study got published in Clinical Ophthalmology and got awarded and recognized at 12 various international and national podium by the best in the field of ophthalmology. Conclusion: in our efforts in developing the AI smartphone-based screening tool, we are ensuring that critical eye care reaches even the most remote areas, improving outcomes for countless individuals. We remain committed to innovation and excellence, continually enhancing our tools to serve a broader range of ophthalmological needs. Thank you.
Yeah, thank you, Dr. Maurya.
Thank you so very much, sir.
But could you please summarize in 15 seconds about the gist of the thing, because it looks so complicated.
Yes, when we started, so we were a team of 50, means 32 were the VR specialists, and I was heading them, and then there were optometrists involved, and then there were IIT engineers involved, and then we need sponsors also. So the Ministry of Information and Technology, they came up and they help us. So right now, sir, all these, if we talk about all these apps, they are online. And Minister sir specifically told me that, Arvind, we need a non-mydriatic offline technology to identify all these disease, especially in the remotest of the area. So that's why we named it Antyodaya. So means it needs to be to reach for the unreachable. That's why the name is Antyodaya. So 15 common retinal disorders, including glaucoma.
Over to the judges, yeah. Please answer that. Over to the judges, please.
Yes, sir.
So this equipment is mounted where? I couldn't get that because the voice was not very clear.
So we have already developed a prototype, and it's under clinical trial. Very soon the results will be out. So this Remedio is there that is costing 4.5 lakh. And it's very difficult because it moves all the time. So we had mounted like a slit lamp.
Ah,
If I,
it's
so it gives stability, and it costs only 1.25 lakh. And it is using the offline as technology, AI based, for screening and diagnostic these common retinal disorders, including ROP.
You have a slit lamp based fundus examination with AI algorithm, which is uh, then helping you to screen people.
Yeah.
Right? And
absolutely,
with the screening, then the referral to the relevant centers can happen.
Yes, sir, of course.
It is basically something to be used at the peripheral hospital level or clinic level, wherein the load to the central level can be reduced and more accurate treatment can be provided to the people at the periphery who have less access to eye health care. Am I right?
Absolutely, sir. Even the optometrist and nursing officer we are training, and they are using it perfectly. We don't require ophthalmologists.
That's because it's a screening tool.
Yeah.
It's not a diagnostic tool, it's a screening tool. Am I right?
It's diagnose also that whether there is.
That would be subject to verification by the eye surgeon at a different center.
Yes, it can be used in telemedicine.
Yeah. Thank you. Thank you. Arvind, that was a lovely innovation. The only issue was that on the PPT, the voice was a little distant. So maybe next time you talk about this now, with the slides, you could use your own voice
Sure, sir.
rather than use the PPT voice. This is just a pointer for a future presentation.
No problem, sir.
It's a
It will be
lovely
taken care.
innovation.
If I weren't told, I would have used my voice only.
It's okay. It's okay. I'm so proud that we're getting so many innovations in India. Dr. Lahane, sir, would you like to say something? You'll have to unmute.
I think I have seen this instrument. It is good and really very good for the screening in the camps. I have used in the camps in I think 3-4 camps, and Arvind, it is working very well. Only the base you are making, that will be more useful because today it is costly. It is a 4.5 lakhs, and if it comes to 1.5, that will be better for the.
Yes, sir. It costs is 1.25 lakh.
And as Maniar said, next time you are more clear than what he spoke. So better.
Sure.
Yes, the Indian voice is always better. But I appreciate and congratulate you.
Thank you, sir.
So our next speaker is Dr.
Kashyap. Dr. Kashyap, can I just interrupt? We had a little interruption for Dr. Narendra, and we were not able to give him some question time. Is he on? Because he was not able to take questions, if you remember.
Yeah, yes, sir, yes, sir, yes, sir.
So just after the next speaker, just make sure that Narendra is available to take questions on
Okay,
it.
sir.
Narendra, can I go ahead with the questions now?
Yeah, sir, yes.
Yeah, Narendra, you
Yeah.
had a topographer, come biometer, come
Analyzer.
T-butt analyzer, and intra and post-op, all in one innovation. My question is, what inspired you? Hello, Narendra, can you hear me? No, you can't hear me. Narendra, can you hear me?
I think he was in a car, probably out of the network.
Go ahead. We'll go ahead. We'll go ahead. Please go ahead.
Yeah.
I'm
So
sorry to interrupt you. I'm sorry.
So our next speaker is Dr. Shivraj Thackeray, and he will be presenting on eye innovative device for unskilled eye lens working. Now, I'd like to introduce Dr. Shivraj Dagre. He has done his fellowship in medical and surgical retina from Department of Retina and Vitreous Services, Arvind Eye Hospital, Pondicherry, between September 22 and September 24. He has done his DNB ophthalmology from Arvind Eye Hospital, Pondicherry, between 2019 and 2022. He did MBBS from St. GS Medical College and KEM Hospital, Mumbai. He has won awards including AIOS LVPI Hackathon Innovation Contest for iVector, AIOS ARC Think Under the Apple Tree Consolation Prize, Moscon Best Paper by Postgraduate and in Community Ophthalmology, and C2 Pondicherry Innovation Contest 22 for Innovation iVector. He is also a part of 28 publication, which includes 3 international publications. I'd like to invite Dr. Shivraj Sagre for presenting his innovation.
Good morning, everyone. Are my slides visible and am I audible?
Yes, you're visible and audible, Dr. Shivraj.
Okay. So good morning, everyone. Today I'll be talking about my innovation, which is called iVerter, which is novel medical tool for comfortable eyelid eversion. Myself, Dr. Shivraj Tagare, along with my team, is going to talk about this product. One second. So, why do we came up with this device? So, as ophthalmologists, we find that a lot of patients come to us with foreign body which goes inside their eye, which may be dust, it may be insect, and sometimes it gets trapped inside that upper eyelid. So, patients are not able to remove it, and it just gets trapped, and it causes a problem. Sometimes when there is chemical injuries and when the chemical gets lodged inside the upper tarsal conjunctiva, we have to do a saline wash. It can be either acid or any laboratory chemical or even firecracker. In such cases, we have to do saline wash for this patient. As there is lack of everting skill in general public, it becomes a very problematic statement for the general population to evert the eyelid when it goes to them. And as eye surgeons, we also find it difficult to evert eyelid in patients with loose skin, patients without eyelashes, children with gloves, when we use gloves and when we use antiseptic or gloves, which becomes slippery. As you can see in this video, when we wear gloves, it becomes very difficult to evert the eyelid in such patients. So we came up with the solution using a simple method, using an ice cream stick. After we eat ice cream, that stick remains. And we made some modification in the stick, put a double-sided duct tape on the edge, and we came up with this innovation. So as you can see in both these videos, as you can see in a child and in this patient having a lax eyelid, you just have to paste the tip of the our instrument over the upper eyelid and just apply a torsional force with your hand. And as you can see, the eyelid gets everted brilliantly. So as this eyelid gets everted and it is very unskilled, it can be done by anyone, not just us as ophthalmologists. It can be done by your nurse. It can be done by the patient's relative, and you can do the procedure with both your hands. So you're basically it's a hand-free procedure. So it's a very unskilled eyelid eversion. It can be done by general population, even for first aid. Like sometimes at middle of the night at 2 o'clock or 3 o'clock, when patient something goes inside their eye and the hospital is far, they can just evert their eyelid and look for the foreign body if it's there. And if it's there, then they can come to ophthalmologist to remove it. It can be done in patients without eyelashes, patients with lax skin, in children who are uncooperative, and procedures like saline wash. As it is a single time use device and which can be disposed after one use, it decreases the spread of infection. And as we are using wooden sticks, it is very environmentally sustainable. So to test out the hypothesis that is a very unskilled eversion, we went to our hospital staff, and as you can see, we just demonstrated them once, and as you can see, these are our office staff which are able to do it very easily. So it's a universal device, that is, it can be used irrespective of their age, irrespective of their gender. It is applicable for all ages. It is highly user friendly, and as such, it can be incorporated as a part of first aid kit in like bandages, basically. Like bandages are used for any wound, and it is used as a first aid. Our instrument can also be used as a first aid when there is a suspected foreign body inside the eye. So we went across and tried another areas where we went to a PHC workup, PHC setup, and we asked their sister to do the eyelid eversion. Similarly, we also asked the mother with her child who came to our clinic, And as you can see, the mother, although like she got a little conscious, and as you can see, she's using two hands, but in her own way, she was able to evert the instrument by herself. So we thought of, if we want to make this product go ahead, we can, pack it with a tooth, an earbud, so that if they want, they can even remove the foreign body trapped inside the eye. And if we want to make it as a surgical instrument, or if as in ophthalmic practice where you don't want to dispose it but just want to reuse it, we can use even stainless steel, and the double-sided duct tape can be changed every time for every patient. So that is with my information. Thank you.
Thank you, Shivraj. One hell of a great invention. You're taking all the skill out of clinical examination.
Thank you, sir. Thank you, sir.
You've mass marketed this, I hope, with a patent. I
Yes,
think
sir.
you should. I think you should, because a lot of eye surgeons have an altruistic motive without commercializing their ideas. I think you should commercialize your idea.
Yes, sir. I will do that. Thank you for the suggestion. Thank you, sir.
Lahane, sir.
No, it is a good innovation, Shivraj.
Thank you, sir.
Now the technique is not required for us. It is very easy to evert the lead, and I think what Ranjit said, I think our Indian innovators are the best innovators. It's very easy to evert upper lead. Really congratulate Shivraj. It is very good.
Thank you, sir. Thank you so much, sir. Thank you, sir.
Very good morning. So our next speaker is Dr. Jan Davis Akara. And let us first introduce him. So he is the glaucoma, cataract and refractive surgeon, Western Eye Hospital, Kochi, and Chaitanya Institute, Kochi, Kerala. And he is known for his innovations. One is the John Dodge foldable fundoscope, which is the ultra portable smartphone fundus camera we will hear today. Another is the designing 3D printed glaucoma drainage device, MIGS and capex surgery instruments. Another is the model of various surgical instruments like CTR, BX, Pecoprobe, and Chopper. And another is the large size model of the eye with cataract to demonstrate the steps of the phacoemulsification. So I invite Dr. John Davis Akara for his talk. So he has two talks. One is on the John Dodge foldable fundoscope, the ultra portable smartphone fundus camera. So Dr. John Akara, please.
Hi, sir. Dr. John is unavailable for another 10-15 minutes. If it's okay to skip him right now, and he'll come back and present it.
Okay, so next will be Dr. Satish D. Seth. So he is available. Dr. Satish Seth.
Hello, sir. Yeah, am I audible?
Yes, Dr.
Hello, am I audible?
Yeah, so first I will introduce Dr. Satish Seth. So he is the Associate Professor at KIMS, Hubli, Karnataka, and he is the recipient of Dr. M.M. Joshi Overall Best Paper Award, POSCON 2011. He is the Best Video Award, POSCON 2012. He is the Best Innovation Award, First World Conference, ISMS ICS 2015. Best Paper Award, Second World Conference of the same ISMS 2017. Second Best Innovation Award, Second World Conference of ISMS ICS. Then Dr. Rohit Sethi, Best Research Award in POSCON 2019 and Best Video Award in ARS Kolkata 2014. So I invite sir for your talk.
Thank you very much, sir, for the kind briefing. I have shared the slides from my end because my laptop had some issues. Can the admins please share my slides there?
Admin, please share his slides that is with you. Admin.
Shed, sir, it would be better if you close your window shield actually. That.
Oh, okay.
Curtains.
Yeah.
Actually, your curtains are you are not visible. The curtains behind you.
Oh yeah. Okay. And now, sorry.
The curtain behind you is reflecting a lot of light.
Yes, sir. I'm getting it. I'm getting it.
And the
I'm getting it.
judges also.
I am moving over to a wall now. Yeah.
Thank you. Better.
Yes. Yes.
We have walled you finally.
Yes.
His wife is not helping him out to close the window.
Is this Dr. John Davis's presentation?
No, sir, Dr. John Davis is not available at the moment.
Okay.
So
Okay,
Dr.
okay. Okay, fine. The next one.
Dr. Bharti madam, is my slide shared?
Yeah.
Yes.
Yes, it is visible.
Yeah, no, it's only my intro slide. My presentation.
We
Yeah.
need that
Intro
presentation.
is already done.
It's already done.
It's already done, ma'am. The introduction is.
Sir, but I'm only seeing my intro slide.
Doing it. Wait.
Yeah.
Yes. It is opening. Wait.
Yes, ma'am.
But sir, time is 6 minutes, showing 12 minutes.
Yes, I know. That was the
Hello, dear friends and
the
colleagues.
prepared slide
Today we are
earlier.
very happy to introduce to
I'll
you
cut short the slides there.
autofocus.
Huh. Please start time. Timer on.
Yes, ma'am. First,
Hello,
let us
dear friends and colleagues. Today we are very happy to introduce to you
available.
Autofocus Pro, a unique and novel ringless polyfocal progressive
Ma'am,
IO.
the slides are not visible.
Vision at all distances, far, near, and intermediate, without haze,
Madam,
shadow,
any
and
issues there?
Dr. Satish, may I play it from my end?
Yes, sir. Sure. Of course.
Okay.
Yes.
But you are saying is 12 minutes. We have only 6 minutes.
Yes,
Ma'am,
madam. I'll be cutting short the video by about 6 minutes only. You can just please play the
So Dr.
PPT from your
Maurya
end.
is playing it, na?
Yeah.
Dr. Maurya is the technological savior, it looks like today.
I will play it from my end.
Go
Yes,
ahead,
sir.
please.
Yes, sir.
Okay, let me share my screen.
Dr. Mora has answer for everything.
Give me I just need to open that video. Just a second.
Arvind is a troubleshooter.
Troubleshooter.
No, we don't need to waste time, no, sir.
Yes.
Already late. Yes, it's open now. Yes. So, yes, I'm sharing my screen. Are you able to see my screen?
Yes, sir. Sir.
Greetings.
Please raise the volume.
Presenting a video titled Optimizing Vision Access.
Admin, please raise the volume.
While eliminating dysphotopsia, glare, halos with good depth of focus.
But this is your slide you are sharing.
Intermediate
Yes.
and near vision.
Yes, it's the same video, sir. We all are involved.
But have you ever seen the IOL that works like polyfocal but actually looks like monofocal? The IOL we are talking about is none other than Autofocus Pro, a make
The same issue here. Can we have the
designed IOL, which is
speaker
cost effective and is
on his own
aspheric,
audio?
ringless.
Dr. Sachin or Dr. Satish?
Yes, sir.
IOL began through Isla Kakadian.
Admin, please raise the volume.
In fact, admin, reduce the volume and let Satish talk.
Sir, the
Yes,
volume
sir.
is controlled at your end.
Moria, sir, can you please mute the sound from your end? Only play the slides. I can talk.
Okay, I'm doing it. Okay.
I can talk.
Yeah.
Respected judges and dear friends, herewith we are presenting world's innovative IOL, which is developed by Dr. Ramesh C. Shah and Dr. Jagdeep Kakadia together. And they were the chief architects of making this IOL. The main motivator was Dr. Ila Kakadia, who happens to be the spouse of Dr. Jagdeep Kakadia. Because she was wearing multifocal contact lenses, she was pursuing it to develop a progressive IOL, and it was shunned by the industry for long. And then Dr. Kakadia sir and Dr. Ramesha sir took up this project and they developed the world's first autofocus progressive polyfocal optic IOL. And that's the motivation from Dr. Ila Kakadia. It is an IOL which excellent DIN vision. That's what we call it as distance, intermediate, and near. By green technology, we call it as gradient refractive index technology, where there is no loss of light energy. There is no diffractive rings, so no photons are lost. The binocular defocus curve of Millioptics Autofocus Pro lens indicates the excellent visual acuity through various lens distances. Over and above, the best corrected visual acuity for far vision, very well balanced vision for intermediate near vision are achieved. The material used are a mix of hydrophilic and hydrophobic, and now we have developed a purely hydrophobic IOL too. We have got some financial interest in this presentation. So we want to disclose that myself, Dr. Kakadia, Dr. Ramesh Shah, and Dr. Vikrant Bale, we do have financial interest in this presentation. There are no double slopes as in other IOLs, and the area of focus, that is the area under the defocus curve, is maximized, which fairly resembles the natural vision as if the vision is seen through a natural crystalline lens. And the accommodation is like that of a teenager. This is the IOL that you are seeing, which is very well placed within the capsular bag without any rotational aspects because of the serrated edges that are provided there. So this is the autofocus progressive technology, what we have developed. It is called DIN. And within 1.5 to 2 millimeter distance, you can have the vision for distance, intermediate, and near all together. This is a schematic optic picture that has been shown. And this is how it appears on a topographer. Even if the pupil has reduced to the size of 0.9 millimeter, still the patient tends to have the distance, intermediate, and near segment all within that 0.9 millimeter. That's the precision by which this IOL has been developed. So this is how the loading of the IOL is done into the cartridge. And it has got two dialing holes, which have to be oriented towards 12 o'clock position because it's a vertically progressive intraocular lens. The dialing holes have to be placed at 12 o'clock position. The IOL can be easily dialed, and once, even if the IOL is rotated by 360 degrees, it will not only help to place the IOL in right position, and it also removes any residual cortical matter that is remaining there within the capsular bag, so that even the PCO can be reduced to a great extent. So on an autorefractometer, sometimes we do get little erratic readings. That is possible because the center of the cornea, which is picked up by the keratometer, can get confused, and we may have little erratic readings. But when the patient reads the Snellen's vision chart, and we have got excellent contrast sensitivity and excellent vision for distance, intermediate, and near, we hardly have any patients who have vision less than n/10. Most of the patients do always have n8 and n6. And if at all, if the patient develops vision less than n10, we do even OCT angiography to find out if there is any macular disorder. So this is the depth of focus curve. So I would recommend all to download this form and do defocus curve for all the multifocal IOLs that are being used by them to assess the type of the IOL that we are using. So the contrast sensitivity is almost equal to that of a monofocal IOL or of a natural human crystalline lens. The only indication that we should have a clear cornea and a healthy macula. The modulation transfer function of IOLs is on par with the best IOLs in the industry. And we can see the patients reading at a reading speed of more than 200 words per minute. So for all the near work that the Indians are used to, it will be helping them a lot for carrying out their activities without wearing any additional glasses. Thank you, one and all. Arvind sir, can you please
having
can you check out the slides?
putting the IL vertically or horizontally? Just give us one question and then over to the judges.
Yeah.
Can I answer this question?
Hello.
Please go ahead, Satish. Please go ahead.
Yes, sir. Yeah. No. Yes, sir. Kakade sir is there for us to talk. Yes. Thank you.
Yes, sir. The IOL's diameter is 6.3 vertically and 7.5 horizontally. So this IOL, once it is placed in the bag and in horizontal position, it covers the complete visual field. So there is no aphakic zone on the temporal side, and the patient will never see the negative dysphotopsia, which usually is caused by the border of the IOL. So that is one major advantage, that not a single patient has ever complained of negative dysphotopsia. And second thing is that when you look at the lens, it looks like monofocal. It's almost impossible for us to differentiate that whether this is a monofocal IOL or a multifocal IOL. But once it is in the eye, and post of second day or third day, if we start refracting, do the fogging refraction, over refraction from +2 to -5, we realize that the vision remains 6.6 or 6.9 for this entire range. So it has an excellent depth of focus, which is ranging from +1 to -4. And the other advantage is that even if we err +1 to -1 on our biometry, still the patient will have 6.6 and 6 vision.
Jagdeep,
Yes, sir.
this is like an progressive lens that we are using in the spectacle. My
Yes,
only
sir.
question is what the size of the pupil you recommend when you are implanting this lens, or if the size of the pupil is small, then is that works?
So all the distance, intermediate and near, all the three zones are in 1 millimeter. So any pupil which is larger than 1 millimeter, this lens works excellently well. And in many patients, we have tried even after putting pilocarpine eye drop, even then the vision remains the same.
Okay.
So
May I add something?
it is pupil independent. Yeah, Dr. Moria sir has done a study of 400 plus of these at AIMS Hyderabad. Moria sir, you can please answer.
Yes, so thank you, judges. So we had done a head-to-head clinical trial with the other multifocals, trifocals, and the enhanced monofocals, EDOFs. So not a single patient has complained of negative dysphotopsia, no halos, no glare. And recently, just 3 weeks prior, I had implanted in my mother's both eyes, and she is having vision of 6/6 part and N5, unaided.
Question here for Satish.
Yes, sir.
Satish, I realized that in 2021 you had operated on one Sanjay Meher and done his contrast post-surgically. The point I'm making is you have to mask the name of the patient and the time and date of surgery in your slide.
Okay, sir.
Go back to your slide.
I really do
Go
not
back
remember
to your
this.
slide,
Yes,
check that out. And never
apologize for that.
never ever reveal a patient's identity on a PPT. That's
Yes.
one. The second question, maybe any of the three can take it, is you mentioned about the contrast. Now, what levels of contrast are achieved? That you have already shown. But the color hue
Yeah.
appreciation, does it change significantly?
Sir, color and hue, just because once we lose the natural lens, the color and hue will be definitely altered. But we
As compared to the other
we have not any
lenses,
study as to what is the change in the hue and saturation that we will be encountering. That it will be only a patient's perspective. But I think it's
yes.
yeah. So since ever since the IOLs have been put into practice, I think some of the lenses which have got yellow tinge, they do have probably some color variations,
And
but otherwise most of the color variations
question
are
is to
almost similar.
Jagdeep and to Maurya sir is has the mobile use increased after the trifocal implantation for your mother and wife respectively?
Yes, now my mother, she can do all mobile work. She is sending me messages.
That is the major gain in this lens is that it is a mobile friendly lens.
Yeah, very good intermediate vision, sir. Very good intermediate vision. And you are talking about the contrast sensitivity. So we are doing a very thorough study. So it is ranging between 1.25 to 1.65.
No, I'm more concerned with the color because I had a patient where the father mother got operated and they had to buy two separate TVs because the color contrast on one for the parents was different and for the kids was different.
For most of our patients, they are not complaining that they are requiring a separate TV. Not till now.
Right.
And my parents, they are both are watching the same TV.
Very small question because you have a lens which has got
None.
usually you
No
have
more questions.
Yes,
Just
yes,
ask them
Kashyap
to-
sir, please ask. Kashyap sir, please ask.
Horizontally, the IOL is optics is a little bigger than the vertically, and then the overall the length of the IOL is much bigger, even in the
No, overall size is only 13 millimeter, just like an average IOL, average PCIOL. Its overall length is 13 millimeter only, sir.
This is a design which was already there by Blumenthal in the Hanita lenses, where he used to do a PMMA with 5x6. This one is, I think, 6x3 by 7 point something, you said.
7.5.
Yeah, 6.3 by 7.5.
Right. So it's just an enlargement of the Hanita lens design used by Blumenthal. That's a
The
good
problem,
innovation.
may I add something, Maniyar sir? So the problem with the modified C-lobe is that the haptic only a few millimeter is touching the capsular fornix. But in our IOL, they said a modified L-shaped and outer serrated edges. So whole of the 6 millimeter is in contact with the capsular fornix, and that is our USP that gives the rotational stability.
Yes, that's a very good innovation.
I have one question. Sorry.
Yes.
Sir, it is shall I interfere? Sir, we call it as zigzag L loop, you know. This particular loop is called zigzag L loop. It has 6 millimeter arc length contact area at the capsule back fornix. So that's why it will have a very high friction. You will have to only manually dial the IOL and it will be having a rock solid rotational stability.
Sir, I have one question. I am Dr. Ajay Gupta from Jamshedpur.
Yes,
Namaskar, Ajay sir.
Yes, sir. Sir, one question. Is there any problem when lens get decentered? Or if lens rotated to just 180 degree away from the desired axis?
Sir, now the axis, since we have not developed any toric lenses so far, up to 30 degrees of rotation which has happened has not caused any problem so far. So anything beyond that, we would always recommend people to dial the IOL back to the 12 o'clock position.
So it's a very pertinent question. So if the axis is so large that even 7.5 and 6.3, this optic design is still decentered. So what we are doing is we are using a WhatsApp nick. So if it is decentered inferiorly, so we are giving the nick in the inferior part. And if it is decentered superiorly, then we are giving a inverted WhatsApp nick in the superior part. And it's working well.
Sir, this is Dr. Pushpit from Jamshedpur.
And even in the cases of say PC rent, the IOLs have been placed in the sulcus and they have also not got decentered.
Sir, this is Dr. Shushruth from Jamshedpur. So just
Yes,
wanted to ask, is all the lenses have to be aligned at 1 o'clock only? Or can it be?
No, it should be at 12 o'clock because it's a vertically progressive IOL. So the near segment will be always there at the lower part. That is the reason that this IOL has to be oriented in that position only where the dialing holes are kept up.
We need to understand this GRIN technology, that is gradient refractive index. So in the superior part, where the holes are, so there the refractive index is 1.42 and it gradually increases inferiorly to 1.54, right? So this gives this polyfocal progressivity to this intraocular lens without any refractive or diffractive zones. So there is no photic phenomena, and there is posterior apodization of the surface also. So means most of the light is entering into the retina. That's why it is crisp and clear vision, MTF values, excellent MTF values, just like a monofocal.
Thank you,
Okay,
Doctor. Thank you,
Maurya,
sir.
since
Maurya sir, there was one question from me, please.
Yes,
I'm
ma'am.
Dr. Rashi Shyam from Ranchi, and in this 400 people that you studied on, were there younger population, young myopes, or
Yes, yes, of
teenagers?
course, of
And it
course.
worked just as well for them also?
Yes, yes, in young patient of plus 10 year, we are implanting and they are very happy.
So the other thing was, suppose
Madam,
intraoperatively, we have a little complication like maybe a zonular dialysis in a 1 or 2 clock hour. Then does the zigzag haptic worsen the situation or not? Should we go ahead or change the plan of IOL
can't work
implantation?
because
Just implant the CTR and then implant the IOL. It works well.
it can't work
Thank you,
because
sir.
the capsular integrity is lost there. The bag, circumference of the bag has been shattered. So the advantage that you have with the zigzag will not be there, but it will still work because it's 13.5 and therefore the bag is normally around 10.5 to 11 millimeters in size. So in that it will work, but the zigzag part will not be operative. Dr. Maurya and Satish, one question here is, have you tried it in iridocyclitis with a surface coating?
Sir, we have 100% hydrophobic preloaded. So in the uveitic patient, I'm using those 100% hydrophobic preloaded. It is not surface coated, it is anti-glistening. So there is no iris deposition post-op. So it's working very well in my post-uveitic patient also, because most of the patients, they are very young female patients. 33 patients I had operated and implanted this IOL, they are very happy. And they are blessing me like anything.
Sir, your mother has blessed you, no? That's more important.
That is.
Is there any more presentation? Is there any left?
So our next presenter is Dr. Prithvi Chandkar. So he is the pioneer 13 plus innovation in ophthalmology. The maximum number of innovation published in the innovation section in IGO for mid-index journal since 2019. So he will be presenting on a smart scope kit, Kruger do-it-yourself ophthalmic imaging device for all. So Dr. Prithvi, please.
Hello, everybody. I'll be sharing my video. Just before that, I want to give a small introduction. What if I tell you that all of our imaging devices that we use in our OPD can be actually replaced by a small alternative, which I have done. So that is what I'm presenting here. I hope the video is seen and.
Hello, everyone.
Can you hear the audio?
To extend my sincere gratitude to JHOS.
It's audible.
In our outpatient department, documenting eye findings is a major hurdle. Imaging is key, but expensive equipment limits access. We need a solution that's affordable, always available, portable, handy, has ample storage, medico-legally reliable. To eliminate these problems, let me introduce all of you to my innovation, the SmartScope Kit. The first component of the kit is smart visual acuity testing using the Eye Handbook app, which helps in vision testing, Amsler grid, color vision, contrast sensitivity, and other parameters. It has an occluder, pinhole, and trial frame with a +10 diopter lens. The investigation component has a blood pressure apparatus, torch, pulse oximeter, syringe, cannula, dilating and topical anesthesia eye drops, forceps, sterile needle, sterile slides, spatula, wipes, hand sanitizer, and sterile gloves. The anterior segment component has a universal eye speculum, ASP, which is made using chart paper with the given measurements and double-sided tape, to which a hole is made using a puncher and intraocular lens of 20 diopters placed between it. This arrangement is then attached to the smartphone and images and video are recorded with the flash on without a slit lamp. These are some of the images taken using the ASPI device without a slit lamp and just with its attachment to the smartphone. These are a few more images of cases with documentation of injury and trauma. We have the SCATS tonometer for measurement of intraocular pressure. We have ASPI-G, which can be used with a 10 diopter intraocular lens, along with a gonio lens to take images of the angle of the anterior chamber without a slit lamp. Then we have IOL scope, which is made using a chart paper to which a hole is created and 430 diopter intraocular lens has been stuck using liquid adhesives. This helps in the imaging of microorganisms without the help of a microscope. Here are images of sheep botfly and fungal hyphae. Then we have the Scooby-Doo, which helps in cobalt blue photography by using ASPI with a cobalt blue filter attached to the flash of the smartphone. Posterior segment component is the trash to treasure red cap, where a hand sanitizer bottle is modified to house the 20 diopter condensing lens at one end and the smartphone at the other. These are the images obtained from the red cam and a few more trauma-related images. These are the full range of frugal equipment in the SmartScope kit. As you can see, there are alternate frugal imaging devices for any of the instruments seen at an ophthalmic outpatient department. These are all do-it-yourself devices which cost not more than 5,000 rupees, excluding the smartphone and the condensing lens. The SmartScope kit is a new age, innovative, effective screening tool for various pathologies ranging from anterior to posterior segment. It is a very efficacious alternative to conventional instruments for ophthalmic examination. It can be used to document trauma cases for academics and in rural outreach programs by ophthalmologists, especially postgraduates and fellows.
So that was the SmartScope kit.
Good.
I would like to say that most of the instruments that we have made is basically a very frugal and do-it-yourself alternative to almost all the imaging devices that we can see in an OPD. So what happens is we can use all these instruments without, it becomes so easy to put anywhere. If you want to go to an outreach program or anywhere, even in your OPD, especially for postgraduates and fellows who cannot afford their own instruments, own imaging devices, this can be made by themselves, do-it-yourself concept, and they can use it for their academics, they can use it for publication, they can use it for conferences, and they can also use it for learning, which is the most important thing. Thank you.
Prithvi, absolutely brilliant. सबका धंधा बंद करा देंगे आप.
Thank you, sir. Thank you so much.
What intrigues me is the JHOS tonometer and the gonio lens. Now, there are a lot of diehards who will swear that the JHOS tonometer is useless and it has lived its life. I beg to differ, of course, but what made you opt for a JHOS tonometer?
Sir, actually, what I'm trying to do here is make a very compact and a frugal kit, which will cater to all the investigations that we can do.
Frugality is one issue, but I'm looking at the accuracy in terms of the pressure readings. And I have for one found that the JHOS tonometer, if well looked after, gives you fairly and better accurate results, especially with 5 and 10 gram weights, also taking rid of the scleral rigidity factors also. So that's a great thing that you've done, and this is compact in terms of everything. Everything is it's a one shop or a two bag kit which you can take with you any which where you want.
Yes, sir.
You
It is
are
actually a small kit. It is just a small kit, almost like this It just comes like a kit like this.
Wow,
You
wow,
put everything
wow,
and
wow.
just take it in.
Now, what have you priced it at, beta?
Actually, it's more of a do-it-yourself concept, but
No,
then
nobody
also,
has the time for that.
yeah.
You
So,
have to market your idea. Please market your idea
so
and
what,
patent the kit. Please patent the idea.
so
That's
what
very important.
actually, I've 3D printed all of these devices, and I've actually used a 3D printing machine and made it into a proper plastic molded type, which can actually be taken by can
What
no.
are you going to price it at? Because I'm thinking of giving this as a gift to every resident.
Yes, sir. Sure, sir. That's I've already spoken to a lot of residents who have bought it from me, and it is such a big education tool and a learning tool.
Price.
Yes, sir.
Maniyar sir, may I add something?
Yes.
So Prithvi, I would request you, as sir suggested, so we are ready to help you without any financial interest. Kindly get it patented. Okay. We have all the resources. We are ready to help you.
Thank you, sir.
God bless you.
Thank you, sir.
Arvind, great offer, Arvind. Thank you. So, Prithvi, give me a ballpark price, back of envelope calculation price. It doesn't matter.
So it would
I see.
anywhere cost below 10,000, sir. It will actually
Excellent. I am going to use this idea in the All India and in the other related societies also. Thank you so much, Arvind. Really superb. Absolutely great.
So,
sir.
interview will be Dr. Jan Davis. Is available? Dr. Jan Davis.
I am here, sir.
Yeah. So you have two presentations. So first you will present the John Doe foldable fundoscope, ultra foldable.
Yes, sir.
Yeah. So please.
Presenting, sir. So I am Dr. John Davis Akara, and is my screen visible, sir?
Yes.
Yes, it is visible.
Okay, so I'm going to present John Doe's foldable fundoscope, which is again a portable frugal device, and this is not just simply portable. This is ultra portable in the sense that it can be folded and put inside your pocket. So let's go ahead and see what it is. So I do have a provisional patent for this invention, and it is in the patent process. Unfortunately, the patent process takes several years. I did not know that when I started getting into it. So it is still in the patent pending state. It is a fundus photography is an essential tool for documentation. It can be used for expert opinion, for screening, and for patient understanding. So you can just show a fundus image of a retinal lesion to a patient in front of you, and they actually have better rapport with you, and they follow your instructions better when they see that. So let's first look at the evolution of fundus photography. It started with very huge machines with very low resolution, and then it went on to slightly smaller machines with tabletop with a very good resolution. Then they started becoming more and more portable machines which you can hold in your hand, but these are still expensive machines. In between all this, smartphones became very good, and then we had a lot of smartphone fundus cameras. I was also involved in this, and here on the right side you can see Dr. Prithvi's trash to treasure red cam, and this is the do-it-yourself red cam, which was by myself and Dr. Biju Raju. This is MI red cam. All these smartphone retinal cameras came into the picture, but still they were portable, but not portable enough to put in your pocket. So then there were some 3D printed fundus cameras. This is myself using an ODOX fundus camera, and this is an ogle scope, and this is a C3 red cam, which was there on Shark Tank, a few months back. My idea is to make it even more portable, because the PGs in the medical college where I was teaching, they were not using the portable smartphone fundus camera which they had. Prithvi's fundus camera was there with us, but they were not using it because they did not want to carry an extra bag. So I made one device which is very foldable, very portable. It fits into your pocket, and it's very convenient to carry. It doesn't add any extra space to whatever the PGs who are on duty going to the wards and ICUs and seeing patients need to carry anything extra. So I designed this during COVID lockdown. I had a lot of free time. I was in the medical college at the time, and I had only COVID duties. OPD was closed. OTs were also, very, very emergency cases only. I learned how to do 3D designing, like Dr. Kakadia sir said. I learned how to do CAD, and I made a 3D model of what I wanted to make. And this is all done on a free software, free CAD. And then I use that design to make a 3D print. I fortunately happened to be in a medical college which had a dental college which had 3D printers. So that is how I made the first prototype. And after that, I made some modifications, and this was the first working prototype. And with this, I was able to take photographs of the retina. So this is how it is done. So the patient's identity is masked with a mask, not just because of patient this thing, confidentiality, also because of COVID. And I was able to take photographs like this directly from the phone. And these are some of the photographs. And on the phone itself, you can do a black circular mask and make the picture, go presentable for, printing or showing to the patient or publication also. So these are some of the pictures taken with that. If you note, you can see the glare from the flash of the camera that is there in all smartphone fundus photographs. And these are some of the other photographs. The lens is a little bad. That's why there are some scratches here. But with a very good lens, you get even better pictures. Whatever type of pictures you get with a smartphone fundus camera, you get with the foldable smartphone fundus camera as well. Here on the left, you see the same eye taken from a desktop fundus camera versus the smartphone fundus camera. There is definitely a loss in quality, but it is good enough for documentation. You may not be able to pick up very minute microaneurysms and stuff, but you can definitely document these. So this is targeted at all cost-conscious ophthalmologists, especially postgraduate residents and those who are starting practice and do not have access to a full-scale commercial fundus camera. And this can be used at bedside, and especially in the ICUs and bedridden patients. There's no other way, and for pediatric patients. And this incidentally also acts as a case for the 20 diopter lens. So if you have your indirect ophthalmoscope, you put your 20 diopter lens inside the foldable fundoscope. It works as a case. You can use it for indirect ophthalmoscopy. You take the case out and move around. You can use it as a fundus camera. This is the patent which I have filed. And thanks to guidance from ophthalmic innovators such as Dr. Suven Bhattacharya, Ashish Sharma, and Dr. Biju Raju. And next, there was a problem of coaxial illumination. So this is how I went to the next model. Newer phones, they have 3-4 cameras. Earlier, it was just single camera, single illumination. It was very easy. So now I had made a new model which has inbuilt illumination also with a battery, so that any phone, any shape, any type of camera can fit into the eyepiece here, and you can take fundus photos with a battery incorporated in the device. And it takes time to attach the phone with the phone adapter. So I made it magnetic docking, which is there in some of the car phone holders. So I put a metal plate into the back of the case of the phone and a magnet into the base of the device, and this automatically attaches the phone very, very quickly. So that is the two problems which I solved. So this is a new design how I made it. Then the software, there are so many existing softwares. The software by Dr. Ashish Sharma for the MIR at CAM is pretty good. I actually use that software for documenting the patient details like this. Then there is Dr. Michael Ullman's software. I in fact contacted him, myself and Dr. Prithvi contacted him. He sent us a trial version of his latest software also. And these are some of the things which I am planning to upgrade and make it commercial. Thank you to all the institutes where I learned all these. Thank you so much.
Simply brilliant, absolutely mind-boggling.
Thank you, sir.
John, the quality of the lens that you are using here, that a determinant in getting better or not so good images? The quality of
Yes,
the
sir. So
3D lens.
yeah, so I used a very old lens because this was the pictures on this are from a very old lens which I had, which is my work lens. That is what I use for many of my projects. So it had some scratches and all that. That's why the glare is there. But whatever type of photographs you get from any other smartphone fundus camera, you can get exactly that. I will take some newer photos and update it very soon.
Second question is there a kind of a sliding scale available like the old RAF gauge we used to have for near point of fixation? Is it possible to slide it up and down?
I did not make it slidable because the newer, all the smartphone fundus cameras, they have autofocus. So the distance needs to be approximately 20 centimeter. Rest of the plus or minus few centimeter is taken care of by the autofocus of the phone by itself. So we don't need the sliding mechanism. If it is a fixed focus camera, such as a Raspberry Pi camera or whatever the other devices use, then yes, you would need a sliding mechanism. I have actually tried that initially, but realized that it is not necessary.
Now in this, just show that again. Show your no, where your finger, where the lens is, the folded lens.
Lens is here.
The folded lens. Hold it.
Yes,
hold it. Now close it. Close it. One more.
Oh, okay.
Lens goes in, right? It's not
Yes,
exposed
sir.
at all.
Not exposed, sir.
So there are no scratches because of the folding, etc., etc.
No. This is completely encased
There
in
is
the
enough clearance on
plastic.
both sides so that the edges don't touch the lens, right?
Yes, sir. There is spacing there. I can actually add an extra transparent shield on both sides of the case also.
Lovely.
So that I
Lovely.
haven't done the transparent shielding, but that can be done. There is space for that.
Lovely, lovely, lovely.
I would like to add a polarized transparent shielding because I can remove some of the smartphone flash glare from that.
Lovely. That would be even great. Absolutely brilliant the way these young guys are using technology. Hats off.
Thank you, sir.
Thank you, Dr. John Davis. So I invite your second talk on designing 3D printed glaucoma drainage device, MIGS and cataract surgery.
Yes, sir. So I'll go on to my second talk. So I do a lot of 3D printing. All this started after COVID. So if you saw these smartphone fundus cameras, which I made, are also 3D printed. And I made several other 3D printed tools. So I'm going to show you those things. I'm sharing sound. Okay. So is my screen visible, sir?
Yes, you are visible.
Okay. So if you notice in this PowerPoint, there are some 3D models on the sides. If you look closely, you can see what happens when I move the slide. So you can also do this in all your presentations using the using the 3D models which I have uploaded for free. So these are various surgical instruments which I have made, including glaucoma drainage devices, MIGS devices, bimanual aspiration, large size IOL models, and so many things, CTR, CTS, BHEX ring, all these things, basically for wet lab or dry lab practice. So many surgeons, many young surgeons, they want to get access to all these instruments to practice, but they cannot unfortunately buy all these. So I made all of these as 3D models, and these 3D models can be 3D printed very easily for very less price. And in fact, this was how I learned to implant glaucoma drainage device. When I was in Ramchandra, I 3D printed a glaucoma drainage device and used it in the wet lab on an animal eye to practice RD implantation before I actually went to the OT. So this is how I train my assistants also. We all practice in the wet lab with all these type of instruments. And there are two types of 3D printing. There is two types of easily available 3D printing. One is the resin type. So the RD implant which you saw was made in resin. And the other instruments I made in PLA with plastic type of 3D printing. And there's another thing which we did. We also, I worked with Dr. Rohit Rao in Jharkhand. He had an idea to make a large size model of a cataract nucleus and the entire to practice cataract surgery to train the students. And this is what we did. We 3D printed the anterior capsule, the nucleus of the lens, and made the nucleus fracturable. So all these cuts are already there in the lens, and you can practice phaco trenching, phaco chopping, basically how to chop a nucleus, how to break apart a nucleus, all these, how to dial a lens, all these were easily taught by using these large size 3D printed models. So I designed this and emailed it to him, and he printed it, and he is training his fellows and PGs with this now. And this is two of the glaucoma drainage devices which I made during the COVID time, different models. Mind you, these are not for implanting in the human eye because they are not of a biocompatible material, but these are for trying out new designs, finding out what might work better, those sort of things, innovating new designs, and also for practicing surgeries. And then there is a bunch of MIGS devices. So this is the iStent Inject W with a white base. This is the Kahook dual blade. All these are models which I drew in 3D and 3D printed. And these 3D models are available to put inside your PowerPoint and also to use in augmented reality. These are all available for free on my account at the NIH, National Institute of Health USA 3D Exchange website, as well as the Thingiverse website. And this is some other instruments, the BHEX ring, the CTR, the modified CTR. And there is a few more. This is the bimalar aspiration cannula. And this is part of a different project also. So this is a bimalar aspiration cannula onto which you can attach a keratome blade, or you can attach a sideport blade onto the back end of it. So it helps in reducing the wastage during surgery. And this is a very useful, very frugal innovation in demonstrating different types of 3D models to students and patients and all of them. So if you have a phone, you just install this free app, Merge Object Viewer, and you 3D and you print a cube. You take an A4 paper and you print the A4 paper, make a cube from that paper cube, and you can use the camera on the phone, or you can use it on the laptop as well, to hold a 3D model in your hand. And that is how you can use this to demonstrate various 3D models to anybody you want to. And this is also possible to do. This is how the cube looks like. This is just a paper cube. And once you load it, you can load all these models onto it. I'll skip through to this part. You can also keep the model on the table or something, and then you can move your phone around it to look all around a particular model. You can move the model also. You can move the cube also. So you can move the phone also. So that is one way to examine 3D models. And that is very useful teaching tool. So pedagogy is going to be, very much updated with this. So thank you. I hope this is useful. So mind you, this is a very, very low cost thing. Just print an A4 paper, use gum and scissors and make the cube.
Lovely. Fantastic teaching aids. I think you should be in touch with Lahane sir and see how you can augment resident teaching with this. It's something so unique and absolutely out of the world. Yeah. I think you were lucky to
Yeah,
have.
really, it is John. It is very unique.
Thank you, sir.
Yeah, so John, you were lucky to be in the right place at the right time with COVID and have
Yes,
access
sir.
to a 3D printer, which I don't think anybody else has that easily, a 3D printer. So being in a dental cum medical college made all the difference, I guess.
Yes, sir. Yes, sir. So the dental college had a 3D printer, and it was not being used much. And seeing that I was interested, they said, please come and use the 3D printer.
Okay.
And I, in fact, got 2 MBBS students also to be interested in this 3D printing. And I told them you can do an ophthalmology project. And they designed a lacrimal punctal plug.
Wow.
And we 3D printed the lacrimal punctal plug and published in IJO also. So that was an achievement for those MBBS students who were in ophthalmology posting. So that was wonderful for them as well.
It's going to be a difficult choice to decide. I'm going to give up.
This presentation is also to be marks to be given, na?
Okay.
sir.
Okay.
I have marked it as John Davis 2. Yes.
2. Okay. Okay.
So our next presenter is Dr. Ankit Agarwal, and a brief introduction about him is a young ophthalmologist specializing in phaco-refractive surgery. He has presented many papers, posters, and faculty talk at various state, national, and international conferences. He has won Best Paper Awards at AIOC 2018, JHOS International Conference 2020, UPSOS Conference 2021, and the Best Video Award in AIOC Midterm 2022. He's from Patna, so Dr. Ankit, kindly go ahead with your presentation.
Thank you, sir. Am I audible?
Yes, you're audible and visible.
Thank you, sir. The topic is low-cost innovation for getting wide-field OCT images. I have no financial interest in this presentation. The OCT is a very important tool now. It's like a slit lamp, which was earlier used. Every ophthalmologist has a OCT now, but having a high-end OCT with a wide field is still a distant dream for many. They cost upwards of 30, 35 lakhs, 40 lakhs, sometimes ranging up to 60 lakhs for a 12 mm scan OCTs, which are usually swept source. So if we want to scan the macular area in the whole macular area in general, then a single OCT scan cannot do it. Thus, the lesions and extensions of edema, SRF, etc., which may be present in the perimacular area, may be missed in a single macular scan. To overcome this, I have proposed a low-cost technique to increase the scan length and thus be able to screen most of the area within the arcade in a single scan. 10 patients with various indications for OCT screening, like retinopathy, preoperative screening for cataract surgery, ARMD, CME, CSI, etc., were selected. The machine which I used was Topcon Maestro 1, but the theory same show any machine will work. The default scan length in the OCT which I used, that is Topcon Maestro 1, was 6 mm, and the scan configuration was chosen as radial. The macular OCT was performed and image was analyzed. Now another OCT was performed with the same machine, but in this the patient was made to wear a +20 diopter aspheric glasses in front of the eyes. The image thus obtained was analyzed and compared with the images obtained before, that is previous. Now this is how the patient is sitting, wearing the glasses, and this is how the glasses that that made the patient wear. The scan length in OCTs done with the spectacles was about 1.5 times larger than the scan length without spectacles. The distance from optic disc to fovea is about 4 to 4.5 mm in normal individuals, that is not hypermetropia or not myopics. Thus, the scan with spectacles covered the entire area between the temporal border of optic disc and the vascular arcade in a single scan, as shown in this picture. So the smaller circle depicts the area which is covered without the spectacles, and the larger circle depicts the area which is covered when the patient is made to wear the spectacles. This is the comparative scan. This is the same eye, the same patient. Scan was the upper one was taken with +20 diopter spectacles, while the lower one was taken without +20 diopter spectacles. So we can see that the with +20 diopter spectacles, we have much more area covered in the scan. In example, in a case of BRVO, without +20 diopter spectacles, we can see a smaller area covered, while with +20 diopter spectacles, we can see a much larger area covered. In a case of NPDR, with +20 diopter spectacles, we can see some amount of hard exudates present outside the scan area also. But without +20 diopter spectacles, only a few hard exudates are present in the area. Now, how the optics work in this? So the light rays coming from a wider region are converged by the +20 diopter, thus giving a wide field OCT image. Thus, in a traditional SD OCT, the field of image obtained is comparable to neural. The patients who underwent OCT with +20D spectacles had an increased scan length compared to those without spectacle addition. This helps in screening of patients capillary retinopathy, BRBO, preoperative immature cataract retinal screening, ARMD, etc., for the extent of the edema and lesions in the macula and perimacular area. Thus, the doctor himself or herself does not need to do scans all the time to see for any particular area. The technician can scan and just take a screening around and tell the doctor that it's fine, or we can just see the report once and that it is completely okay. The limitations are the system has only been tested on one OCT by myself. However, basic optics of any OCT remain same, so it should work with most OCT machines. The parameters like macular thickness, volume, etc., which are dependent on the machine software, will not work here because the refractive change has occurred and the machine will not be able to compensate for that. Hence, we cannot use this to analyze the images using the machine software. The conclusion is that this innovation helps increase the field of imaging and thus can capture perimacular areas which may have been missed earlier without the need for investing a huge amount of money on a newer wide field OCT system while spending less than rupees 1,000 on a spectacle frame with plus 20 diopter bias very glasses. Thank you.
So we'll ask the judges to ask the queries. Invite the judges.
Ankit, can you hear me, Ankit?
Yes, sir. Yes.
Acha, the question here was that you made a limitation statement saying that the machine's algorithms won't work. But a
Yes.
simple thing would be that you use it both ways. You use it first without and then with the glasses, so that wherever you need to focus more, only that part is part of your plus 20D, and the machine algorithms work in the first image without the glasses. You follow what
Exactly,
I'm
sir.
saying?
Yes, sir.
So that is not a limitation anymore. It's not a limitation. Only thing is you're doing two OCTs. One is with and one is without the glasses on the same patient.
Yes.
Yeah.
So what happens, sir, that when I did both OCTs together to show the difference that how much image extension is occurring with the
I'm not
glasses.
talking the difference. I'm talking about how to overcome your so-called limitation that you have made a statement. It's
Yes.
not a limitation.
Mhm. Understood.
There is an image enhancement. So the first image is with the preloaded algorithms of the machine, and the second is the image enhancement to be able for you to focus a little better, where you will use your clinical experience and judgment to come to a conclusion.
Yes.
Yeah, go ahead. Any questions from anybody else?
No question, sir.
So, Dr. Narendra Singh Verma, are you around?
Yeah, I'm there, sir. I'm there. Sorry for I was traveling. Yeah.
सुन ही लिया जाए ऐसे बहुत देर हो चुकी है फटाफट अगर कुछ हो सके जजेस सर डॉक्टर मनियार सर
Maniar, sir, sorry, I was traveling.
There's no sorry at all, Narendra. The only issue was that you made such a composite equipment. Now, what inspired you to do this? I'd like to know. It's a more of a personal question.
Sir, I attended Dr. Vasada sir conference. Then I see you 6 years before. They are doing topography. Then they are converting the anatomical structure in the degree. And at the OT, they are converting degree to the anatomical structures. So that the one thing came in my mind that why we are doing this so. So then we develop a app. And where to fit the app. So then we started developing a topographer. So it is a long journey. In the COVID, we were having a lot of time. And then I decided that it should have all the things which are needed in the toric lens implantation. It should give you the dry eye evaluation, keratometry, marking, error-free marking, no error. And after evaluation, all the formulas easy to evaluate and everything. It will tell you. So will be compact, easy to use for toric lens.
Thank you. Thank you, Narendra. I have no further questions. Dr. Kashyap, sir, in the hall, or Bhartiben or Dr. Kashyap, is Dr. Shahid also going to produce,
No,
present?
he is unable to present,
Okay.
so he has withdrawn. So now I request the honorable judges to prepare the mark sheet and send to the to us.
Yes,
Means
I'll do that.
send to the judges group. And in the meantime, we are going to start our prestigious extramural oration, that is Dr. R.P. Tandon oration. And for that, we invite the chairperson, Dr. Rajmohan sir. He is the past president of JHOS. Dr. Rajnikant Sinha. He is an eminent ophthalmologist from Dhanbad. Dr. S.K. Mitra, our honorary secretary. Myself, Dr. Bharti Sharma, she is the cornea surgeon from Jamshedpur. Dr. Abid Akhtar is a high volume phaco cataract surgeon from Ranchi. And the session coordinator is Dr. Dolly Tandon. She is the worthy daughter of worthy father, late Professor R.P. Tandon's daughter. She is an eminent senior ophthalmologist practicing in Ranchi. Dr. Dolly Tandon is here. Hello, Dr. Dolly Tandon.
Hello.
Yes. And Dr. Vibhuti Bhushan is our treasurer. He is the session coordinator. So we have two session coordinator for this session. So over to Dr. Dolly Tandon, madam, for coordinating, and she will first introduce the R.P. Tandon Oration Award, and then she will introduce the awardee. And this time, our awardee is Dr. Prafulla Marana from R.P. Center, AIMS, New Delhi. He is a cornea surgeon. So in the meantime, we will prepare the result. In the meantime, we will prepare the result. So over to Dr. Dolly Tandon.
Yes.
Yes. Madam, आप पहले हमें 2 मार्कशीट मिल गई है. We are bringing it to the conference hall. कौन-कौन भेजा है? ठीक है.
I'm going to please share your slides. Yeah, good. We are seeing, we can see your slides, Dolly.
Can you see me? Can you see the slides?
Yes. Yes.
Yes, slide is visible. Slide is visible.
Okay. And can you hear me all right?
Yes. Also audible.
How do I get this out of the way?
Dolly, the face is not coming as the way as beautiful you are. क्या हो रहा है face पे? क्या the light has to be little, adjusted.
I can't hear you very well.
Madam, please, we are 1 hour late.
Intensity करना होगा. That is coming on.
Change the orientation change कर लेंगे. I think the light is coming from her behind actually. That's why that face is
Oh,
not able.
light is coming from front, but I need to remove this something which is coming. I don't know how to do it.
Can you turn off the Zoom background, madam? I think that is what is happening. It's trying to find the background and remove. It's
yes.
Accidentally removing your.
Yeah, that can be blurred also, sir. That can be
Please,
blurred.
innovators, please keep logged in. So we will announce after 15 minutes after this session is over.
Where is the date, Dolly?
I can't hear you very well. I think there's something wrong. Let me see.
Anyway, please go ahead. Chalo.
Yes, 1 minute.
Dolly, we cannot hear you now.
Wait 1 minute. Yeah.
Dolly Di, please fast.
Yes.
Dr. Manyar sir, Your mark sheet, we are waiting.
Is requesting remote control of your screen.
Should
Approved.
we show from here?
Okay, okay. Yeah.
Bharti, give me 5 minutes. I've got it handwritten. You want a handwritten one or you want a printed one?
No, sir. आप हाथ से लिख के भेज दीजिए ना.
Okay, done. I'll just take a photo and send it to you.
हाँ सर, वही करिए.
LED glow, sir. आइए sir.
Vibhuti sir, if you can help, please.
What has happened, Dolly? We are showing from here.
Okay, it's all right.
Show from here. रुकिए, 1 minute. I'm calling the assistant. Please, oh, she is unable to do it. हम लोग यहाँ से we are showing.
First slide is visible. First slide is visible.
Please come.
Files are visible. I don't know what is the problem.
We have to change from here. We have to change from here. You please keep reading. We will change from here. हम लोग यहाँ से change कर रहे हैं. Please start.
Okay. Respected seniors and our colleagues, I'm going to talk about Dr. R.P. Tandon. He's my father, and we'll start his oration. Dr. Praful Kumar Mahanta will be doing his award, getting his award for oration. Dr. R.P. Tandon is no longer with us. He was one of the most prominent members of our fraternity. Those of us who had the privilege of knowing him would fondly remember him as a distinguished ophthalmologist and a wonderful human being. He was very knowledgeable and had immense wisdom. If there was one that defined him, it was his quest for knowledge. He was a voracious reader, and he imbibed everything that he read. He could talk on any subject, from ophthalmology to oceanology, and philosophy to politics, from science to economics, and from history to the latest gossip. He was a great communicator, and once he got on the topic, you could not be charmed by the clarity of vision and oratory skill. He had a natural gleam in his eyes and a mesmerizing smile. Dr. Tandon had an early education at St. Michael's School, Patna. He did MBBS from the Prince of Wales Medical College, Patna in 1954 and MS in 1957 from the same college. He then joined the Bihar Health Services and was posted at Bodh Gaya. He left for London in early 1959 and did DO, RCS, RCP, followed by FRCS in 1964. He came back to India in 1965 and joined Rajendra Medical College, Ranchi, and worked there for the next 10 years. Dr. Tandon left government service in 1975 and went into full-time practice at Ranchi. With the liberalization of economy, he was quick to grab the opportunity to upgrade his clinic with the latest equipment and technology. He was very popular among his colleagues. To them, he was just Tandon. He was clinician and surgeon par excellence. His clinical knowledge and wisdom was immense, and most of the who and who of Ranchi flocked to him for advice and treatment. His clientele also came from nearby areas of Ranchi. He was one of the founding members of Academic Medical Forum. He was its founder secretary and wrote the constitution and later became its president. Academic Medical Forum honored him in 2000 as the most outstanding ophthalmologist of Ranchi for his leadership in leading the forum to his present position, and above all, for his being a fine model of a cultured human being. He was president Bihar Ophthalmic Society during 1989 to 1990. Jharkhand Ophthalmic Society also honored him with Lifetime Achievement Award in 2006. He commanded a great versatile personality. During this time, he authored many books on varied subjects. Example, Successful Man, Transformation to Love, Mind, the Karmic Laws, etc., to name a few. Apart from academic forums and societies, he was also a member of Sri Sakti Sai Seva Trust and Sri Sakti Sai Organization. Dr. R.P. Tandon left for his heavenly abode on 3rd December 2011. He leaves behind a great legacy. His wife, Mrs. Saroj Tandon, his 4 daughters, and their families are doing well. And we are proud to have one of the daughters, Dr. Dolly Tandon, as an active member of the Jharkhand Ophthalmic Society. Thank you. Was that audible?
Yeah.
So,
Doctor, you have to introduce the awardee.
Yes.
Please call her. Please be here. Please be here. Please, Dr. Prafulla Maharana ka lagao. Screen stop करिए. Stop your screen showing. रुको 1 मिनट, म्यूट पे कर रहे हैं. Visible.
Not as yet.
Visible.
No, it is not visible.
Open the presentation, please.
अरे हम लोग कर रहे हैं इधर से. उनको दिया हुआ था.
हाँ वही से
तो उसको ओपन करो, खोलो.
और PowerPoint हाँ.
अरे मार्कशीट ऊपर
उस
पहुंचा.
पर डबल क्लिक कीजिए, उस पर डबल क्लिक कीजिए.
हो गया.
नहीं जो हाईलाइटेड है ना, जो हाईलाइटेड है PowerPoint, उसको डबल क्लिक कीजिए.
ऊपर से कॉन्फ्रेंस हॉल से नीतीश को भेजिए नीचे. यू आर देयर ना. ठीक है. ये इन लोग को स्लाइड दिया हुआ था लेकिन लोग कर ही नहीं पा रहा. ऊपर से कॉन्फ्रेंस हॉल से नीतीश को भेजिए.
डॉक्टर मैम जस्ट डबल क्लिक दैट, वो जो हाईलाइट किया हुआ उस पर डबल क्लिक कीजिए, वो खुल जाएगा.
मैम पहले
कहाँ पर?
हम्बल रिक्वेस्ट है मैम, पहले स्टॉप
आपका
करिएगा.
स्क्रीन में जो हाईलाइट
जस्ट अ
आपको
सेकंड
रिजल्ट
है उसको डबल क्लिक कीजिए. दैट्स ऑल.
You guys want to declare the result?
डॉक्टर भारती
या कॉन्फ्रेंस हॉल पे
जस्ट डॉक्टर
कॉन्फ्रेंस हॉल
भारती
में
को
पहुंचाया
स्टॉप करके
तो
ना
क्यों
पहले पीपीटी ओपन करके फिर शेयर करिएगा प्लीज.
ये कर ही नहीं पा रही है. कर रहे हैं रुको.
अभी
हाँ,
अभी
हाँ.
पहले पीपीटी ओपन करके फिर शेयर करिए
वो
प्लीज.
भी
फर्स्ट ओपन द पीपीटी डॉक्टर, देन शेयर प्लीज.
वो हम लोग कर रहे हैं इधर से. प्लीज
हाँ जी, एक बार पीपीटी ओपन करके फिर शेयर करिएगा.
फुल स्क्रीन करो.
अब वहां से जाके सेव कीजिए.
तुम भी आओ देखो.
सेव कीजिए.
शेयर करो.
कर दिया. इनफैक्ट डॉक्टर टंडन ने शेयर किया शायद.
नहीं हम लोग कर रहे हैं.
ओके, आई एम स्टॉपिंग डॉक्टर टंडन.
हाँ उनका आप बंद करो.
तो वैसे ही कीजिएगा पहले.
हाँ जी, you can please.
Here we can see. Prafulla Maharana, we can see him.
Yes, it has come.
मार्कशीट तो जल्दी से जाके ऊपर. We will declare the marks after the oration.
Yes.
So all the innovators, please stay logged in.
Yes.
So we have, am I audible?
Yes, yes, very much.
So we have 3 prizes. The first is 15,000, second is 10,000, and the third is 5,000, and it is sponsored by Intot Pharma. So after the oration, we will announce the awards, first, second, and third. So over to Dr. Dolly Tandon.
Yes. Dr. Praful Kumar Maharana, he's an MD, and he has done his senior residency and is working in RP Center, AIIMS, New Delhi. He's additional professor, cornea, cataract, and refractive unit, RP Center, AIIMS, New Delhi. He's also academic co-in-charge, RP Center. Also Secretary, Delhi Ophthalmic Society. He has been the chief editor of Ophthalmology Clinics 2 and Postgraduate Ophthalmology. He's published 395 Google Scholar, 156 PubMed Index papers, 50 chapters in national and international books. His areas of interest are keratitis, keratoconus, and keratoplasty. Best Surgical Technique Award. He's got the Best Surgical Technique Award from Branzo, Young Achiever Award, ISC KRS, Ajit Babu Manji Award, Odisha State Ophthalmology Society, and awards for Best Paper in various conferences. He has been the principal investigator in 2 ICMR trials, clinical trials in
Investigator. Co-principal investigator.
He has been the principal investigator in 2 ICMR trials, co-PI in 18 trials, including 2 multi-centric international trials. Thanking you, Dr. Praful Kumar Maharana. He'll be speaking about infectious keratitis. Over to you, Dr. Maharana.
Thank you, ma'am, for that kind introduction. I think you'll have to stop sharing the slide. Then I can share mine.
Admin, kindly.
जल्दी से ये करो कौन सा अभी है पानी मंगाओ ऊपर से पानी मंगाओ
If my slides are visible?
Yes.
Hello. Okay, so good afternoon. Yes, good afternoon, everyone. And thank you, Bharti ma'am and team JOSCON for allowing me to present this as a RP audition award here. And let me start with the talk. So I'll be speaking on non-healing keratitis, my approach, because you all know corneal opacity is the most common cause of blindness as per the latest census in patients, young patients below 50 years of age. And one of the most common cause for corneal opacity is keratitis. In fact, keratitis is leading cause, and second to that, probably trauma. So, being a referral center, RP center, we get a lot of cases of refractory keratitis. So, what I thought over last 5 years, I did some work to see what is best and what is the culprit in non-healing keratitis. So, I'll be presenting that data here. So, non-healing classically we defined is any bacterial ulcer which doesn't show any sign of healing, or it worsens after 48 hours with optimal therapy. For fungal keratitis, the response comes little slow. So we wait for 1 week. If there are no improvement or there is worsening, then we label it as non-healing keratitis. So there are several causes. If you go through the literature, there are several causes for non-healing keratitis. The most common being drug, that the penetration of drugs are not that good. So that is one of the important cause. The other factors being physician. Physician means you made a wrong diagnosis and putting drops in a wrong direction. Or patient factor. Patient is not compliant. Or nowadays, one common problem that we are encountering is increasing drug resistance. The patient may have organism which are resistant to the the antibiotic that we're using. And there are several UKs here. UK mean unknown factor. What I believe, what most corneal surgeons believe, in spite of these four major factors, there could be some factor which we still don't know or unaware of that may lead to non-healing of keratitis. This is the review article. If you want to go through detail, then you can go through that. So we looked after several aspects that may be a factor in non-healing keratitis. The first factor that we evaluated was drugs, organism, patient factor. So those who do cornea, they till now, people they don't we don't have any direct correlation between the drug amount of drug that is reaching the site of corneal ulcer and the MIC or the minimum concentration of drug that can inhibit that particular organism. So far, in literature, if you go through that, there are only experimental studies, animal study. So what we did so one unique study where we measured the concentration of natamycin as well as voriconazole in patients' cornea. And then we also measured the MIC of antifungal drugs, these drugs in those patients. Then we compared because that would have given us the direct idea of whether the penetration of drug is really poor, is claimed by experimental studies, or are we dealing with something else? So there are the two concepts that I think all of us should be aware of. One is bioavailability. That means how much drug is reaching the site where it is required. The second is minimum inhibitory concentration or the concentration that inhibits visible growth of microorganism after overnight incubation. So in layman term, MIC is the amount that is required to kill the bacteria or fungus, and bioavailability is the drug that is present there. So in ideal situation, your bioavailability should be better than MIC. So in this study, what we did, we took all the fungal keratitis patients. Those were not responding to medical management, and we did a therapeutic penetrating keratoplasty. In all this organism, we ensured that the patient receives the last drop of either voriconazole or natamycin at least 1 hour before the surgery. Then we divided the host button into two halves. One part we sent to our pharmacology department to measure the drug concentration in the cornea. The second half we sent for MIC estimation. Now, measurement of drug concentration, it was done through LCMS or liquid chromatography mass spectrometry. The details I will skip here. It is not required for clinicians unless you are planning some research similarly. And this was the E-test that we did. These are strips. Once you deep into the colonies, that can give you the MIC level of the organisms. Although it is not a very accurate method of measuring MIC, but this is the practical solution to measure MIC in most of the cases. So we did this E-test to measure what are the MIC of this organism. So I'll skip most of the results. I'll just focus on which are the major conclusions that we found here. So to our surprise, 85% of cases in patients, 85% of the patient, the voriconazole concentration that was achieved in cornea was less than the MIC that was required to kill almost 90% of the organism. So that suggested a very poor penetration of voriconazole. Remember, this is in contrast to the common belief. Normally, we believe voriconazole has a better penetration compared to natamycin. But in our study, it was little bit in contrast to what our belief is till now from literature. And in natamycin, the penetration was better than voriconazole. However, in 38% of cases, again, it couldn't reach a level where it could kill all the fungus present there. So the age-old concept that poor penetration of drug is a major factor for non-healing of keratitis holds true. And those who have gone through MUT study, the largest trial, the multicentric trial in fungal keratitis, there they found out that natamycin is superior than voriconazole. And when the result came, everybody was surprised. How come this is possible? Because voriconazole has a better penetration than natamycin. But if you correlate that outcome with our study, that holds true. Voriconazole, even if in experimental models appear to have a better penetration, when in real life situation, the penetration, from the result from our study suggests it is poorer compared to your natamycin. That is what probably the MUT trial they found natamycin was superior to voriconazole. And the second major factor, the conclusion that surprised us was that even in natamycin cases, those patients where the concentration was higher than MIC 90, still the patient didn't heal or there was a poor response. So as I said, there could be so many unknown factors like patient immune status, all these factors that we still may not be knowing, that also plays a part of healing of fungal keratitis. And another important thing, age-old concept is that if you debride the corneal epithelium, the penetration of drug improves. But in our study, when we compared, we did a correlation analysis, and what we did that we measured various factors like infiltrate area, size of the epithelial defect, duration of treatment, depth of ulcer to antifungal concentration in cornea. And we didn't find any correlation at all. So there are few myths that we could clear with the result of this study. And the second test study that I did was looking after the diagnosis. So we don't have, in India, most of the cities, they don't have accurate microbiology diagnostic tools. So there was a recent study in AO, American Academy of Ophthalmology. They did a study where they found that in 70% of the cases, a clinician can accurately predict whether it is a bacterial keratitis or it is a fungal keratitis simply based on clinical signs. Now in India also, we know whenever you see a prescription from some practitioner, you will find there is a cocktail of therapy, fungal, antiviral, everything is there. So we wanted to see whether clinical diagnosis is good enough to predict whether you are dealing with a micro fungal or bacterial keratitis. So what we did, we included 20 to 80 cases of microbial keratitis. Out of that 40% cases, we had result of clinical diagnosis as well as corneal scraping results and post-therapeutic keratoplasty histopathology. So we compared these three results. And what we found that in cases of overall bacterial, fungal, or other keratitis, only 54% cases the clinician could accurately predict whether it's a bacterial or fungal or some other form of keratitis. Although it was better with fungal in 75% of cases, clinician can predict it's a fungal keratitis, but for bacterial keratitis, it was very poor. So what we concluded that when you compare these three methods, corneal keratitis diagnosis simply based on clinical finding may not be that sensitive to start with specific therapy. So it's better whenever you are dealing with a keratitis and you don't have microbiology setup, it's always good to cover all possible organisms rather than we giving specific therapy. And it's always good to refer the patient to a higher center or center where microbiology is possible. Then again in diagnosis part, we explore the usefulness of corneal biopsy. So a corneal surgeon would understand that normally we do corneal biopsy when two of the corneal smear or corneal scraping samples are negative and the patient is not showing any signs of healing. So what we did, we took all the patients which were already on antimicrobials for more than 1 week. And what we did was that we did biopsy primarily instead of waiting. So normal approach, what we do whenever a patient of keratitis comes to you on multiple drugs, we withhold antibiotics. We label it as a drug holiday period. We give it a holiday period of 48 hours. Then we do corneal scraping. If that fails, then we go for biopsy. But in this study, what we did, the moment a non-healing keratitis was there, we went out with biopsy straightforward instead of waiting and giving a drug holiday period. So this is a pre-op and post-op period of corneal biopsy photograph, and this is a short video how we did biopsy here. So anybody can do in OPD setup if you have a slit lamp and a minor OT. Just clean the eye of all the mucus or all the debris that is there. And what you need is you need to have just a crescent knife. And if you have a dermatological trephine, skin trephine, that would much better because that would allow you precise area of corneal biopsy. So prefer an area with some part involving ulcer and some of the normal looking cornea. Do a partial trephination and take a crescent knife and take a piece of cornea and send it for histopathology as well as microbiology like corneal just like you do in corneal scraping method. So what we did in this study, we took 44 patients. It was a randomized control trial. Okay. So in that 22 patients, they underwent corneal scraping after a drug holiday period. 22 patients, they underwent corneal biopsy directly. Then we compared the outcome of microbiology investigation between biopsy and corneal scraping. So when bacterial keratitis was there was not much difference. As you can see here, the p-value was just 0.3. But in cases of fungal keratitis, you can see compare these two bar. when 54% of the fungal organism could be isolated with a biopsy, while in scraping it was just 18%. And the significance, then the difference was statistically significant. So this suggested that if you are suspecting a fungal keratitis, rather than waiting for a drug holiday period of 48 hours and then go for scraping and then go for biopsy, you may directly go for biopsy. It will save 3 or 4 days of intervention. So, and that exactly translated into our clinical outcome also. If you notice here, the number of cases in biopsy group, only 54% needed keratoplasty because we could get a diagnosis early and we started treatment. So almost 50% could be treated medically only. While in cases where only corneal scraping was done after a drug holiday period, 73, almost two-thirds of the patient, they required a keratoplasty. So if you are suspecting fungal keratitis, you can go for a direct biopsy. That will save at least 25% of patients or 25 out of 100 patients from undergoing a keratoplasty, and the patient may heal with simple medical management only. So this was a third major study that we did. And then, there is always a controversy. A lot of trials, they showed that if you add oral antifungal or oral antimicrobial, it has no effect on keratitis. So what we did, we tried to look whether the antibiotic that we're giving to a patient, whether it is reaching the tear film at a concentration which would be enough to kill the bacteria, or it is not reaching to that level. So what we did, again, we did a study where we included 38 patients. We give them oral ciprofloxacin for 5 days, and then we measured the tear film concentration of oral ciprofloxacin. Again, we use that liquid chromatography mass spectrometry to do that, and we collected the tear film when we submerged it. So this was the analysis part, which again, I'll not be discussing in detail. So what we got is that, see, this is important. So we compared the concentration of ciprofloxacin in tear film of infected eye versus normal eye. So all cases were unilateral keratitis. So infected eye, the mean concentration was almost 824 nanogram per ml, while in normal eye, it was 504. So whenever there is a corneal infection, the bioavailability of that drug which you are giving orally, that is significantly more compared to what it is reaching in non-infected eye. So if you give oral antibiotic, there is higher chances that it may reach at a higher level. And you can see in this, it was statistically significant. Then what we did, we calculated the MIC level of organism for ciprofloxacin from historical data, because in that we didn't have a control arm. So these are the various studies where we explored against most of the organism. For us, the point of interest is Staphylococcus aureus, because that is what we see in most cases bacterial keratitis. So what we found that the tear film concentration of oral ciprofloxacin that was achieved is much more compared to the MIC of Staphylococcus aureus over the result from various studies in literature. So that means if you are suspecting a bacterial keratitis, probably a Staphylococcus origin, if you give oral antibiotic, that is definitely going to aid in your treatment, and it may help in cases of non-healing keratitis. So if I summarize what we did over last 5 years, as I showed in my first study, the antibiotic resistance may be high, because if you remember, in cases of natamycin, even if the drug concentration was more than the MIC, still 50% of the patient, they didn't respond. It might be because those organisms that were there, they were resistant to antibiotics. So whenever you are dealing with a keratitis and you are giving all treatment, but the patient is still not responding, it's better to go for an antibiotic sensitivity test. Don't have any microbiology investigation accessible to you, it's better to refer the patient and start with the antibiotic combination, which covers both gram negative as well as gram positive. Okay. Corneal biopsy is a primary tool. Yes, instead of giving a drug holiday period of 48 hours, you can consider doing a biopsy in patients of non-healing keratitis. Oral antibiotics, they do have a role in non-healing keratitis. There is no harm in using oral antibiotic when the patient is not responding to topical drops. So thank you very much for your kind attention, and my best wishes are with Dr. Tandon's family. One aspect that catches my attention in his biography was that he wrote several books which was not related to ophthalmology. So again, being a corneal surgeon and those corneal surgeon or general practitioner, you have to have out of the box thinking. So rather than following the same protocol that over the period of people keeps on teaching you, you should explore extra things while treating cases of non-healing keratitis. And with this, I would also like to invite all of you to our winter DOS conference, which is going to be held on 23rd and 24th November at Hotel Ashok. And if you haven't submitted any topic yet, you can send me through WhatsApp if you wish to join us for the program. Thank you very much.
Thank you, Dr. Maharana. That was really very nice. Thank you for the kind words for my father. There was some difficulty in coming to the presentation. Thank you, everyone.
Thank you, Dr. Prafulla, for accepting our invitation. And we thank you very much. And we are going to felicitate you with the plaque and all in our annual conference, which is in March at Devghar. So keep your dates free in March. I will inform you for the dates. And I want to announce the winners of the innovative session. Please, camera on karo. Is the camera on?
Yes, yes. We can
Yes,
see.
okay. The first prize goes to Dr. Jagdeep Kakaria for retro illumination system.
Wow.
Thank you.
And
Thank you, ma'am. Thank you very much. Thank you
ये तो
very
सब
much,
आपका ही चेला
judges.
लोग जीत रहा भाई, बहुत बड़े इनोवेटर है आप. The second prize goes to Ramesh C. Sa for Terigo, again your Shishya only. And third is the young doctor, Dr. John Davis Akara for ultra portable fundoscope. Or John Davis, you won, and I did not create the group because there is a lot of controversy of for sharing the numbers of the innovators and international heroes. So I have not created a group. So it is AIOS property, but I'm really thankful that I got the numbers. I'm thankful to AIOS, they gave me the number, and I'm also thankful to the innovators that they accepted and they presented. So, and then whosoever wants to take the mobile number or whatever they want to purchase, they can take from me. And now we are going to start the third session. Third session, though. So, yes.
क्या डॉक्टर ककरिया हम लोग को एक महीने का चेला बना सकते हैं?
सर आप तो गुरु हैं.
अरे नहीं, ये तो आपका हम्बलनेस है. यू आर ग्रेट इनोवेटर. यू आर ग्रेट इनोवेटर. मुझे तो लगता है चेला लोग भी आपका ही इनोवेशन को प्रेजेंट करता है. यू आर ए ग्रेट इनोवेटर.
Thank you, ma'am.
Even
Thank
Dr.
you so much. It's all inspired, all the flashes of wisdom given to me by my friends, and since I have a team, so I can make the innovations to happen or produce it in 3D. And I also look forward to coming to the annual conference of Jharkhand Ophthalmic Society in the March.
Yes. We will invite you. We will
Sure.
invite all the first, second, and third innovators to our annual conference.
Yeah.
And
Thank you.
thank you, sir. Thank you, all the innovators. Now we are starting our third session. That is the case presentation session, very sensitive session. All the PGs.
Ma'am, it's 3 a.m. here in the USA, and
Yeah, I know.
take a leave now.
You are widely awake. But then when I saw the mark sheet, I told you to keep awake because something very good is awaiting. So it's worth keeping awake. So now,
Okay, sure, I will.
and we are going to start the third session. This is the case presentation, and our session coordinator is Dr. Deepak Lakda. He is the senior most faculty of Rio RIMS Ranchi, the largest medical college of Jharkhand. And Dr. Reena Singh, she is the cornea cataract refractive surgeon and very well trained in RP Center, AIMS, New Delhi. And our chairpersons are Dr. S.R. Singh. He is the secretary, president, Ranchi Ophthalmic Forum. Dr. Anup Gupta, he is the vice president, Ranchi Ophthalmic Forum. Dr. Rashi Shyam is a very prominent glaucoma surgeon from Ranchi. Dr. Anand Shushrut is from Jamshedpur, prolific cataract surgeon. Dr. Anindya Anuradha is a prolific glaucoma surgeon from Ranchi. Dr. Ratnesh is a prolific phaco-cataract surgeon from Ranchi. Dr. Tanisha Ojha is a is a glaucoma surgeon from CCL Ranchi and takes keen interest in sharing all the PG teaching and everything, all the public awareness programs from CCL. And we are highly obliged to Dr. Tanisha Ojha. Dr. Archana Kumari is also one of the chairpersons. She is a VR surgeon from Ranchi. She practices in Ramgarh also. So this is all about the chairpersons. Now over to the session coordinator, Dr. Deepak Lakra and Dr. Reena Singh to introduce our honorable judges. So our judges, I can see Dr. Shweta Walia. She has become, can you see me? Yes, Dr. Shweta Walia is associated with me since 2016 when we used to organize TSTC in AIOS. For 3 consecutive years, we organized TSTC. I was the chief instructor and she used to be my associate. That time I recognized her talent. And Dr. Prakhyat Rup is there. He's a very junior guy, but he's extremely talented. He's my guru. When I started my trans PRK and this keratoconus thing, which is very new to me because previously I used to do only LASIK. So this boy taught me all the intricacies which he learned in Narana Netralaya. He's basically from RP Center and is a great innovator. So beta, we welcome you in this judges session. And आप तुम लोगों का भी डिटेल होगा. Shweta Walia has become CSC of Madhya Pradesh. Fuse Bansal is here. He's another judge and very, very dynamic. He came here when we were having our annual conference in Kushalpalli. He took lot of efforts, and he came on the last day. He met everyone in Ranchi and he won. He won. He is very young. How he manages his practice and All India Ophthalmological Society politics, I really don't know. And he is also contesting for CSC post in Maharashtra, which is one of the biggest society. So, and we have Dr. Deepak Mishra, who log in kiye hain. Dr. Deepak Mishra, call karo. डॉक्टर दीपक मिश्रा इज अनदर स्टालवार्ट. ये तो फॉर्मल इंट्रोडक्शन होगा सबका, मैं थोड़ा इनफॉर्मल इंट्रोडक्शन दे रही हूँ. डॉक्टर दीपक मिश्रा इज फ्रॉम यूपी. ही वाज सीएससी ऑफ यूपी ऑप्थेल्मोलॉजिकल सोसाइटी, लार्जेस्ट ऑप्थेल्मोलॉजिकल सोसाइटी, and he takes keen interest in academics. He was there in Sao. He sacrificed all his Bhutan trip and he was just following Dr. Lalit Verma. He was looking after the academic program of Sao. That was really highly appreciated. तो अब इन लोगों का फॉर्मल इंट्रोडक्शन के लिए मैं सेशन कोऑर्डिनेटर्स को इनवाइट करती हूँ. सो ओवर टू डॉक्टर दीपक लकड़ा एंड डॉक्टर रीना सिंह.
Good afternoon. Good afternoon. It is my pleasure to introduce the judges. The judges are Praful Mehta, Deepak Mishra, Shweta Walia, Ritus Bansal, and Prakhyat Rup. So already Dr. Praful Mehta was introduced by Dr. Toli Tandon. And I'm going to introduce Deepak Mishra. He's the Associate Professor, Regional Institute of Ophthalmology in BHU. He's the Achiever Award has his total number of awards is 55, including the 15 gold medal. He's published 21 books and chapters. His publication in 103 in peer-reviewed index journal. He's a reviewer and editor of board member in 15 national and international journal. He's member of All India EOS. He is the Honor Secretary, International Society of Manual Small Incision Cataract Surgery. He is the chairman of ARS UP State. He is the founder PG Examination Forum and National Convener FFTC. He is the journal member of FBC AIOS. He is the chairperson of postgraduate activity of the Equine. Next judge is Shweta Walia. He is the professor and in the MJ Medical College, Indore. He is the Joint Secretary of MP State Ophthalmic Society. ESC has more than 50 publications in national and international journal and contribute the chapter in Hindi ophthalmology textbook. She is one of the initiative in which Madhya Pradesh takes the national lead. Is an innovative technique of socialist glueless SF5 in 2016. This award is All India Talent Research Award. Is given by Prime Minister of India, Sri H.D. Devgowda. Best Teacher Award, Srimati Mani Harish Chandra Memorial Award, a minor class of patents, Indore Annual Medical Publication Award, Daika Award, and awarded excellent later by Indore Collector and Minister Kailash. Vijay Varghese during 26th January parade ceremony for the exemplary work done by promote the eye donation in Indore city. And next introduced by Dr. Reena.
Good afternoon, everyone. So I'm going to give you a short introduction about our other two judges, Dr. Piyush Bansal and Dr. Prikhyat.
Change the slide, please. Piyush Bansal का slide दिया जाए.
Dr. Piyush is a known vitreoretina surgeon. He's a former long-term fellow and adjunct faculty of LV Prasad Eye Institute, Hyderabad, and San Raffaele Hospital, Milan, Italy.
Dr. Reena, little slow and loud.
Okay. I should start again, Dr. Piyush, don't mind. So Dr. Piyush Bansal is our third judge. He's a known vitreoretina surgeon. He's a former long-term fellow and adjunct faculty of LV Prasad Eye Institute, Hyderabad, and San Raffaele Hospital, Milan, Italy. He is a founder and director of Bansal Vision Institute, VVI Eye Hospital, VVI Retina Center in Pune, Maharashtra. He is also consultant at DYP Medical College, Jehangir Hospital, Aditya Birla Memorial Hospital in Pune. He has more than 50 publications, both national and international forum, and he is an executive member of and governing member of VRSI, Vitreoretina Society of India. He is also member of the scientific committee, member of All India Ophthalmic Society. He's a renowned surgeon. His area of retina macular surgery, diabetic vitrectomies, AMD, and also is a specialist in ROP and uveitis. He has performed more than 9,000 retinal surgeries so far. He is very active personality, as ma'am has already introduced. For accepting our invitation, Dr. Piyush. Next judge is Dr. Prikhyat Group. Dr. Prikhyat Group.
Please change the slide. Please change the slide.
Prakhyat.
Dr. Prakhyat का slide दीजिए. Good, thank you.
So our next judge is Dr. Prikhyat Group. He is an alumnus of RP Center, AIIMS, New Delhi. He did his post-graduation as well as specialization from RP Center. He is trained in cornea refractive and ocular surface surgeries. He has a distinction of being only surgeon to hold 2 patents in the United States for his inventions on IOL optics. He is a 2-time recipient of winning Pitch Challenge Award at ACRS. He is the only person in the world to do the same. He's a great innovator. I really appreciate that. He is a prolific surgeon in complex anterior segment surgery, like corneal transplant and remake and DSEC. He has recently emerged as world leader in advanced lenticle extraction surgery. And right now he is an invited faculty at Zymer Academy at SNEC, Singapore. Welcome, Dr. Prikhyat, and thank you for accepting the judge position in this session. Thank you very much.
So my first speaker is Ujjwal. He is the first year DLB student, and he is talking on ocular tuberculosis and unusual presentation.
प्लीज आप उन बच्चों लोगों को बता दें कि 6 मिनट से बच्चे लोगों का 5 मिनट पे घंटी बजा दीजिएगा.
Okay. So the pages, there is 6 minutes for the presentation. I will give the bell 5 minutes and one more after 1 minute and 2 minutes for the discussion. Okay. So Dr. Ujjwal.
डॉक्टर उज्ज्वल आप रेडी हैं?
हाँ, yes.
ठीक है बेटा.
Am I audible?
हाँ बेटा.
Okay.
स्लाइड शेयर करो बेटा.
Please share the slide.
Is my screen visible?
नहीं.
Yes, your screen is visible.
Thank you.
Good
Good morning, everyone. I'm Dr. Ujjwal. The topic is ocular TB.
Screen is not visible.
बेटा
Screen
रुको.
is not visible.
Yes, yes, it is visible.
हाँ, ये कॉन्फ्रेंस हॉल में दिखना जरूरी है. Judges, Dr. Shweta Walia, Dr. Prakhyat Roop, can you see it?
No, no, no.
No, I can't see the screen.
Because I am unable to connect Dr. Deepak Mishra and Dr. Praful Maharana. So Dr. Prakhyat and Dr. Shweta Walia has to do very. Praful Maharana called me. You are there, na? You are judge.
हेलो
हाँ,
Dr.
आप
Piyush
judge
is the
हो.
judge.
मैं 2 मिनट में आ रहा हूँ मैं हूँ मैं सुन रहा हूँ
तो because your numbering will matter a lot. ये बच्चा लोगों का सारा टीचर लोग बैठा हुआ है यहाँ पे.
हाँ मैं वहाँ पे हूँ आप जजेस को इंट्रोड्यूस कर रहे हो ना अभी
अब हम शुरू कर रहे हैं because बहुत तबाही हो जाएगा नहीं. ठीक है.
Dr. Ujjwal, please share your screen.
I'm not able to. There is an option of share that I'm clicking, but it isn't.
टीम को बोलो करेगा. बेटा हम तो दूसरे बच्चे को लेते हैं अभी, तो तुम तब तक टीम से बात करो.
Okay, okay.
डॉक्टर रीना तुम और डॉक्टर अभिषेक सहदेव, डॉक्टर दीपक लकड़ा, प्लीज आप दूसरे बच्चे को बुलाएं.
Next speaker is Arshit Savan, Dr. Arshit Savan. You ready?
Yes, sir, I am ready, sir.
सोफिया को लगाओ, जल्दी से लोग बैठे मत रहो. सोफिया को लगाओ, उसकी टीचर है.
Am I audible, sir?
She present on the endophthalmitis or uveitis diagnostic dilemma.
Am I audible, sir?
Yeah, you're audible.
Your audible or screen is not visible actually.
One second, sir.
Share your screen.
Now is it visible?
Yeah, now it is coming. Now it is coming.
Yes.
Is it visible, sir, now?
Yeah, it is coming. Make it full.
It's full screen, sir.
It's okay. Go ahead.
Okay. Good morning, everyone. Good afternoon, everyone. Today I'll be presenting a case which came to our OPD, and we were in a huge diagnostic dilemma whether the case should be treated as a case of endophthalmitis or a case of uveitis. So we all know that endophthalmitis is the inflammation of the inner coats of the eyeball, which results in accumulation of exudates in the vitreous and aqueous. And if it presents less than 6 weeks, then it's called as acute. And when it presents after 6 weeks of operation, then it's called as chronic. While uveitis is the inflammation of the middle layer of the eyeball, which is called as uvea, and is classified as anterior, posterior, intermediate, and pan-uveitis. So a 55-year-old male presented with chief complaint of sudden diminution of vision associated with pain from past 3 days. Patient underwent small incision cataract surgery 1 month back. Preoperatively, his BCVA was 6/36 with a cataract grading of NS4 PSC4, for which he underwent small incision cataract surgery with PCIOL, and which was uneventful. On postoperative day 1, the visual acuity improved to 6/12. So the patient was advised to routine postoperative medications. On postoperative 1 week, the visual acuity was 6/9. So the patient was advised to continue the same postoperative medications with tapering dose of prednisolone acetate. But patient presented after 1 month with the chief complaints of pain and redness in right eye from past 3 days, with a BCVA of CF 1 meter in the right eye, and in the left eye was 6/12. The external examination was normal with Hirschberg corneal reflex to be central. In slit lamp examination, we could see there was congestion in conjunctiva in the right eye, and also there was the incision mark with the recent surgery, which was well opposed in the right eye, while left eye was absolutely normal. In the anterior chamber, we could see there was cell of grade 4 and a flare of grade 1, but no hypopyon was present. While in the left eye was there was no cells and flare. The IOP was 16 and 18 mm respectively, which was measured with Goldman ablation tonometer. So we did a dilated posterior segment evaluation, in which we saw that the media haze was grade 3 and posterior pole was very hazily visible. Ophthalmos, blood vessels, macula, and general background could not be commented upon, while in the left eye it was absolutely normal with a cup disc ratio of 0.3:1. So we did a B scan, in which we saw there was multiple vitreous echoes and a small amount of exudative retinal detachment could be seen. So with this, the patient presented, which was post-operatively 4-week with sudden diminution of vision from past 3 days associated with pain, with a visual acuity of CF 1 meter. So we were in a dilemma whether to treat the patient as a case of endophthalmitis or we should proceed it with a case of uveitis. So the symptoms for endophthalmitis, which patient presented, was blurring of vision, pain, and redness, and signs with hazy media. And for uveitis was redness, painful blurring of vision, and with the signs of anterior chamber cells and vitreal cells.
ये तो खा लिया ना तुमने?
The mode of management of the two entities are
दही खाना
completely
है?
different.
खूब
In the
सारा दही
right
खाना,
perspective, it was
रायता बनवा लो।
endophthalmitis.
हाँ बनवा लो, मेरे लिए भी बनवा लो।
If it
उसमें
was
तीनों डालना है, पुदीना भी
endophthalmitis,
डालना है, बल्कि मैं तो कह रहा हूँ
then
वो
we have
मिक्स
to
चॉप वाला रायता बनवा लो, टमाटर प्याज खीरा।
antibiotics, and if it is in case of uveitis, then we have to go for the management of steroids and immunomodulators. So meanwhile, we started the patient on oral antibiotics with tablet ciprofloxacin 500 milligrams PD with paracetamol, and postoperative medications was continued. And we underwent and we asked the patient to get the investigations done. So the patient came after 2 days. The best correction visual acuity was still counting finger 2 meter. The slit lamp and fundus was status quo. It was no worsening was seen. It was as it was it presented 2 days before. And in the investigations, only serum ACE was positive, while MAN2, quantiferon TB, the viral markers TPHA all came out to be negative. We also advised the patient to get an HRCT done. So we saw that there was no worsening. The status was same as that of the last presentation. So we started on tablet prednisolone 60 milligrams OD and continued the same tablet antibiotic ciprofloxacin 500 milligrams BD, and the rest medications was continued as it was. But again presented on postoperative day 7, and we could see that there was a drastic improvement in the visual acuity, which was 636. And slit lamp examination, the cells also reduced from grade 4 to grade 2, and the fundus, the media haze improved from grade 3 to grade 2, and now we can see there was few peripheral vascular sheathing was seen in the right eye. The left eye was completely normal with a visual acuity of 612, and the fundus was normal with a cup-disc ratio of 0.3. Patient also came with the HRCT test, in which it showed there was a Cox sequelae was seen. On further asking to patient, then the patient gave the history of contact with the TB patient, which was his wife 10 years back. So FFA was planned for the right eye. So we can see in the subsequent FFA, there was vascular sheathing and leakage was, there was vascular leakage was seen associated with CNP areas in the periphery in the right eye, while in the left eye, the FFA was completely normal. So we finally made a diagnosis that it was a case of right eye tubercular retinal vasculitis and pseudophakia in right eye, and the left eye was senile cataract. So we continued the same treatment with tablet prednisolone 60 milligrams OD, tablet pantoprazole, tablet calcium was further added. Now here comes the question that should we start antitubercular therapy or not? So we have a very good study, COTS2 study, which gave us the guidelines for starting a treatment of antitubercular therapy or not. They made a consensus and they made a calculator, which is called as a COTS calculator, which was efficient and low cost evidence-based tool, which helps us and to guide to start the ATT or not. So we put all the details of our patients in the COTS calculator, and we found that the median score was 3 and interquartile range was 3, which indicated that the median score 3, that there was a mixed probability to start ATT or not, while interquartile range with of 3 gave a poor consensus that less than 60% of the expertise agreed on starting of ATT. So we didn't start on ATT, and we advised the patient to continue on tablet prednisolone. So tablet prednisolone was continued, and patient was advised to follow up after 1 week. So now we see that there was drastic improvement of the visual acuity, which was 624 in the last presentation to 612 with pinhole. And slit lamp examination, the anterior chambers cells also reduced, the media haze improved to grade 1, but peripheral vascular sheathing was present, but which improved from the last visit. So we advise the patient to continue on to tablet prednisolone in the tapering dose. So coming to the discussion part, we all know TB is it affects every 4th person on the planet. Ocular TB has very uncommon manifestation. The incidence is about 1.4 to 1.8, and clinical manifestations, it includes from anterior to posterior, from anterior granulomatous uveitis to posterior choroiditis or retinal vasculitis. Vasculitis is mostly type 3 hypersensitivity reaction, which occurs to the blood vessels, which we see as which results in vascular occlusion. So there has been studies to find out what should be the treatment of vasculitis. There has been a meta-analysis in 2016 with 1917 participants, which concluded with 84% of ATT, there was no recurrence. And we have a very famous COTS1 study, which was the first multinational analysis for tubercular uveitis. It did not conclude anything, but it was the baseline for further studies which has to be done. And there was still a lack of any RCTs for the treatment of ocular TB. The similar studies also used ATT along with oral steroids, but there was no significant difference as we can see in both the studies, and there was treatment failure found in the COTS-1 study. So still to address the uncertainty of management of ocular TB was there. So COTS group, which found out the COTS consensus, which we have already seen in the past slides. And finally, they made a guideline for starting of ATT or not. So coming to the conclusion that the diagnosis and management of ocular TB is a significant challenge. There is a heterogeneous clinical manifestation, and there is always a lack of agreement on diagnosis and management of ocular TB, but COTS consensus guidelines have helped us in initiation of ATT and helps to address the uncertainty in management. So thank you so much.
Ashmi and the other presenter, I request you and tell you that we'll give you first to alarm at 5 minutes, and then you have to start concluding your presentation, and 6 minutes we'll definitely would like you to stop giving your presentation so that we can have 2 minutes time for discussion. Also, the next presenter should be ready. Dr. Ikrani, you should start presenting your presentation.
Judges, please.
So Arshi, it was a wonderful presentation and excellently managed.
Thank you, ma'am.
Only one question from my side. What are the causes for late onset endophthalmitis? Post-operative?
First, ma'am, it could be lack of wound integrity. Second is like the patients are not using the medications properly. And third is also, ma'am, ocular hygiene is if it is not maintained.
I meant what are the etiological, the
Mostly, ma'am,
microbiological organs?
bacterial staph is known to be the most common causative organism for endophthalmitis.
For late onset, post-operative endophthalmitis.
But mostly it is the staph which is said to be the most common cause. Either it could be a fungal as well.
Okay. Thank you.
Thank you.
So I'd like to make a comment. First of all, Dr. Arshi, fantastic presentation. I think the whole idea of putting some points across, of not jumping into a surgical management in such a case is very important. Having made a diagnosis, being patient in the beginning, and making sure that the diagnosis doesn't go wrong. Is very important. The way you handled it was very good, doing the angiography later on and then dissecting it out. The discussion part also was quite admirable.
Thank you so much.
The next speaker is Indrani Chanakya. You ready?
Yes, sir. Yes, sir.
You're talking on the management of traumatic globe perforation and its final visible outcome.
Yes, sir. Am I visible, sir?
Yes.
बेटा
Yes, ma'am.
डोंट वेस्ट टाइम. जैसे स्लाइड तुम्हारा ऑन होगा, टाइमर उधर ऑन हो जाएगा. अभी टाइमर ऑन नहीं करिएगा, जैसे स्लाइड ऑन होगा तभी करना. रीना, when she will start, then only put on the timer.
Yes, ma'am. Is the slide visible?
I'm talking to
Yes,
Dr.
present.
Reena, the session coordinator, कि when she starts speaking तभी करना.
Yes, sure.
Is the slide visible?
देखो
No,
प्रेम,
doctor, it's not visible. Can you please
स्लाइड
share
नहीं
it?
दिख रहा उसका.
No, the slides are not visible.
अरे आप इंटॉर टीम.
Yes, ma'am, I'm there.
प्लीज देखिए इसकी स्लाइड क्यों नहीं चल रही है.
Dr. Endu, can you come to the Zoom window, please, first?
Yes,
Are
sir.
you on a phone?
Yeah.
Any chance you can change it to a laptop? Dr. Endu, any chance you can change it to a laptop, please?
Right now, I don't have.
You will have a share option on the Zoom window. Just click on that.
Yeah.
And you should be able to select the screen.
Display over other apps.
Yes,
all
you have to
allowed.
enable that. You have to enable that.
बैठे बैठे करते रहो. फोन लगाओ सब चेयरपर्सन. बेटा एक्सप्लोर लगाओ. इसके बाद वाला सेशन में आप चेयरपर्सन है। मेरे मोबाइल चलाओ।
Dr. Indu, do you
Isn't
need
the
time? No, it's still not visible. Do you need time so we can move on to the next presenter?
We can move on to the next speaker.
Are you ready? The first presenter was Dr. Ujjwal. Now you are able to connect. Can we take Dr. Ujjwal for presentation right now?
Yes, let me check once.
Yes,
Okay.
please.
Check your slides. In the meantime, can we see Dr. Sanvali for the presentation? Are you there, Dr. Sanvali? This is Dr. Ujjwal. Dr. Ujjwal, slides are visible.
Yes.
हाँ बेटा, अब टाइमर ऑन कर दो रीना।
It's visible, Dr. Ujjwal.
Dr. Ujjwal is talking on observative use in the unusual presentation. So,
yes.
Dr. Ujjwal,
Good.
Please, आप लोग बोलिए टाइमर स्टार्ट्स।
Time start now.
Yes.
Good morning, everyone. My topic is ocular TB. A 67-year-old female came to our OPD with blurring of vision in right eye since 1 week, which was gradual in onset, progressive in nature, and was associated with redness and pain. She was a known case of diabetes and hypertension from 5 years, and family history, personal history, allergic history, and drug history are not significant. The general examination, systemic examinations were normal. Coming to the local examination, her best corrected visual acuity in the right eye was 636 and 612 in the left eye. Rest, all external features, Hirschberg corneal reflex was central. Coming to the slit lamp examination, there was corneal opacity from 6 to 10 o'clock in the right eye. Cells 3 plus was, and Van Herrick's grading 4 was there. A broad posterior synecdoche was seen from 2 to 5 o'clock, and NS4 cortical 4 cataract was seen. Left eye was within normal. The fundus was hazy due to vitritis, and the rest features could not be commented. Left eye, the cup to disc ratio was 0.3, and rest were normal. And fovea reflex was present. So we made a diagnosis, provisional diagnosis of right eye panuveitis and both eye senile cataract. We investigated serologically for RBS, CBC, and ESR, and MONTU, VDRL, HRCT chest, and quantiferon TB was advised. We started her on treatment, prednisolone 1% every hour, homide 2% 3 times, and moxin for 4 times. In the follow-up, her best corrected visual acuity was still 636. Slit lamp examination, the cells grading came down, and the fundus was still hazy. Her CBC reports were normal. RBS was normal. The ESR first star was raised. MONTU came out to be positive, and quantiferon TB test came out to be positive. The VDRL was negative. The HRCT came, there was no evidence of Koch's pathology or sarcoidosis. So we also started her on tablet prednisolone and calcium and pantoprazole along with it. Now, what is the final diagnosis? Is it tuberculosis choroiditis? So a study has showed that PCR for various types of choroiditis done by Jyotirmay Vishwas, Mohammed Salman Qazi, have concluded that eyes with choroiditis with suspected TB origin should be subjected to PCR for diagnosis for TB. So we advised her for real-time PCR, and which came out to be negative. And so ATT was not started, only tablet mycophenolate mofentil was started, apart from the rest of the drugs. In follow-up, as we can see, there is some corneal opacity from 6 to 9 o'clock. There is broad posterior synecdoche in the right eye. The left eye was normal. In the fundus, there are some.
One second, we can't see anything.
Yes.
We can't see anything. We can see just some iPhone. Yes, we want to see the pictures, the slides, the fundus photos that you're talking about.
Is it clearer?
No, it's not.
Somebody's screen is actually showing.
Indu is sharing screen, I think.
Yeah, Indu
So
sharing
stop
screen.
sharing. Stop sharing screen.
Is it visible?
Not yet.
No,
It's
not yet.
frozen. It's frozen. It's somebody's phone that's being shared over here.
Yeah, it's showing Ravi Jha. Some Ravi Jha screen is, I think, showing over there.
Sir, we can switch the screen, sir. On the top, we can see two options, Ujjwal screen or Hindu screen. So we can click on Ujjwal screen, then it's visible.
Okay, got it.
Okay.
Can you go back to the pictures of this patient?
Yes.
We missed seeing that.
1 second.
No, good
Can you
afternoon.
next?
हाँ बेटा अभी केस प्रेजेंटेशन हो रहा है इसके बाद फैकल्टी से शुरू होगा केस फैकल्टी
Is it visible now?
Yes.
Okay. So in the fundus in the right eye, the media is decreased. We can see inferiorly some whitish exudates, and the left eye was normal. So as we can see, like ocular TB can be extraocular or intraocular. Extraocularly, it can cause proptosis, chemosis, headache. In the eyelids, it can cause chalazion, lid abscesses, phyctenular keratoconjunctivitis, and interstitial keratitis can be seen. If it is intraocular, mostly intraocular is only seen anterior uveitis like granulomatous uveitis, and posteriorly choroidal tubercles or serpiginous choroiditis can be seen. Endophthalmitis is also seen. It can also affect the cranial nerves, causing palsy. Thank you.
So what is your final diagnosis?
Ma'am, my final diagnosis is ocular TB, but as we can see, the PCR came out to be negative. We can not confirm it. It is only a presumptive diagnosis. So we didn't yet start her on ATT.
Ujjwal, can you stop screen sharing, and we'd like to see you as well. So again, so the diagnosis of tuberculosis is always presumed. That is the whole reason it's called presumed ocular tuberculosis.
Yes, sir.
One disappointing thing was that you haven't shown any pictures. You well presented for a first-year resident, but we haven't seen any pictures of the patient at all. So it's always
Sir,
Fundus photo was there.
the patient didn't agree on means clicking photos of her, means it was a bit difficult.
Okay. Yeah, the photos, I think those photos were representative photographs from another
Yes,
institute. isn't it?
yes,
Shankar
sir.
Netralaya.
Yes, sir. Actually, we had advised her, and then they went there, and when they came back, they showed us the reports.
Okay, so those pictures are the patients. Okay.
Yes, they are of the patient, sir.
लास्ट का पेशेंट अनाउंसिंग करो ताकि जल्द से जल्द कर दो
Are you ready?
If
Yes, sir.
Okay. Our next speaker is Indrani Chanakya. She is talking on management of traumatic growth preparation and its final visual outcome. Please share the slide.
Yes. Is this visible, sir?
Yeah, now it's
Good
visible.
afternoon. Yes, sir. Good afternoon, respected seniors, colleagues, and my dear juniors. I am Dr. Indrani Chanakya, JR second year from the MGM College and Hospital, Jamshedpur. Today I am going to present a case on traumatic globe perforation. My guide is Dr. M. Jamal, sir. My case is about a 26-year-old male carpenter by profession living in Jamshedpur, Jharkhand, presented to the hospital with chief complaints of sudden diminution of vision in the left eye. So the figure is showing complete grade 4 hyphema of the left eye compared with the normal right eye at day 1. He complained of moderate pain, redness, sudden painful diminution of vision, history of penetrating trauma with a nail in his left eye while he was working in a company as a carpenter worker, following which he came out came to our hospital emergency and was admitted to the eye ward where he underwent medical as well as surgical treatment. His personal history included mixed diet, normal appetite, normal bowel and bladder, and no ill habits, normal sleep pattern, and no known allergies. No history of diabetes, hypertension, asthma, heart disease, or not on any medications. No history of significant vision loss in any of the family members. Patient was conscious, cooperative, and well-oriented to time, place, and person, well-built and nourished. Afebrile, pulse 86 per minute, regular in rhythm and volume, measured in right radial artery, BP 126/80, mmHg in left arm, sitting position. Respiratory rate was 14 per minute and known pallor icterus, cyanosis, lymphadenopathy, or edema. Head posture normal, ocular posture normal, facial symmetry symmetrical. This figure shows complete hyphema on day 1. Visual acuity in right eye was 6/6. Left eye, it was perception of light positive and projection of rays doubtful. Extraocular movement, full and free in both eyes. Lid and adnexa was normal in both eyes. Conjunctiva clear in right eye, and left eye there was congestion, globe perforation at the limbus. Cornea was clear in right eye, and left eye it was hazy. Anterior chamber depth normal in right eye, and left eye grade 4 hyphema, sedal cyst was positive. Iris pupil lens was not visible due to grade 4 hyphema. Macula foveal reflex periphery not visible due to grade 4 hyphema. And we gave some investigations like X-ray orbit left eye, then ultrasound based with the B-scan examination left eye showing some vitreous hemorrhage but no signs of retinal detachment. Routine investigations included BT-CT, hemoglobin percentage, TLC, DLC, CBC, blood sugar, HIV, HbS, Ag, and anti-HCV. Ultrasound B-scan, very gentle report was given on day 2 of the trauma. Vitreous showed multiple dot and membranous echo suggesting vitreous hemorrhage. Retina was attached, choroid mild thickening, and optic nerve shadow within normal limit. Intraocular pressure recorded using short tonometer at 2:30 p.m. on the day of trauma. So right eye 17 and left eye was less than 4. Medical treatment included injections of tetanus, perinom for nausea, and clopar for analgesia, gentamicin IM to decrease the risk of endophthalmitis, antibiotic eye drop ointment, antifungal netamycin 5%, long-acting cycloplegic like atropine 1% to decrease IOP, syncytial eye development, adenoid photophobia, and the risk of secondary bleeding. Tablets included cefixime, Dilona, Omaze, multivitamin, Visalone on tapering dose, black goggles was advised, and elevate the head to 30 degree was asked. Slit lamp photo included the fibrin, shows fibrin on nasal side of the pupil on 5th day after starting eye drop, prednisolone acetate, 1% 6 times daily from the 3rd day. Surgical treatment, excision of the prolapsed iris done with repair of globe with 3 mattress 10-0 ethylon suture to fix the iris root at 1.5 mm from the limbus at superior nasal position from 9 to 12 o'clock position, done under the periverbal anesthesia. Air in anterior chamber with subconjunctival injection of gentamicin and Dexona was given. Post-op management included injection gentamicin, perinom, clopar, Dexona, paracetamol, Ciplox, vitamin B complex, Rantac, and Nipafinac eye drop. This is the picture showing 10-0 ethylon suture post-surgery 6th day. The figure shows post-surgery slit lamp examination on 12th day. Figure shows globe perforation superior nasal at limbus after suture removal in follow-up session 38th day. The figure shows iridodialysis and fibrin clot resolved on 3 months, 9 days of the follow-up. And follow-up on the 110th day, that is 3 months, 19 days, slit lamp examination showed iridodialysis present but fibrin resolved. Schirmer's test, right eye 15 mm, left eye 23 mm, visual acuity OD 6/6 and OS 6/9 partial. Then refraction was done and it came to be 6/6 in both eyes. So the diagnosis, traumatic hyphema, grade 4 with globe perforation, left eye, which was treated successfully. Thank you.
What do this?
One question. Did you give any intracameral antibiotics?
No, sir. No intravenous.
I think if it was a
Judges for question.
Indrani, I have
Yes,
few
sir.
questions to you. You said PR projection of rays was doubtful. What does that mean?
Yes. So the projection
How
of
did it?
rays in the four quadrants,
Yeah.
the patient was unable to give the direction from where the light was coming. So it was doubtful at that time.
PR check, the checking for projection is standardized by endovitrectomy study. And so you should never write doubtful because that will land up you in legal trouble. You should mention whether projection results accurate or not accurate, if accurate in how many quadrants, right? And second, you said Siddle test was positive. In spite of that, you started prednisolone acetate 1 hourly preoperatively. What was the rationale for that?
So on the third day it was started prednisolone.
Preoperatively, right?
Yes, sir.
So would it increase the risk of infection if there is a perforated cornea and uveal tissue is out and you start prednisolone acetate 1 hourly? Would it increase the risk of infection? Because in perforating injury, we are a little bit scared of fungal infection.
Yes, sir.
So I think that part could have been avoided because unless until you repair it, then what's the point of? And why that positioning, 30-degree positioning of for the patient was given?
To resolve the hyphema, it was grade 4 hyphema.
And last question, what is the source of bleed in your patient?
Sir,
The
most
theoretical
probably the
question.
ciliary vessels.
Ciliary vessels? No. Go back and do search. It'll message me. Okay. So what is the source of bleed in all these cases? Any other judges?
I just a suggestion to all the participants for case presentation. I think it is better to draw hand diagrams because in exams you have to make handmade colored diagrams. Showing pictures is okay, but hand diagram should also be there. And second, in your case, when was the surgical repair taken?
I'm on fifth day.
Why?
One
What
week.
was
Yes.
the reason for waiting for 5 days?
I'm the grade 4 hyphema.
The tear repair is an ocular emergency. It should be done the time patient presents to us. And we should
And I
not wait
think,
for.
ma'am, I think there was iris incarceration also there. There was through the wound. So
yes,
yeah, so it would have been better if you had given an intracameral antibiotic also if at the time of repair.
Did you excise that iris or excise that iris?
excision. Yes, sir. So excision of the iris.
Abscission.
Yeah.
That's good. Okay, I think we can move on to this week.
May I have a few comments, please? I'm Dr. Kashyap.
Oh, sure.
I heard that you talked about JHOS tonometry. That
Yes, sir.
should not be done. Number one. Number two, if the perforation is there, you must take the history properly and the how the injury occurred. And on a slight doubt, you should get a CT scan done in perforated injuries. Number three, you have to take a good precaution while doing a peribulbar injection. You know what? You have to give the injection very, very slowly, so that the content of the eyeball does not come out. These three things are very important. Okay. And repair, of course, repair as early as possible. Thank you.
Okay.
Dr. Indu, I would like to make a remark. Means like, what is your diagnosis? What is your final diagnosis for the case?
Ma'am, the traumatic hyphema with globe perforation was there.
No, globe perforation, why? Isn't it, you didn't do it according to the, you have to do it according to any OTS study or Birmingham, anyone, but you have to write all the type of injury. It's not perforating in your case, it is penetrating, right?
Yeah.
So that is very important, as right now your diagnosis, if it goes wrong, it's very difficult for you in the exam. Okay.
Next speaker is Dr. Sanwali. He is a second year diploma student and he is talking on BRBO with Assistant macular edema. Dr. Sanwali, are you ready?
Okay, Sanvali.
Is not there.
Sir. Sanvali,
Okay.
you are ready with the presentation. Can you start?
Yes, sir. 2 minutes. Yes, sir.
This would be ready with the presentation. You should go to the next one. Okay, share the slide. The time to start.
44-year-old male, senior by senior by octopus, residing in Katatoli. He came with sudden paleness, diminution of vision, noticed by patient for about 7 days back. Patient was hypertensive.
Your voice is not clear.
Dr. Sanvali, can you
Yes.
keep nearer to you?
Can you hear, sir?
Now it is better. Now you can start the presentation.
Yes. 44-year-old male by occupation senior clerk residing in Karatoli came in JHOS with sudden paleness, diminution of vision, noticed by patient about 7 days back. Patient was operated normal 7 days back. Then he noticed suddenly paleness, diminution of vision in the right eye. Left eye was normal. There was no history of redness, pain, discharge, watering, photophobia, glares, halo, trauma to the eye. There is no history of frequent changing of glass. Patient was hypertensive about 8 years ago. He is on medication on Temsar AM 2 times, but he was not taking medication regularly. There was no history of diabetes mellitus, blood transfusion, coronary artery disease, asthma, no history of hyperlipidemia, any other renal disorder, no any history of bleeding disorder. Family history unremarkable. Past surgical, there was no ocular surgery was done. Personal history, he was history of smoking or tobacco user. History of taking antihypertensive since 8 years. Personal history, except smoker and alcoholic, type was normal. Systemic examination was done. Except blood pressure. Blood pressure was very high, 170 by 80. Other systemic examination was normal. Ocular examination was done. Uncorrected visual acuity was in right eye 6 by 36, left eye 6 by 6. Best corrected visual acuity was 636, left eye 6 by 6. Near vision plus 125 duster and 12. And in the left eye 125 days, but near vision was 96. IOP done by application tonometry. In right eye 18 mmHg, left eye 18 mmHg. Ocular examination, external examination was normal. Slit lamp examination was done. Eyelid was normal. Conjunctiva, sclera, cornea. Iris was normal color pattern. Anterior chamber normal. Pupil reacting to the light. Direct and consistent was pattern. Lens was clear. Fundus examination was done by indirect ophthalmoscopy. Right eye media was clear. Disc normal in size, vertically oval tip. Horizontal oval disc, pink in color, well-defined margin. CDR 0.4, healthy neuroretinal limb. Vessels arising from the center of disc. Branching dichotomously. Dilated and tortuous veins were there. Macula in right eye, fovea was there. In left eye, fundus examination was normal. Right eye background retina. Multiple streak-shaped superficial red dull lesion was present. Signs of resolved fans of hemorrhage in supraretinal artery. And edema noted in macular area, suggestive of cystile macular edema. Left eye appears normal. Fundus examination undone by OCT examination because indirect I couldn't able to take the photographs. So I took the photograph from OCT. Provisional diagnosis: right eye branch retinal vein occlusion. As dull red lesion was seen, resolved frames of hemorrhage at supratemporal quadrant with cystoid macular edema. DD in the favor of BRPO, hypertensive patient, branch retinal vein occlusion, unilateral, sudden painless dimness of vision, flame-shaped hemorrhage in the supratemporal quadrant, torsity of vein. And in the favor of hypertensive retinopathy, sudden painless dimness of vision, In against, it is always bilateral, congested retinal vein, copper wiring arterioles. Hemorrhage are not confined to the one sector. Non-ischemic CRVO. In the favor of dilated and tortuous well, sudden painless dimness of vision. But against hemorrhage in all quadrant, ocular ischemic syndrome, it always unilateral, dilated retinal vein, but is gradual visual loss. Anterior segmental involvement is more common. Periorbital pain will be more. No torsity of vein. This is the diagram of showing PRBO, CRBO, and ocular ischemic syndrome. Investigation, OCT macula was done. CBC was done. Lipid profile was done. Lipid level was high. As we noticed, total cholesterol was 250 milligram. LDL cholesterol was 90 milligram. And HDL cholesterol was also 50 milligram per deciliter. Triglyceride was high, 250 milligram per deciliter. Fasting BP was normal. PTINR was normal. ESR was normal. UDA electrolyte was done to rule out any renal disease associated hypertension. Plasma oxygen level was normal. Thermophilic factor was done. OCT was done on 5th April. Then you can see the cystoid macular edema was there. On the then we planned intravitreal eccentric injection. Then second OCT was done on 3rd 5. Then again we can see that superior malcombrate hemorrhage is more clearer. And then third dose was given. Scheduled third dose of anti-VEGF. On OCT examination was found that patient was developing cystoid macular edema again. Then further again intravitreal ranibizumab was given. And then both on fourth follow-up, OCT macula was done. Then we can inferior temporal hemorrhage with cystoid macular edema was found. Patient was referred to Shankar Netralaya. And then right eye sectoral laser photocoagulation with intravitreal ranibizumab was given. Then patient again came to the JHOS on 27/9/2024, and then we did the OCT, and there is improvement in the inferior temporal hemorrhage and also in cystoid macular edema also improved. And the visual acuity on the third, it was 6/36. Then again 6/12. Then again 2/60. Then 9/9 6/12. Now came to the discussion of the VRBO. Branch determined occlusion. This is usually happen in the people who are aged 40 and older. We will have the following at risk of branch determined occlusion: hypertension, glaucoma, diabetes, hyperlipidemia, blood coagulation disorder, hyperhomocystinemia, hardening of arteries. VRBO is the most considered result of compression of the vein at the AV crossing. As AV crossing is more in the superior temporal quadrant, so VRBO is more common in the superior temporal quadrant. Then pathogenesis, compression of vein at the AV crossing, degenerative changes of the visual wall, abnormal hemorrhagic factor. This all leads to the retinal vein occlusion, stasis, increasing the pressures, either due to intraretinal hemorrhage, macular edema, NTG permeability, ischemia hypoxia, leads to neovascularization. Investigation normally slit lamp, OCT, FFA to know the area of ischemia. Visual field should be done to rule out which area, which cardiac or cardiac is involved. Management depends on the systemic conditions such as hypertension, diabetic mellitus, hypercognitive status. Manage macular edema with intravitreal anti-VEGF. Manage neovascularization with sectoral laser photocoagulation. Manage vitreous hemorrhage with pars plana vitrectomy. Thank you.
Take on the time. Yes, please, for the question.
Okay, can I put up one question, please? Dr. Sabri, while you were treating the superotemporal BRBO, consequently, like in subsequent follow-ups, the patient presented with an inferotemporal BRBO, right?
Yes.
So, and the age of the patient was only 44. So,
yes,
what are the systemic risk factors that you laid emphasis on and tried to manage? That is
depending on the patient. Depending on the patient, if it is a woman, so OCP usage can be asked. And anemia, hypertensive, diabetes mellitus, then hypercognitive state.
Yes, so that has to be taken care of because he was only 4 and was showing first superotemporal, and then consequently he came up with inferotemporal, right?
Yes, ma'am.
Okay.
Is there any question?
We can take next presentation.
So next,
Thank you, ma'am.
Priyanka, Dr. Priyanka.
Yes, ma'am. Yes, ma'am. Good morning, ma'am. Hello.
Priyanka, ready?
Good morning, ma'am.
Okay. The first year, DMT students consists here, seal top on diabetes mellitus with clinically significant macular edema.
Yeah, Mr.
Yes, slide, please.
Yes, sir.
The slide is not visible. The presentation is not visible.
Sir, I can't hear you.
Priyanka, can you hear us? Is it clear to you?
I'm not getting your voice, sir.
Unmute yourself. Unmute yourself.
Can you share your slides? Now it is.
I'd like to add one thing in the last paper, that OCT tells you about the swelling, the FFA tells you about the site of FFA tells you the site of obstruction, but whether after the obstructions there is ischemia or not ischemia, the FFA doesn't tell you. So in such cases, the ERG tells you whether ischemia has happened or not. If there is no ischemia, you can predict about the visual acuity that will improve or not. So ERG is very important in such cases. I know many people places they do not have this, but it's a very, very nice tool to predict about the visual acuity after the absorption of the edema.
The ERG is not available in my place, so I could not find the ERG, sir.
But FFA also tells
Also
about
required.
ischemia.
Actually, patient has been referred to certain neurology, because we don't have facility of FFA and ERG. Something right.
There are two people logged in. There is an echo which is coming. Better to go for this later. Okay, Priyanka, you can start. Dr. Priyanka, are you audible? Can you please continue, doctor?
All cases, case presentation is done.
We have just finished with the 4 and we are proceeding towards 5. Dr. Priyanka, can you start? Yes.
Hello, ma'am.
Yes, doctor, it's visible. Can you please make it full screen? To slideshow. Go on slideshow. Dr. Priyanka, we are not getting the slideshow screen. It is, we are able to see all the slides.
Hello.
Yes, doctor.
क्या?
Present Priyanka.
हाँ किए.
Start your presentation.
मैम आवाज नहीं आ रही है.
You start your presentation. Your slides are visible.
Okay, ma'am. Okay, ma'am.
Doctor, you can start the presentation, please.
Okay, sir. Okay,
Dr. Priyanka.
Yes, sir.
Please start the presentation.
Yes, sir. So, a 45-year-old male patient presented to ophthalmology OPD of Gandhinagar Hospital with complaint of sudden painless loss of vision in right eye more than left eye 1.5 years before. Chief complaint. Sorry. सॉरी कहाँ चला गया यार? Chief complaint diminution of vision, right eye more than left eye. History of presenting illness. The patient was apparently asymptomatic 1.5 years before. Then he developed gradual loss of vision in right eye. There is also a history of distorted vision in right eye. Past history, patient have diabetes mellitus since 10 years and no history of renal disease and anemia and any history of trauma. Personal history, patient is a known case of diabetes mellitus and is on medication, anti-diabetic medication. There is no history of hypertension or any other chronic illness. Family history, there is no history of diabetes mellitus, hypertension and hyperlipidemia in his family. Visual acuity at time of presentation 6/60 in right eye, which is not improving on pinhole, and left eye 6/18 partial, which is improved to 6/9 partial. An external examination with slit lamp, an external examination, right eye and left eye both are symmetrical on both sides, facial symmetry, external face normal in both sides, head posture normal, ocular alignment normal in both eye, ocular position normal, eyelid flat in both eye, conjunctiva in right eye congested, left eye normal, sclera normal, cornea hazy with mild severe edema in right eye and mild edema in left eye, iris normal pattern and normal color in both eye, anterior cerebral normal depth, pupil round and reactive to light in both eye, lens normal in both eye. Fundus examination, media clear in both eye, disc regular and margin, NRR normal, CD ratio normal within range 0.3 to 0.4 in both eye. Here is a history of painless loss of vision, so my differential diagnosis will be central retinal artery occlusion, central retinal venous occlusion, macular edema due to venous occlusion or diabetic macular edema, retinal detachment and vitreous hemorrhage. On OCT examination, there is a significant thickening of the macula in right eye with cystoid space and subretinal fluid. After this finding, we are planning to give anti-VEGF, which are given in my hospital, injection ranibizumab. Based on the clinical history taken and relevant clinical examination, most probably this is the case of clinically significant macular edema. Clinically significant macular edema is detected on clinical examination as defined in the ETDRS. Criteria for CSME: a retinal thickening within 500 micrometer of the center of the macula, exudate within 500 micrometer of the center of the macula if associated with retinal thickening. Thickening itself may be outside the 500 micrometer. Retinal thickening, third criteria will be retinal thickening one disc area 1500 micrometer or larger, any part of which is within one disc diameter of the center of the macula. So, treatment of CSME will be Avastin, Eylea, and Lucentis. Anti-VEGF medication help to reduce the swelling of the macula, slowing vision and loss, and perhaps improving vision. DCDR.net protocol, I conclude that intravitreal ranibizumab more effectively improve visual acuity than focal or grade treatment for central involved diabetic edema. NET protocol T conclude that there are no difference in visual acuity at 5 years respective of whether aflibercept, bevacizumab, or ranibizumab is used in patient with maculopathy and visual acuity of better than 6/15. Aflibercept more likely to improve visual acuity than bevacizumab in those with vision of 6/15 or worse. After giving injection ranibizumab, 3 successive injection in our hospital. This is the OCT picture of right eye. Further, in December 2023, this is the condition of right eye. This fundus examination of right eye versus left eye. This is a OCT picture of left eye. Further, other than anti-VEGF, laser photocoagulation is also a treatment for CSME. Anti-VEGF therapy has replaced laser treatment for most cases. This remains a well-proven therapeutic option. It should be considered in case with off-center swelling, which can threaten the fovea. Focal diode or argon burn are applied to leaking microorganism aneurysm 500 to 3000 micrometer from the fovea and using a spot size 50 to 100 micrometer. Duration 0.05 to 0.1 second with sufficient power to obtain a grace reaction beneath the microorganism. Grid laser burn are applied to macular area of diffuse retinal thickening, treating no closer than 500 micrometer from foveola and 500 micrometer from optic disc using spot size of 50 to 100 micrometer and duration is 0.05 to 0.1 second. Modified grid include focal treatment to foci of leakage, usually microaneurysm. Sub-threshold micropulse diode laser also use pulse duration combined with a relatively longer interval, 5% duty cycle, allowing energy dissipation. This minimizes collateral damage to the retina and stimulating the RPE, retinal pigment epithelium stimulation. Intravitreal triamcinolone in pseudophakic eye. Intravitreal triamcinolone steroid injection followed by prompt laser is comparable to ranibizumab. This is a good option in pregnancy or in recent myocardial infarction. There is a risk of elevation in IOP and risk of cataract. Pars plana vitrectomy may be indicated when macular edema is associated with tangential traction from a thickened and taut posterior haloid. It has also been suggested that some eye without a taut posterior haloid may also benefit from vitrectomy. Clinically, a taut thickened posterior haloid is characterized by an increased glistening of the premacular vitreous face. CSMA not involving the center of macula, particularly where exudate threaten the fovea, may be treated with laser treatment in the form of continuous wave focal or modified grade laser photocoagulation. If available, subthreshold macular laser treatment, intravitreal anti-VEGF therapy, or an intravitreal steroid implant may be alternative for this indication. CSMA involving center of macula but with a visual acuity of better than 615 can be treated with aflibercept, Viveki, or ranibizumab. CSMO involving the center of the macula but with a visual acuity of 615 or worse and significant foveolar thickening should be considered for aflibercept treatment with initial induction using monthly injection for 3 to 6 months. An intravitreal dexamethasone implant is an alternative and may be considered in patient with absolute or relative contraindicated for anti-VEGF. In eye with PDR and coexisting DMO, ranibizumab or aflibercept treatment alone should be considered. Scattered laser treatment, pan-retinal photocoagulation continue to be the mainstay of pediatric treatment. Severe NVD without hemorrhage carries 26% risk of visual loss at 2 years. That is reduced to 9% with PRP. Before treatment, normal.
You are exceeding your time limit.
Yes, ma'am.
Please conclude your presentation. You have exceeded your time limit way back. Please conclude your presentation.
My patient is on clinical examination diagnosed as clinically significant macular edema.
Listen, doctor. What she is trying to say is that आपका presentation का time बहुत पहले खत्म हो गया है क्योंकि आपको उसमें बहुत ध्यान रखना होगा. So अभी आप खत्म करना पड़ेगा आपको presentation.
Okay, sir. My case is clinically significant macular edema.
Presentation. That is what she say.
I think Dr. Priyanka is not able.
Hello.
Can someone call her? Can someone call her?
Admin, can we miss?
Okay, judges question. Okay, judges, go for question.
So I don't think we'll probably take too many questions over here because it's, so the rest of the participants, please do keep a watch on the time. Your presentation time is 6 minutes, so don't overshoot it. One advice to you, doctor, excellently managed. However, you make sure that your slides are not as full. The next time you make a presentation, the discussion is brief. I wanted to ask you a few questions, but I think we'll move on to the next one. If the next person is ready.
Yes, sir. Okay, sir.
Dr. Priyanka, very brief,
Yes.
but I would like to give a very important point that diagnosis, you have not mentioned anything about the diabetic retinopathy grading. You cannot straight away only say it is CSME. You have to say that the diabetic retinopathy is in which grading, right? You have to mention anything. And the entire treatment depends on that. You were saying that there was vitreous hemorrhage in the eye, and why there was vitreous hemorrhage, what is the grading? It is a PDR in that case. So you have
Yes,
to
sir.
be.
It is PDR. Yes, ma'am. PDR with CSME.
You have to mention and you have to take in consideration PRP treatment, right? Only
Yes, ma'am.
anti-VEGF, you have to inform the patient that. So your diagnosis, if it is not complete, and the eye you have not mentioned properly again and again. So you have to be very, in exam, you have to mention the eyes, the diagnosis has to be complete. Okay?
Yes,
And
ma'am.
Priyanka, you mentioned about the corneal edema, right? So why should it happen? So anyway, let's proceed to the next paper.
That way exceeding our time limit. So next presenter is Payal Sarkar. Dr. Payal, you should be ready with your slides. And I would request all of you to please stick to the time. 5 minutes, we are going to give you first alarm, and 6 minutes, you have to stop it.
Otherwise, you get negative marks.
Otherwise, marks will be deducted on exceeding the time limit, unless until there is some technical issues, okay? So, Dr. Payal Sarkar, please present.
Yes, ma'am.
Dr. Payal, are you ready?
Yes, ma'am. Am I audible?
Yes,
Yes,
you
yes.
are audible. Share your presentation.
Share your screen. Dr. Payal will speak on the retinatic screen. Okay, sir. Dr. Payal, you start the presentation. Share your slide.
Is it visible?
No.
Am I visible now?
Yeah. Your slide. Yeah. Your presentation, your time start now. You can start.
Yes. I'm Dr. Payal Sarkar, CCL Gandhi from CCL Hospital, Gandhinagar. I'm going to present a case. So my patient is a 60 years old female homemaker presented to our OPD with a complaint of diminution of vision in both eyes since past 20 years. History of present illness. Patient was apparently well more than 20 years ago, following which she gradually developed painless diminution of vision in both the eyes, which gradually increased over the years. Previously, she had a history of difficulty in night vision only. Presently, she is able to see through her central vision and has no peripheral vision as such. She visited a local ophthalmologist and who suggested her diffractive correction. However, there was no noticeable improvement, and so she visited our institution. There was no history of pain, redness, watering, photophobia, floaters in the eye. Past medical history, no significant past history, no history of hypertension or diabetes, no history of any prolonged drug intake. Past surgical history, nothing, no significant past surgical history. Family history, there was no family history of night blindness. On general examination, the patient was alert, conscious, cooperative, and oriented to time, place, and person. No pallor, icterus, clubbing, cyanosis, or edema. Temperature was normal. 16 beats per minute. Respiratory rate, pulse rate was normal. Blood pressure was normal. All systemic examinations was normal. External examination, facial symmetry, symmetrical on both sides. External face normal, head posture was normal, ocular position was normal, and ocular alignment, CBT was central. On ocular examination, on visual acuity, without pinhole was 6 by 36 in the right eye, and same in the left eye. And the visual acuity with the pinhole was 6/18 in both the eyes. Pupillary reaction, round, regular, normal, and reacting to light in both the eyes. Ocular movement was full and free in all the directions of gaze in both the eyes. Ocular admixture was within normal limits. Ocular motility was full and free in both the eyes. Color vision could read all the plates in the Ishihara chart, and apprehension tonometry was 16 mm Hg in right eye and 18 mm Hg in the left eye. Ocular examinations, eyelids, conjunctiva, sclera, cornea was normal in both the eyes. Anterior chamber, deep and quiet in both the eyes. Iris, normal color and pattern in both the eyes. And lens, she was phakic in both the eyes, and early PSC was noted in both eyes. On posterior segment exam evaluation, media was cleared in both the eyes, vitreous was clear. Optic disc, CDR, vertical CDR ratio was 0.5, a healthy neurolateral rim, and no evidence of any NVT in both the eyes. Macular reflex was dull in both the eyes. Peripheral retina showed peripheral arterial attenuation and extensive peripheral bony spicules. This is the OCT photograph taken of the patient, which shows the OCT shows within normal limits, but there was significant thinning. And the fundus photograph showed a peripheral whitish yellow-white specks in the peripheral of the retina, but the macula was spared, and a significant arterial attenuation was present. The visual field was done for both the eyes, which showed a significant visual loss in both the eyes, and showed only tubular vision and ring scotoma. ERG facility is not available in our hospital, and we advised it to get it done by outside, but unfortunately we lost the patient to follow up. So my provisional diagnosis is bilateral retinitis punctata albicans. Thank you.
Please follow the question.
I find that you said that the patient's pupil is normally reacting and the patient's vision is almost 6/36 and all that. In such cases, an extensive case, I expect there should be an RAPD.
But no such RAPD was noted.
Okay, something unusual.
So how will you manage this patient?
Since it is a case of retinitis RP, so basically the patient is the main modality of is like counseling the patient about her condition.
Okay, and
like it is a progressive, like it is a progressive case with and her family counseling and her first degree, all the relatives and all the children should be like screened early for detection of any changes.
Also, you mentioned that the patient has PSC. What about
yes,
that?
ma'am. Since it was an early PSC noted and no such according to the evaluation, I think the PSC was not significant enough to cause visual diminution. So when it progresses,
the best corrected visual acuity is 6/18.
Yes.
So what was the cause of diminished vision, central vision?
Ma'am, I'm not sure.
Okay. Okay. Over to other judges.
Yes, ma'am.
Dr. Zayed, we are ready with your presentation. Dr. Zayed, the next presentation. Thank you, Dr. Payal. Very well presented.
Thank you, ma'am. Thank you, ma'am.
Dr. Zayed, you are up for your presentation, or else we can proceed with Dr. Vatsala.
I think Dr. Jayad is not there.
Dr. Vatsala,
Hello, good afternoon, everybody. Am I audible?
Yes, yes. Now, Dr. Vatsala Pawar is the first year MS student in the University in Sachi. He will present on the chemical injury of the eye. Dr. Vatsala.
A very good afternoon to everybody present over here, respected teachers, professors, judges, colleagues. Today I am here to present a case on the chemical injury in the eyes. My guide is Dr. Rahul Prasad, sir. A 29-year-old male, driver by occupation, resident of Ranchi, came to the RIMS emergency at 9 p.m. with the chief complaint of burning sensation in both the eyes, pain in both the eyes, watering in both the eyes, and redness in both the eyes since 12 hours after he got a chemical injury in his eyes 12 hours ago. My patient sustained a history of chemical injury from a fluid that splashed from his bike's battery on his face and eyes 12 hours ago. He complained of burning sensation in both the eyes since 12 hours associated with diminution of vision, which was sudden in onset and painful. It was associated with watering from both the eyes, photophobia, and redness. He washed his face and eyes with tap water and went to a local hospital in Ranchi. There he was examined and was diagnosed with both eyes corneal abrasion with limbal damage. He was prescribed some topical and oral medications and was referred to the higher center for further management. For this complaint, he visited RIMS emergency. He has no significant ocular history in the past, neither he has any significant systemic illnesses in the past, and no significant family history was found. My patient had normal appetite, normal bowel and bladder habits, no addiction to any known substances, and he belonged to lower middle class socioeconomic group. General examination. My patient was alert, conscious, cooperative, and well oriented to time, place, and person. My patient was of average build and fair in nutrition. The vitals are mentioned below. The temperature, he was afebrile to touch. The pulse was 66 beats per minute. Blood pressure was 110 by 70 millimeters of mercury, and the respiratory rate was 16 cycles per minute. He had no sign of pallor, icterus, clubbing cyanosis, lymphadenopathy, and edema. The systemic examination was within normal limit and no abnormality was detected. Ocular examination. His uncorrected vision in the right eye was 612, whereas it was 6:9 in the left eye, and the uncorrected and the best corrected were the same. The eyelid and adnexa showed lid swelling with upper eyelid abrasion in both the eye. For the right eye as well as for the left eye, he had chemosis with diffuse congestion, and the stain was negative in the right eye, but it was positive and on the medial side of the conjunctiva in the left eye. The cornea showed epithelial defect of 10 into 8 millimeters in the right eye, whereas it was 7 into 7 millimeters in the left eye. Limbal staining was present from 3 o'clock to 10 o'clock clockwise in the right eye, whereas there was no limbal staining in the left eye. All the other findings were normal, and the IOP by digital tonometry was normal. On fundoscopy, since it was a little corneal haze, so the media was hazy. The optic disc was normal in shape, normal in color, cup disc ratio was 0.4, and the margin was well defined, and the neuroretinal rim was healthy in both the eyes. Blood vessel was of normal caliber. The macula was, the foveal reflex was, could not be visualized due to the hazy media, and the periphery was within normal limit. This is the photo depicting the right eye as well as the left eye. Both are showing corneal defect, the epithelial defect. According to the Roper Hall grading, it belongs to grade 2 because the cornea was a little haze, but the iris was visible. Case summary, a 29-year-old male presented to the emergency with a history of chemical injury in his eyes 12 hours ago, associated with pain, watering, redness. Systemic examination was normal. Best corrected vision for right eye was 612 and left eye was 6:9. And he had chemosis with diffuse congestion in both the conjunctiva, and epithelial defect was seen in the cornea. Limbal staining was present in the right eye from 3 o'clock to 10 o'clock in the right eye, and the IOP was normal in both the eyes. The fundoscopy, the media was hazy. The FR could not be appreciated.
My differential diagnosis is acid chemical injury and alkali chemical injury. My provisional diagnosis is both eyes grade 2 acid chemical injury. Management, firstly, when he came, we gave thorough wash with 1 liter of ringal lactate in both the eyes, and eye drop prednisolone acetate 1% was prescribed in both the eyes to be instilled 1 drop 2 hourly for 2 days, followed by tapering doses. Eye drop moxifloxacin 1 drop 4 times was advised daily. Eye drop polyethylene glycol was advised 1 drop 1 hourly. Eye drop homatropin 2% was advised to be instilled twice daily. Eye ointment chloramphenicol and polymyxin B was advised to be applied at bedtime in both the eyes. Tablet vitamin C 500 milligram was asked to be taken 4 times a day for 14 days. And NSAID was told to be taken as and when he was suffering from pain. My patient was called for daily review for 6 days and then on the 15th day. And this is the picture taken on the 6th day. It shows some superficial punctate staining in both the cornea. And Goldman applanation tonometry showed that the IOP is 18 and 18 in both the eyes on day 6. This is the photograph of the patient on the 15th day, and everything became normal, only apart from the mild upper lid abrasion that was present in both the eyelids, and the IOP was 18 and 16 millimeters of mercury. Patient is currently under observation and on monthly follow-up. Thank you.
Excellent presentation. I have just one question. The last follow-up was on which day?
Ma'am, day 15th.
Day 15. So the cornea had completely healed in 15 days, and there was no reaction in the anterior chamber, and everything was normal. But in your management, you had written that the steroid was tapered in 7/7 dose, and it continued for so many days. Why?
No, ma'am. The point is that firstly, we gave a large dose of steroid, and on the initial day, we decided that we would taper it gradually. But because this is how it has to be tapered, but when we saw that the patient is doing good, we tapered it a little earlier. We decreased the number of days, as in like taper in every 3 days.
If the cornea is not epithelium doesn't heal in 7 days, then what will be the frequency after 7 days? If the epithelium has not healed in 7 days, then what will you do?
Ma'am, so firstly, I've read that since steroid can be given only for 2 weeks, because after that it has a detrimental effect to the cornea. So we can do amniotic membrane transplant after 2 weeks.
So that's the reason I'm saying the steroid, it has not to be given for so many days. We have to observe for 7 days. If the healing is not there in 7 days, we have to stop the steroid. Giving steroid for 7 days and tapering it for so long is not the protocol.
Okay.
So Vatsala, am I audible?
Yes, sir.
So Vatsala, there are few points. One, already steroid people have discussed, so no need to taper the steroid dose. You can continue with QIDO 6 times for 7 to 10 days and then stop. That is one. And second, I saw you were giving polypropylene glycol, I think, as lubricant. So normally in chemical injury, there is so much watering, you don't need any lubricant. And if you use a glycol formulation, that may hamper the effect of other antibiotic or drugs that you are using. So that can be deleterious. So normally we don't use lubricant 1 hourly because patient will have a lot of watering, that itself will take care of that. And one more thing, nowadays we don't use Roper classification. So it's better to use DUAS classification. Why? Because it has 6 grades and it is more flexible compared to Roper. And limbal involvement one should be careful about, because in your case I think there were 3 clocks are limbal involvement. So at times what happens, even if the epithelium heals later on, there may be breakdown. So you'll have to take care of that. And overall, I think it's fine. So you don't use sodium citrate or ascorbate at your setup?
No, sir. It's we don't use it at our setup. I know that it should be used, but since sodium citrate wasn't available, so that is why we asked him to take vitamin C orally 4 times a day.
Thank you.
Thank you, sir.
Actually, Vatsala, you should add doxy actually. Doxy 100 milligrams per day for 10
Yes,
days.
sir.
Because of corneal, the corneal reason for the doxy adding. What is the reason, Kevin?
So, doxycycline, or in fact any tetracycline, it inhibits the collagenolithic activity. So basically, the collagen could be formed easily.
We have very limited time limit constriction. So can we proceed with the next presenter, Dr. Ashish Bharti?
Thank you, Vatsala.
Thank you, sir.
Next speaker is Ashish Bharti. Are you ready?
Yes. Yes, sir.
Okay, the Ashish Bharti is the first year MS student of Rio in Ranchi, and he will present on the ocular surface squamous lymphoplasm. Okay, Ashish. Thank you.
Stop sharing and reset.
Can we start the presentation? It's already very late.
Yeah. Go in the slides. We should go for next speaker.
Sir, is it visible? Sir, my PPT is visible or not?
Yeah, it is visible. It is visible. Please start.
Yes, sir. Yes, sir. Good afternoon, everyone. I'm going to present a case. A 61-year-old male from Hazaribagh, Jharkhand, presented to Rio Rims IOPD with a chief complaint of mass in left eye conjunctiva since 4 months and redness in left eye since 4 months.
Change
History
your
of
slide.
presenting.
The slide is not moving. Ashish.
Slide is not moving. Change your
Yes.
slide.
Do the slides, Sona.
Yes, sir. Sir, is it moving now?
No.
Recall the slide.
Slide so right.
Yeah.
Yes, sir. A 61-year-old male from Hazaribagh, Jharkhand, presented to Rio Rims IOPD with a chief complaint of mass in left eye conjunctiva since 4 months, redness in left eye since 4 months. History of presenting illness. Patient was apparently asymptomatic 4 months back. Then he developed fleshy mass growing temporarily towards the cornea in left eye, which was gradual in onset, rapid progressing since 1 month, and was painless in nature. He also had redness and foreign body sensation in left eye, which was associated with diminution of vision. There was no history of trauma, discharge, watering, and other ocular complaints. Past history. He has no history of diabetes mellitus, hypertension, TB, and any other chronic illness. No history of significant weight loss. No history of chemo radiation exposure. Family history. No significant family history. Uh, Patient was on personal history. Patient was on mixed diet, non-alcoholic, non-smoker, bladder, bowel habits were normal. General examination. Inspection. Patient was conscious, cooperative, well oriented to time, place, and person. No neurological deficit seen. No skin lesion seen. palpation. Abdomen was soft and non-tender. No organomegaly noted. No palpable lymph nodes or skin lesion seen. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema. Vitals. Pulse rate was 80 beats per minute. Respiratory rate was 18 per minute. Temperature was 37 degrees Celsius and BP was 138 by 86 mmHg. Ocular examination. Patient vision of both eyes was 6 by 12 and best corrected visual acuity of right eye was 6 by 6 and left eye was 6 by 6 partial. Orbital margins were intact and intact on palpation of both eyes. Eyelid and adnexa was within normal limit of both eyes. Ocular movement was full and free of both eyes. Conjunctiva and sclerae mass seen on temporal aspect. Cornea was clear of both eyes. Anterior chamber depth was normal in both eyes. Pupils were round, regular, reactive to light of both eyes. Lens was NS2 of both eyes. Fundal glow was present and fundus was within normal limits of both eyes. IOP was 16 mmHg of both eyes. Description of the conjunctival growth. Mass in the temporal aspect of left eye appears to not be involving the cornea. It was leukoplakic lesion, 6 into 5 mm in size. Margins were not well defined. It was raised, freely mobile, superficial, soft in consistency, and highly vascular with feeder vessels present. There was no ulcerative changes. Takes up staining with rose Bengal stain. No preauricular, submandibular, deep cervical lymphadenopathy. Case summary. A 61-year-old male patient presented with a slow growing mass in the outer aspect of left eye since 4 months, with no systemic illness and no similar illness in the family member. On examination, his left eye showed a conjunctival mass in the temporal aspect, which appears not to be involving the cornea. It was a leukoplakic lesion, 6 into 5 mm in size, with freely mobile and highly vascular with feeder vessels present. Rest of the anterior segment of both eyes was within normal limits, and both eyes fundus was within normal limits. My provisional diagnosis on the behalf of history, examination, and investigation was left eye ocular surface squamous neoplasia. Blood investigation of the patient were within normal limits. My differential diagnosis: ocular surface squamous neoplasia, PANS, benign intraepithelial dyskeratosis, pingicula, pterygium, pyogenic granuloma, malignant melanoma, and nevi. Management. Treatment option explained to the patient. Choice of topical therapy versus surgical management. Patient opted for surgical excision. Surgical management, excisional biopsy, and medical management, immunosuppressant drug like mitomycin C. Histopathology report shows tumor cells arranged in nest or single cell within inflammatory stroma. Individual cells show large hyperchromatic nuclei with coarse chromatin and nucleoli. Impression was squamous cell carcinoma. This is my first off-day outcome showing diffuse conjunctival congestion, no remnant mass seen. This is seventh post-op day outcome. Congestion was resolved. Follow-up. I drop mitomycin C 0.04%, one drop 4 times, continued 1 week on and off post-op. Patient was advised to follow up once in 3 months for the first year and once in 6 months for the next 2 years. Thereafter, annual follow-up. Thank you.
Yes, for question.
So what precautions do you take when you are excising ocular surface neoplasia?
Ma'am, we took 2 mm of margin, 2 to 4 mm of margin while excising.
Okay, and any reverse cryo? Cryo
Sorry,
done at the margins of the excision?
No, ma'am.
Excise conjunctiva?
Cryotherapy was not given, ma'am.
Okay. What other drug can you use in place of mitomycin C?
Ma'am, we can use immunomodulators like interferon alpha 2 beta and ma'am 5-fluorouracil.
Oh, good.
So can I just come in? So 2 to 4 margin seems little bit on the lower side, right? So if you see the article by Shield, they recommend at least 4 mm of normal conjunctiva because that clears up. And in your case, you didn't use cryo, but ideally that should have been used because OSS is like a tree. So when you are doing save excision, you are just cutting the stem and the upper part, but the roots are still there and they might have spread beyond the clinically visible area. So if you are not doing cryo, it's better to go for a bigger margin of conjunctival normal conjunctival excision. So that would have ensured complete removal. But anyway, you continued mitomycin C. That's a good approach because if you are not doing cryotherapy, then I think you have to continue mitomycin for a longer period of time.
Yes, sir.
And did you close the defect? Because I think you didn't show the video. So what did for the defect that was created after exercise in the past?
Sorry, sir.
What did you do with the defect? Once you remove the mask, there must be a conjunctival defect, right? So what did you do with that?
Sir, we didn't close it, sir, with conjunctival graft or.
Okay, that is also one of the approach, but nowadays people are closing that because there may be a fear of local stem cell deficiency there. And if
Yes.
you one school of thought is you should keep it, leave it like that only because if there is any recurrence, then that will give you an easily identifiable site deficiency.
Yes, sir.
Thank you.
Yes.
Yes, speak.
Thank you, Dr. Ashish. It was very well presented. Thank you very much. Dr. Anamika?
Thank you.
Yes, ma'am.
Thank you.
Okay, Dr. Ashish, had you heard about Relicnor?
Yes, sir.
Have you heard about Relicnor?
Sir, interferon.
Relicnor drug.
No, sir. No, sir.
Okay. Next projector, Anamika Chaudhary. You ready?
Yes, sir.
First student.
Dr. Anamika, can you make it full screen?
Yeah, is it full screen, sir?
No, you have to make it on PowerPoint show mode.
Yes, sir. One second.
बॉटम में जो माइनस के साथ में आइकन है नीचे बॉटम में और उस पे
Okay,
क्लिक कर
I'll do that. Is it visible now?
डॉक्टर जो
Beta, you are switching on the, you're
माइनस
clicking
के
on
जो
the
लेफ्ट हैंड
zoom.
साइड पे जो आइकन है माइनस के लेफ्ट पे जो आइकन है लेफ्ट पे डॉक्टर हाँ जी
Yes. May I proceed?
स्टिल नॉट
But it's
About
not done.
to press that. Press that icon.
Click.
I've stopped it. You can reshare again. You should be good to go. आप दोबारा एक बार शेयर कर दीजिए. You can share the screen again, doctor.
Yes, just a second. Yeah, is it visible now?
Now make it full screen, please.
Yeah.
You need to make it full screen, PowerPoint show mode. The same icon what you have pressed.
Yes. Yeah, it's okay now.
No, actually not. But you can continue like this. I think it's not happening at your end.
Just a second, sir. Is it visible now?
Doctor, you have stopped the sharing. You have to screen share first.
Can you screen again?
Is it visible now?
Yes.
May I proceed?
Yes, doctor, please continue.
Yes. Good
Yeah,
afternoon,
perfectly.
Good afternoon, everyone present here. Myself, Dr. Anamika Chaudhary, first year MS Opthal student from Rio RIMS Ranchi. My guide is Dr. Sunil Kumar Sir, additional professor and HOD, Rio RIMS Ranchi. So, a 15-year-old female patient from Gola, Ramgarh, presented to the OPD with the complaints of diminished vision in both her eyes since childhood.
History of presenting illness. My patient was apparently asymptomatic at birth. Then her parents noticed whitish discoloration of her corneas. Patient experienced blurring of vision since childhood. She went to local practitioner and was managed conservatively. Surgical management was not done. There was no history of any pain or redness, no history of worsening of the symptoms in the daytime. Past ocular history, no history of trauma, infection, or any ocular surgery. Past medical history, no history of any systemic illness. Family history, no history of similar illness in the family. Birth history, normal vaginal delivery with no forceps injury. She belongs to lower socioeconomic group. General examination. My patient was conscious, cooperative, and well oriented to time, place, and person. She is of average build, pulse 72 beats per minute, BP 110 by 70 millimeter of mercury, and rest everything was within normal limit. Now coming to systemic examination, her respiratory system, cardiovascular system, nervous system, gastrointestinal system, everything was within normal limit. The main part, ocular examination. In right eye, the uncorrected visual acuity was FC half meter and the best corrected visual acuity was also the same. In the left eye, uncorrected visual acuity was FC 1 meter and best corrected visual acuity was FC 1 meter. IOP by Goldman applanation tonometer was 10 millimeter of mercury and 14 millimeter of mercury respectively. Globe position and size, normal in both the eyes. Written Arenexa was within normal limit. So coming to the anterior segment examination of the both eyes of the patient, as we can see from the diagram, there is bilateral diffuse grayish blue ground glass opacification extending from limbus to limbus, relieving no clear zones. There is bilateral increased corneal thickening in both the eyes. In the right eye, multiple bullae could be seen over the epithelium. Because of the poor visibility, the other structures could not be examined properly in the right eye, whereas in the left eye, the rest everything is within normal limit. So on fundoscopy, both eye media was hazy and so fundus could not be visualized. So my differential diagnoses are congenital hereditary endothelial dystrophy, congenital glaucoma, mucopolysaccharidosis, congenital rubella, Peters anomaly. Now here's a table which enumerates some points which are for CHED and something which are against the other DDs. CHED, of course, there is bilateral diffuse corneal haze extending up to the limbus with no clear zones, which is a very positive point. Points in against of congenital glaucoma again is there's increased corneal diameter, harp striae, raised myopia, and ophthalmos and congenital glaucoma, which were not present in my case. Mucopolysaccharidosis, as we all know, the systemic stigmata of MPS is very significant, which was not there in our patient. Congenital rubella can be ruled out because of the absence of nuclear cataract, raised IOP, posterior synechiae, meiosis, chorioretinopathy. Peters anomaly, again, in Peters anomaly, there is central leukomatous opacity with a normal peripheral cornea, but in our case, the entire cornea was involved. So, ruling out all the other options, we came to our provisional diagnosis as congenital hereditary endothelial dystrophy. So, the management options, we all know the definitive management options could be a penetrating keratoplasty or a posterior lamellar keratoplasty like DSEC and TMEC. In our case, because of the poor visibility, increased corneal thickness, so there could be an increased risk of damage to iris and the other lens structures. So we opted for penetrating keratoplasty in the right eye of the patient. So investigations were done. Her B scan was within normal limit in both eye and rest everything was normal. So we proceeded with our treatment management. So under peribulbar anesthesia, maintaining all aseptic and antiseptic measures, right eye PKP was done. Recipient corneal tissue was excised with a corneal trephine of size 7.5 millimeter and donor cornea with 8 millimeter. Donor cornea was sutured onto the recipient bed with 16 interrupted sutures using ethylon 10-0. AC was formed with air bubble and PNB was done. So this is an intro of photo. Post-op, she was given eye drop moxifloxacin dexamethasone 1 drop 6 times daily, eye drop brimonidine timolol 1 drop 2 times daily, eye drop carboxymethylcellulose 1% 1 drop 4 times daily, tablet prednisolone started with 40 milligram daily for 1 week and then tapered accordingly, tablet pantoprazole, tablet ciprofloxacin 500 milligram BD. So this is the post-op photo of day 7 of my patient. Right eye, we can see that the uncorrected visual acuity was finger counting at 5 meters. IOP was 12 millimeter of mercury. Graft was clear with few DM folds. Edges of the graft were very healthy. No infiltrates or reactions in the AC. 16 interrupted sutures intact. AC was well formed. Pupil and lens were normal. Post-op day 28 right eye, the uncorrected visual acuity was 660. IOP was 12 and rest everything was within normal limit. So this is my patient. This is the post-op photo of right eye PKP of congenital hereditary endothelial dystrophy patient. The patient is still under follow-up, and we have planned for a left eye DSEK of this patient. As in the left eye, the visibility is better, so we can go for that. So now coming to the discussion part, CHED, as we all know, is a bilateral corneal clouding characterized by cloudy cornea that may be present from birth or may be infantile in onset. As a consequence of the endothelial dystrophy, the cornea becomes edematous, which leads to degradation in the patient's vision. It could be autosomal dominant or autosomal recessive. Onset is often perinatal. When associated with sensorineural hearing loss, Harboyan syndrome, the gene affected is SLC4A11, which codes for a transmembrane protein from the bicarbonate transporters family. There is focal or diffuse thickening of Descemet's membrane and endothelial degeneration. Often there is blue gray ground with ground glass appearance to total opacification. This is a comparative table between CHED1 and CHED2. Thank you.
Yes, for question.
यहाँ पर है सर यहाँ पर वाला बेरी
So, why PKVP was planned in the right eye? Why not endothelial keratoplasty?
Ma'am, because the visibility was very poor. There was increased corneal thickness and the visibility was so less. This could lead to complications like there could be injury to the lens and the iris structures. So we planned for PKP.
Okay.
For the expectation. Dr. Nitish Kumar Marshall, are you ready? Dr. Nitish?
Yes, sir. Yes, sir.
Okay. Now, next lecturer is Dr. Nitish Kumar Marshall. He is the University from Ranchi, and he will present. Screen or slide.
Yes, sir.
Go on the slides. Let us go in slide so. Unmute. Unmute yourself. This is तुम्हारा आवाज नहीं आ रहा है. Unmute करो. Okay.
Dr. Nitish, start your presentation. Dr. Nitish, start your presentation.
Nitish, can you hear me? Nitish, are you in problem?
Your voice is not coming. Nitish, you are not audible.
Nitish, you are not audible.
Yeah. I think there must be some problem with the Dr. Nitish audio. So can we proceed with the next presenter, Dr. Komal Soni? Admin, can we proceed with the Dr. Komal Soni and then we can go back to Dr.
Yes, ma'am. Yes, ma'am. Am I visible, ma'am?
Yes, you are audible.
So admin, can we should.
Okay, ma'am.
Yeah. Nitish has to understand. You have to understand first.
Good afternoon, sir. Good afternoon, ma'am.
Please wait.
Dr. Nitish, please consider.
Nitish, you are in.
Stop yourself. Nitish.
IT team can unshare it.
Dr. Komal, are you ready? Dr. Komal?
Good afternoon, sir. Good afternoon, ma'am.
Yes, share your screen.
Share your screen, okay? Now, Dr. Komal, sorry, is the second year BG student from Rio Ranchi, and is talking on CSR. Share your presentation.
Doctor, who's presenting?
Komal Soni.
Dr. Soni, please share your screen, please.
Yes, I'm trying, sir.
Just press the share button on the Zoom. We were able to see your presentation. You stopped. Dr. Soni, are you able to share?
Yes, I'm trying, but not able to connect, sir.
Just go to the Zoom window, press the share button, green button, that's it. On the Zoom window, press the green button, share, which says share. Are you on the Zoom screen? Yes, we can see this. You can start, please. You can go to the first. Thanks.
Good afternoon, sir. Good afternoon, myself, Dr. Komal Soni, and my guide is Dr. Rahul Prasad, sir. I'm presenting a case. A 32-year male presented in RIMS OPD with chief complaint of diminution of vision right eye for 2 months. Patient was apparently symptom-free. Well, 2 months back, then he developed diminution of vision right eye, which was gradual, progressive, and painless. It is associated with magnification in irregular boundaries of image and diminution of vision, which is exhibited more on looking centrally. No history of type 1 diabetes mellitus, hypertension, trauma, COX, foreign bodies, sleep disturbance, gastrointestinal disturbance, diminution of vision right eye night, and use of any topical medication or any conflict between family members and friends. For this, he visited local practitioner where he got diagnosed in right eye central serous chorioretinopathy. For he was prescribed lifestyle modification and some topical medication, but not get relief. So he visited RIMS OPD for the same complaint. Past and family history. No significant past and surgical history was noted. No significant family history was noted. Personal history, patient is on mixed diet, regular bowel and bladder movement, adequate sleep of 8 to 9 hours, no addiction to unknown substances. On general examination, patient of average build and fair in nutrition, he was conscious, alert, well-oriented to time, place, and person. Vitals, temperature afebrile on touch, pulse was 76 beats per minute, BP 108 to 78 mmHg, no icterus cyanosis, clubbing, lymphadenopathy, and pedal edema was seen. On systemic examination, CVS, respiratory, abdominal, and CNS, no abnormality detected. On ocular examination, we have seen that visual acuity for right eye was uncorrected visual acuity was 636 and BCVA was 618 and left eye was 66. Position of head was within normal limit, both eye, eyelid and adnexa within normal limit, conjunctiva within normal limit, cornea clear, both eye, anterior chamber normal in depth, pupil normal in shape and reacting to light, both eye. Lens within normal limit, both eye. IUP was measured at 8-11 with gold applanation tenometry. 16 and 14 mmHg was observed. On fundoscopy, both eye good pupillary dilatation was done. We have seen that media was clear both eye. Optic disc vertical oval, CD ratio 0.3 and NRR was healthy in both eye. Blood vessels normal in caliber both eye. On macular finding, we have seen left eye FR present, on right eye FR dull, a round well-delineated localized elevation of macula, which is suggestive of serous macular detachment seen. Peripheral fundus shows tessellations. This is the fundus diagram of the patient. Left eye within normal limit and right eye shows retinal edema. My case summary is 30-year-old male with chief complaint of diminution of vision, eye for 2 months, which was gradual, progressive and painless. It was associated with magnification, irregular of boundaries, diminution of vision, aggravated more on looking centrally. On examination, UCVA 636 and BCVA 618, right eye plus 2 spherical diopter given. Fundoscopy examination shows right eye FR dull, a well-round, well-delineated macular elevation shows. My differential diagnosis is acute central serous chorioretinopathy, neovascular AMD, polypoidal chorioidal vasculopathy, dome-shaped maculopathy, optic disc pit maculopathy, VKH, and adult onset of foveal macular vitelliform degeneration. My provisional diagnosis is right eye acute central serous chorioretinopathy. I have done investigation of OCT of right eye. This is the OCT of right eye, which shows neurosensory detachment from RP and subfluid collection. My definite diagnosis is right eye acute central serous retinopathy. I have observed for 1 and 2 months patients. Thank you, Zan. Thank you, sir.
It is for question.
No question from my side.
So do you think the fundus rosine angiography is important in such cases?
Yes, sir. Obviously, but sir, patient didn't respond, sir.
Okay, what do you expect in such cases? What do you expect?
Sir, they shows leakage in FFA, ink blot pattern, smoke stalk pattern, and in chronic CSR, we see some granular depositions.
So can you predict after you see the elevation of the retina, can you predict how many, what is the time it would take it to resolve that edema?
So it may be resolved in 3 to 4 months, but if not respond, then we provide treatment to the patient such as laser.
At what stage would you call it a chronic CSR?
Sir, if patients, it persists for 3 to 4 months, and if there is some previous it's sequel of DME, CMD.
So do you think the patient had this thing for the first time or it was a recurrent?
Sorry, sir.
Was it for the first time, the CSR, or it was recurrent? It had the same kind of a history in the past?
Sir, recurrent.
If there's a recurrent and such a big CSR, should you have start some treatment, some intravitreal injection?
Yes, sir. Intravitreal bevacizumab anti-VEGF.
Very nice. You have done perfectly fine. Very nice. Very nice. Good, good.
Thank you, sir. Thank you, ma'am.
Okay, we can go for the next presenter. Dr. Nitish, you ready? Dr. Nitish, are you audible? Are you audible?
Dr. Nitish, please unmute yourself.
Yes, sir. I am audible, sir.
Yes, you are audible. Dr. Nitish will present on the standard disease.
Yes, sir. Good afternoon, everyone. A 20-year-old female residing in Purulia, West Bengal, a student by occupation, presented to RIMS OPD with chief complaints of diminution of vision both eyes since childhood, mild photophobia both eyes, last 2 years. History of presenting illness. The patient was presented to RIMS OPD with diminution of vision since childhood in both the eye, which was gradual in onset, progressive in nature, and painless, and associated with mild photophobia from last 2 years in both the eye. No history of night blindness, delayed dark adaptation, impaired peripheral vision, no significant drug history, and non-smoker. No history of using spectacles, ocular trauma, and head injury. Families, there was similar complaint also present in her sibling. External examination, facial symmetry was within normal limit, external face was within normal limit, head posture, ocular examination was within normal limit, ocular motility full and free in all directions. Ocular examinations, visual acuity unaided in right eye 1/60 and near vision and 12 at 25 centimeter. Pinhole no improvement in left eye 1/60 and near vision and 12. BCVA in both the eye was 1/60. IOP measured by Goldman appellation tonometry at 11 a.m. in right eye was 12 mm of mercury and left eye was 16 mm of mercury. Conjunctiva was within normal limit in both the eye. Cornea was clear in both the eye. Anterior chamber was normal in depth in both the eye. Pupils were round, regular, reacting to right, and no RAPD in both the eye. Lens was clear in both the eye. On posterior segment examination, media was clear in both the eye. Optic disc was normal in size, vertical oval in shape, horizontal oval in cup, well-defined margin, pink in color, with CD ratio of 0.3. And macula in both the eye was yellowish white fleck seen in the perimacular region with central atrophic region that looks like a beaten bronze in both the eye. Fovea reflex was dull in both the eye. Blood vessels arise from the center of the disc with branching dichotomously with AV ratio of 2:3 in both the eye. Periphery, yellowish white fleck seen in the mid-peripheral region in both the eye, and the rest periphery appears normal as far as seen. This is the fundus picture of both the eye. Summary: a 20-year-old female presented with gradual painless progressive diminution of vision since childhood. There was history of similar complaint in her sibling. Uncorrected visual acuity in both eyes was 1/60 and near vision and 12. Posterior segment in both eyes, yellowish whitish fleck seen in the perimacular region and mid-periphery region with central atrophic lesion that looks like a beaten bronze. Differential diagnosis was Stargardt disease, cone rod dystrophy, leber congenital amaurosis, age-related macular degeneration, chloroquine and hydroxychloroquine maculopathy, and West vitelliform macular dystrophy. And my provisional diagnosis was both high Stargardt disease. Point in favor of cone rod dystrophy was rod dysfunction evident earlier, peripheral vision affected, and night blindness. In leber congenital amaurosis, onset usually in infancy, severe early onset vision loss, sluggish or absent pupillary response, nystagmus, ERG showing flat or near flat response. In ARMD, age is more than 50 years and presence of drusen and neovascularization. Chloroquine and hydroxychloroquine maculopathy, history of drug intake. In West vitelliform macular dystrophy, presence of vitelliform egg yolk lesion. Plan of management: investigation, spectral domain OCT and multifocal ERG done. In OCT, both eyes showing the loss of outer retina layers, including the photoreceptor, ellipsoid zone, and hyperreflectivity seen within the RP. And this is the multifocal ERG showing the foveal cone function will be distorted. In advice, genetic counseling will be advised and low vision consultation and avoid high dose of vitamin A. Rehabilitation plan and advice explained about current visual status and prognosis done. Contrast adjusting measures suggested. Advice glasses with medium grade tint. Advice and dispense do magnify 4:65 for near. Advice 4 times enhanced telescope for board work where focusing was good, tracing was good, as well as tracking was average. Will dispense on next visit. Explained about visual disability certificate and government benefits. Discussion: Stargardt disease is the most common juvenile macular dystrophy and a frequent heritable cause of central visual dysfunction in young patients. The prevalence of Stargardt is between 1:8,000 and 10,000. Stargardt disease is most commonly caused by the mutation in the APCA4 gene and is typically inherited in an autosomal recessive fashion. The APCA4 gene is an ATP binding cassette transmembrane protein involved in the transport of all transretinal. The mutation is APCA4 results in the accumulation of all transretinal in the photoreceptors as well as RPE. Subsequent conversion of all transretinal to N-retinylidine and N-retinyl ethanol amine, which is toxic to the RPE and photoreceptor. Thank you, sir.
Excellent presentation.
Fantastic.
Excellent.
Serious for the question?
No, we can, no question from my side.
So we proceed for the next speaker. The next speaker is Priya Suman. Dr. Priya, are you ready?
Yes, sir.
Okay. So Priya Suman is the second year student from the Rio RIMS Ranchi, and he will present the central retina vein occlusion. Priya, yes, share your slide, please. Good.
We can see your
Okay.
slide, yeah.
You can see. When the slides are.
Good afternoon, sir. Ma'am, I'm Dr. Priya Suman. My guide is Dr. Rahul Prasad. I'm presenting a case, 66-year-old male, complaint of sudden onset diminution of vision in right eye since 5 days. He was apparently well 5 days back when he developed sudden onset diminution of vision in right eye, which was painless. There is no history of similar episode in past, no history of trauma or floaters. Patient is a known case of hypertension for 12 years and is currently under medication. He had no history of diabetes, asthma, thyroid, or cardiac illness, no history of any ocular disease or systemic illness. There was no specific family history, no ocular surgical history. Patient has normal sleep and appetite, normal bowel and bladder. He is a known smoker for 35 years. My patient was alert, conscious, well-oriented time, place, and person. He had no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. His blood pressure was 146 by 90 mmHg. Pulse was 84 per minute. Respiratory rate was 16 per minute, and he was afebrile. Cardiovascular system, respiratory system, GI, and CNS were within normal limit. On anterior segment examination, in right eye, the uncorrected visual acuity was 660, and best corrected was 660. There was no improvement with glasses. In left eye, it was uncorrected was 636, and best corrected was 612. Near vision in right eye was N24 and left eye N6 with plus 2.75 diopter sphere. Extraocular movement in both eyes were free and full in all directions. Adductor with conjunctiva were within normal limit. Cornea were clear in both eyes. Anterior chamber were normal in depth in both eyes. Iris was normal color and pattern in both eyes. Pupil was normal shape and reactive to light in both eyes. Lens was nucleus crosses grade 2 in right eye and nucleus crosses grade 3 in left eye. IOP by GAT showed 16 mm in right eye and 14 mm in left eye. Gonioscopy in both eye were done, and it was up to stellar spur were seen. On posterior segment examination, the media was clear in both eyes. In right eye, the optic discs were vertically oval in shape, hyperemic in appearance. Margin was blood, suggestive of disc edema. There was circumferential halo is seen around the disc. Obscuring of blood vessels on disc of one major blood vessel was seen. In left eye, the optic disc was normal in shape, normal color. CD ratio was 0.4. Margin was well defined. NNR was healthy. Macula in right eye was dull, appeared as fluid pocket. There was dot, blot, and flame shade hemorrhages seen. In left eye, foveal reflex was seen. Blood vessel in right eye was AV ratio was 2:4. Dilated and tortuous retinal veins. Intraretinal dot, blot, flame shade hemorrhages were seen. In left eye, it was blood vessels were normal in caliber. AV ratio was 2:3. In right eye, the peripheral retina showed cotton wool spots. Interretinal flame-shaped hemorrhage in all quadrants, and it was tessellated, and peripheral retina was attached. In left eye were within normal limit. This is the fundus photograph of right eye showing optic disc edema. There is a AV ratio of 2:4. In the macula, there is edema, and the dot blot hemorrhages are seen, cotton wool spots are seen, and the flame-shaped and dot blot hemorrhages are seen in all 4 quadrants. Left eye fundus photo were within normal limit. On systemic examination, his blood pressure was 146 by 90 mmHg. Blood sugar were within normal limit. Serum triglyceride was raised 198 milligram per deciliter. Cholesterol was mildly raised. ECG was within normal limit, and homocysteine level and thrombophilia screen were within normal limit. This is the OCT picture of right eye showing cystoid changes in the macular area and subretinal fluid. Thus, my case summary is that a 66-year-old male presented with history of sudden onset painless diminution of vision for 5 days in right eye. He's a known hypertensive for 12 years, currently under medication, and has history of smoking for 35 years. Systemic examination revealed raised blood pressure. His best corrected visual acuity is 660 in right eye and 612 in left eye. anterior segment findings were normal. Right eye fundoscopy showed dilated tortuous vessels with intraretinal dot blot and flame-shaped hemorrhage in all quadrants, hyperemic disc with macular edema, and left eye fundus were within normal limit. OCT in right eye showed huge cystoid macular edema. Central macular thickness noted was 755 micron. Blood investigations revealed borderline lipid profile. My differential diagnoses are non-ischemic CRVO, ischemic CRVO, DRVO, diabetic retinopathy, papilledema, ocular contusion, or retinal trauma. Thus, my provisional diagnosis is patient is suggestive of a case of non-ischemic CRVO with macular edema with cataract in right eye. Patient was advised for strict control of hypertension and hyperlipidemia. He has been planned for first dose of intravitreal anti-VEGF ranibizumab under topical anesthesia to be followed next day, 7 day, and then 1 month for assessment of visual acuity. And for this second dose of anti-VEGF, he was planned for first left eye cataract surgery, followed by right eye cataract surgery, and patient was referred to physician for control of hypertension and hyperlipidemia. Thank you, sir.
Excellent presentation. Just one question. What is 100 days glaucoma?
Ma'am, it's a neovascular glaucoma, which occurs in CRVO patients in ischemic, mostly seen in ischemic CRVO.
Good. Over to other judges.
We will go for the next speaker. Dr. Ming, Lalming Mavi.
Yes, sir.
First year resident in the Rio Rims Ranchi and receive it present in the FECO Atlantic glaucoma. Okay, go for.
Yes, sir. Sir, is my slide showing?
Yes, yes. Go in the slides.
Yes, sir. Good afternoon, sir and ma'am. I will be presenting a case of phacolytic glaucoma, and my guide is Dr. M. Deepak Lagra, sir. A 65-year-old male patient from Hazaribagh, farmer by occupation, came to the OPD with the complaints of diminution in right eye since 5 years, pain in right eye since 2 days, watering and redness in right eye since 2 days. History of presenting illness. The patient was apparently asymptomatic 5 years back. Then he developed diminution of vision in right eye, which was insidious in onset, slowly progressive, painless in nature. Then 2 days back, the patient developed acute pain and redness in right eye, which was associated with nausea and vomiting. It was not relieved by medications from local pharmacy. It was not associated with discharge from the eye. There was no history of fever or any topical drug installation. Past history, left eye cataract surgery done 2 years back. There was no history of ocular trauma or any systemic illness. Family history was not significant. Personal history, the patient's sleep appetite, bowel and bladder movements were normal. There was no history of alcohol or alcohol consumption or smoking. General examination. The patient was conscious, well oriented with time, place, and person. General appearance, pulse, BP, respiratory rate, and temperature were all within normal limit. Systemic examination, central nervous system, cardiovascular system, respiratory system, and per abdomen were all within normal limit. Local examination. Visual acuity in right eye was PL positive. In left eye, uncorrected was 6/18 with base corrected was 6/9 with minus 0.50 diopter spherical. Digital tension was raised in right eye. It was normal in left eye. IOP by Goldman appellation tonometer at 11 am was 42 in right eye. It was 18 in left eye. Eyeball and eyelids were normal in size, shape, and position in both the eyes. Ocular movements were free and full in all cases in both the eyes. Conjunctiva in right eye, congestion, both conjunctival and circumciliary, was present in right eye. In left eye, it was within normal limit. Sclera in both the eyes were within normal limit. Cornea in right eye was hazy. Corneal edema was present, and it was clear in left eye. Anterior chamber in right eye was formed with 4 plus cells and 3 plus flare, and it was normal in left and quiet in left eye. Iris could not be, details could not be assessed due to flare. In left eye, it was normal in color and pattern. Pupil in right eye was mid-dilated with sluggish reaction. In left eye, it was normal in sensitivity and reacting to light. Lens in right eye was hypermature, Morgagnian type cataract. In left eye, it was pseudophakic with posterior chamber IOL. Fundus in right eye was no view. In left eye, CD ratio was 0.3. Vessels and macula were within normal limit. This is the slit lamp examination of right eye showing cornea, hazy cornea and edematous cornea with hypermature cataract. Blood investigations were done, including HP, TSC, RBS, ESR, urine and viral markers were within normal limit. My provisional diagnosis is right eye hypermature cataract with phacolytic glaucoma and then left eye pseudophakia. Primary treatments that were given, mannitol 20%, 300 ml IV over 30 minutes stat, tablet acetazolamide 250 mg2 tablet stat, tablet PCM with aceclofenac and serratiopeptidase, eye drop moxifloxacin 0.5% with dexamethasone 0.1%, 1 drop 8 times per day, eye drop atropine 1%, 1 drop 3 times per day, eye drop nepafenib 0.1%, 1 drop 3 times per day, eye drop brimonidine 0.2% with timolol 0.5%, 2 times per day. And then IOP after 30 minutes of the immediate treatment was 26 mm of Hg. Then right eye SICS with PCIOL was done under guarded visual prognosis. Post-op treatment, tablet ciprofloxacin, tablet prednisolone, which was tapered from 60 mg, tablet pantoprazole, tablet PCM with aceclofenac with serratiopeptidase, and then moxifloxacin 0.5% with dexamethasone 12 times per day, hydroxytropine 2%, 1 drop 2 times per day, hydroxynepafenib 0.1%, 1 drop 3 times per day, brimonidine with timolol 2 times per day. The post-op finding, post-op day 1 finding in right eye were finger counting at 1 meter, visual acuity, digital tension was normal, IOP by Goldman applanation tonometer at 930 mm was 14, cornea edema was present with DM falls, SE was formed, 4 plus cells and pigments were present with 3 plus flare, IOL was in place, fundus could not be assessed due to hazy media. This is the slit lamp picture on post-op day 1 showing corneal edematous cornea and DM falls with air bubble in AC. Patient was discharged on the following treatment: tablet ciprofloxacin, tablet prednisolone, tablet pantoprazole, tablet PCM with aceclofenac and serratiopeptidase, eye drop moxifloxacin and dexamethasone, which was tapered from 12 times, then eye drop nepafenib, homatropine, and hypersol. Then patient was called on 1 week follow-up. The findings on 1 week follow-up were vision 6/60, digital tension normal, IOP by Goldman applanation tonometer at 930 was 16. Cornea was still hazy, edema has reduced with few DM falls. In AC, 2 plus cells and pigments were present, flare was 2 plus, fundus was visible. This appears to be within normal limit. CD ratio was 0.4, FR was dull, blood vessels were within normal limit, and peripheral fundus was tessellated. Then 3 weeks follow-up. Best corrected visual acuity was 6/12. Digital tension was within normal limit. IOP was 14. Cornea was clear. SE was quiet. Fundus was the same as the findings in 1 week follow-up. Thank you.
Yes, please, Professor.
Thank you so much. Thank you so much.
Thank you, ma'am.
And please wait all the presenters for the result. In the meanwhile, please log. We will be having guest faculty session, and after guest faculty session, who are your judges also, we will be announcing result. So in the guest faculties, we have done introduction of everyone. We need only introduction of Anu Malik, which we will do before her presentation. So, take it up, please.
Have lunch. Lunch.
Yes. So, in this session, we have chairpersons, Dr. Rajiv Gupta sir. He is the ex-principal, Rio RIMS, the largest medical college of Jharkhand. Dr. S.P. Khanwal, he is heading Jamshedpur Eye Hospital, Jamshedpur, which is a very big hospital in Jamshedpur. Dr. Vinay Gupta is a prolific cataract and glaucoma surgeon from Giridih. He is there. Dr. Andy Mishra, he is our future conference organizer at Devghar. Dr. Anuj Pathak, he is the cataract surgeon from Ranchi. Dr. Bharat Singh, he is from Ramgarh CCL, cataract surgeon. Dr. Purendra Bimal, he is a cataract surgeon from Garhwa. Dr. Siddharth Shekhar, he is a cataract and plastic surgeon from Ranchi. So these are our chairpersons, and our session coordinator is Dr. Rashi Shyam. Dr. Rashi, are you there? Dr. S.P. Khanwal sir is there. Dr. Rashi. So now over to the session coordinator, Dr. Rashi Shyam and Dr. Abhishek Sadeh. So we have done all the introduction except Dr. Anu Malik. So the first speaker is Dr. Prakhyat Roop, the genius RPC alumni Prakhyat Roop. So you want us to, Dr. Prakhyat, over to Dr. Prakhyat Roop.
Hello. Hi, can you hear me?
Yes.
Can I share my slides?
Yes.
Okay. So at the very outset, I would like to thank Jharkhand Ophthalmic Society, Dr. Bharti ma'am, and the whole executive for inviting me for this talk. I am going to be speaking about a excimer laser used in keratoconus. We are pushing towards spectacle independence using excimer laser while doing treatments of keratoconus. And these are my financial disclosures, nothing relevant to this presentation as such. I am going to dive in directly into my presentation. So I am going to be discussing all the components of excimer laser assisted C3R. The most important aspect of doing an excimer laser assisted treatment along with C3R in a keratoconus case is the subjective refraction of the patient. So you have all the tools in the world. You have the wavefront, you have the ray tracing, you have topo guidance, you have everything. But ultimately, what you are treating is the subjective refraction of the patient. Second is the corneal abrometry and topography that you must capture on a very good device. Third is the customized ablation, which you are going to use to correct the aberrations and debulk the refractive error. And lastly, you are going to increase the biomechanical strength of the cornea that you have now ablated and changed the shape of, and ultimately fix it in that particular, so to say, topography. And that you are going to use the sub 400 protocol of the cross linking, which is by Hafezi and al. You can also use a hypotonic CXL or a contact lens assisted CXL, different techniques of the sub 400 CXL. Next, I will dive in directly into the cases so that we continue to get the perspective of what I am speaking about. So this is my first case, one of the very few cases that I started initially with around 2.5 years back. So this case is a moderate keratoconus in both eyes. The vision was best corrected to 6/60 with glasses and on pinhole up to 624. In the left eye, the vision was going from 624 to 612. Now, this is the left eye. We decided to treat the left eye first because we were not very confident with the treatment. So the first eye we treated was the left eye. She had a 1.5 diopter sphere with 3 cylinder, improving to 612. This is the topography. And what you do is, this is how we plan the treatment. We first take up 0 refractive correction ablation, and that shows us what is the amount of ablation and the ablation pattern required to actually just take away the aberrations from the cornea. And once we understand this is how the ablation pattern is going to be, we decide to see if we can minimize the ablation depth. Now, this is a very unique feature of the Schwind-Amaris system. It's not available in any other excimer laser, that you can actually customize the type of aberration that you are going to correct and to what extent. So after that, you go into feeding the debulking of the refractive error. So you decide what amount of refractive error you want to correct. And as a protocol, I take 2/3 of the cylindrical power that is manifest in the correction. So I start with that, and then I assess my ablation depth. Now I have a cutoff which I'm going to discuss of everything. So I have to look at that, and then I can also decide to debulk the spherical error. And that is how my treatment profile is now decided. Once this is decided, I take up the patient on the table. So the patient is in the treatment bed, and we move the eye into position. Once the eye is in position, we have to capture what we call the static cyclotorsion measurement. So basically, this machine is very good and very sensitive in procedure, which is why it's a breeze to do a keratoconus treatment on this particular machine. So you can see that it's a very odd kind of a pattern with laser spots being concentrated on the cone area more. And then we go ahead, and now this is the trans PRK which is happening. Throughout the procedure, there is a dynamic cyclotorsion compensation. That is, during the procedure, if the eye is rotating and there is a cyclotorsion, even that is being tracked along with obviously the X and Y. So this is the beauty of the tracking that happens in this machine. And once the excimer is done, we can wash and put the riboflavin dye and the soaking time starts. So what is the key to success in this kind of a treatment? Well, the first is, like I said, the high quality acquisition of a topography map. So the Schwind is attached with the Sirius, and the Sirius is a topography combined with a tomography. You get a metric of actual quality of acquisition, clearness of the acquisition of all the maps. So you have to achieve a very high acquisition quality to get extremely good results. The second is the tracking. Now, this machine has, like I said, a 7-dimensional tracking, which they call, in which the cyclotorsion is compensated not only static, that is at the starting of treatment, but also throughout the procedure. So even if the eye is rotating by some degrees during the procedure, that is being tracked and compensated for, which is why when you're treating the cone, you are sure that you're treating the cone and not putting your excimer laser spots on some other point. And lastly, there is a facility of actually reducing the amount of ablation, because the amount of ablation is going to determine your ultimate results. Because more ablation can lead to a haze. You are not going to use mitomycin C when you are going to do a PRK extra. So that is why, to minimize the ablation, this feature of actually using artificial intelligence to analyze the Zernike polynomials of the higher order abrasions and actually build a protocol of treatment that reduces the ablation is a big gain. Now, to put things in perspective, this is a patient. I take him up for treatment, and you can see the amount of cyclotorsion that comes when you measure the cyclotorsion. So it's minus 6.4 degrees. And we know that for every degree that we are off axis in toric treatment, we are losing 3% of effectiveness. So by this logic, I'm actually reducing my effectiveness by about 20% if I would have treated this patient and this position. So I start adjusting the patient's head tilt. So basically, I'm turning the head right and left, and then I start to see a change in the torsion angle. And I continue to do this. I reposition and remeasure, and I'm coming to less and less torsion angle. So I do this once more to basically go under 3%. So now I get minus 1.8, and then I accept and treat my patient. And during the treatment, you can see that the dynamic cyclotorsion compensation is being measured. So it's always being tracked whether the cylindrical axis is accurately being treated or not. Now, this is another example of a patient sorry, this is the same patient. This is the pre-op left eye of the same patient, and this is the post-op. You can see the change in topography. The topography has become so much more regular, and undoubtedly, the patient is obviously improved tremendously in her vision, and it's unaided 6/6 partial. So from having this distorted topography and 624 best corrected to unaided 6/6. And you can see it's possible because now the astigmatism is quite regular, almost gone. So, and this is the ASOCT map, which you can see the demarcation line is so good. It's going up to the 80-85% depth in the center. You can see it all along is perfect. The second case, a 17-year-old male, right eye has a moderate keratoconus, left eye is formless. Left eye does not actually really show anything except this small island of anterior topography bulge. So we decide to treat the right eye. It's 4.5 diopter cylinder at 30° accepting to 618 parts. So this is the topography of this patient, and you can see that there is a cone here paracentrally. This one is a smaller one. The third case that I would like to discuss has a slightly more steeper cone. So you can see that actually the cone is going up to 63, 64 diopters here, and the patient's refraction is also quite high, -4 sphere with -4.5 cylinder to 636, and that is the best corrected vision that this patient is getting. Left eye is still better. So now when I'm planning the excimer laser of this patient, the things that I am going to do is, my first step is to see for a zero refractive error ablation. How much am I ablating? What is the pattern? Look at the thinnest Paki. Now my cutoff for the thinnest Paki is 350 micron at the end of treatment. So I am looking at something which is more than 400 after the epithelium has healed. So my cornea would be cross-linked and more than 400 micron in Paki after a month of this treatment. And that is a very, very stable cornea for the long term. Because mind you, I have cross-linked it and increased its biomechanical strength. So I plan for debulking astigmatism, keeping in mind that I don't have to breach this mark of 350 residual bed. Then I can plan for debulking the sphere if the ablation depth allows me. And then I optimize the depth of this ablation by using the depth management tool, which is sometimes so dramatically effective that it changes the ablation depth by up to 30%. So it's a big boon. This is the pre-operative map, and so this is the pre-operative map, and this is the post-op of this patient. You can see that patient still has an astigmatism, but he can be refracted to 6/9 parts with a 3 diopter cylinder, and the sphere is almost gone. This is the change in the left eye. You can see that from a 61 diopter steepest, it has gone down to 51. So a 10 diopter change is seen in the Kmax of the patient. Now we come to those cases where you can't do this. So there are a few cases where you will see a eccentric cone, which is kind of like a nipple cone configuration. Here, even the refraction is not possible. The patient is not accepting any refraction. Now here what we do is a topo-guided removal of epithelium in keratoconus. This is called TREC. So in TREC, what we do is we program a profile of removing epithelium or removing basically 20 microns extra of the cone at the apex of the cone. So this is how the treatment is. Just have a look at this pattern. You can see that there's an eccentric green circle. This is the area where the ablation is going to happen. No other part of the cornea is going to be ablated. So we have designed a treatment profile which you can see is eccentric, it's oval, and it's going to only take away 20 microns or whatever, 30 microns extra only from this paracentral area. So as my treatment starts, I've taken off the epithelium manually, and now I'm doing an excimer. And you can see the pattern of ablation is completely eccentric, only localized to this cone area, and that it's just 6 or 7 seconds, and that's it. This is done. And now I again put my dye and start the cross-linking process. So topo-guided removal of epithelium has actually been published and shown to improve results tremendously in terms of contact lens fitting, in terms of best corrected spectacle vision. And you can see in this patient from a pre-op, this is the treatment profile that I had planned. So basically, you can see that on the cone, I am ablating 20 microns extra. And at the end of the treatment, the patient's cone has shrunken and the Kmax has reduced by about 8 diopters. So before the patient had a vision of 3/16 improving to 618, now it's 660 improving to 612. And that helps significantly. So basically, why I am able to do all these treatments and render at least 50% of my patients spectacle free is because now the technology has become much more accurate. Earlier, we were utilizing Topolizer Vario or iDesign or Zeiss to actually capture the data and do the topo-guided treatments. Now, with the Schwind Amaris and the Sirius software, we are actually analyzing 5 times more data than we were earlier. We are utilizing the Scheinflung and Placido to actually image the whole anterior segment, analyze the higher order abrasions, and customize the higher order abrasion treatment. We are doing a cyclotorsion compensation that is not only static but also dynamic. And this is why, and also in the end, you must understand that the frequency of the excimer laser is very important for the residual haze. And Amaris or Schwind is the only platform that actually switches from a higher frequency to a lower frequency for the last 25% of the treatment within each single treatment. It is the only machine that does that, and it significantly smoothens the results. I think that's the end of my presentation. This is basically what the tracking is all about. So it's a very short video. You can see that it is basically the rolling movements and the cyclotorsion, which are the more important aspects, and also the axial displacement, that is the z-axis, which is basically tracked by this system. So throughout the procedure, the machine is actually tracking the shift of the pupil, it's analyzing the motion, and the seventh dimension, which they actually call, is the motion analysis. So basically, this is the z-axis tracking, and what latency free tracking means that they are actually analyzing the motion, and using artificial intelligence or using machine learning, the machine has predicted the pattern of the movement of the eye so that the next laser spot is actually falling at the point where the eye is going to be by the time it reaches the eye surface. So it's really complex, and I don't know how it's happening, but it's definitely much ahead of any other platform that I have ever used. Thank you.
Presentation. Yeah, very good presentation by Prakash Group. Now we go to the next presenter, Piyush Bansal, about advances of VR surgeries. So Piyush, are you ready? Dr. Piyush?
Yes, sir. Am I audible?
Dr. Prakash, let me ask you one question, Dr. Kashyap.
Yes, sir.
Yeah. So to ablate the epithelium, what is the best way to get the epithelial mapping for the ablation?
So there are two ways, sir. One, you can use a good OCT, and the second is actually the very high frequency ultrasound. So the high frequency ultrasound is really expensive, and it also is very time consuming. So the patient has to put their eye in water. There's a whole assembly. So there's only just one machine that does that, and then it tracks. It does ultrasound scans on different meridians, 16 meridians, and then it gives you the epithelial map. It is considered to be the gold standard, but for all practical purposes, OCT is quite close.
I have asked Dr. Rohit Shetty also this question. He said, if you have Anterion, go for the epithelial mapping. I think this was the question. So
Yes.
if you have Anterion, then go for the Anterion cornea model. And that is the best because MS39 is extremely costly.
Yes. So basically, Anterion is a great OCT. Anterion is a great OCT machine. So you can go for it.
We have Anterion. So he said, if you have Anterion, then go for a cornea model and add that in your armamentarium, because MS39 लोगे तो वो एक ही चीज करेगा और it's very costly.
There is no point in MS39 is basically mapping the epithelium along with the shine film. So it's an OCT along with a topotomo. So it's basically multimodal imaging, which is the purpose of it is different. So just to image the epithelium, I think OCT is the best thing. OptoView or Antirion or whatever commercial Heidelberg, the available OCTs are good.
Just we have to have a cornea model.
Yes, you have to have the lens attachment for that. Right.
Cornea model में upgrade करना होगा. We have to buy because इसके anti glaucoma and cornea model के अलग पैसे लगते हैं.
Yes.
So the session coordinator, Dr. Abhishek, to the next speaker, Dr. Piyush Bansal. We have already introduced Dr. Piyush Bansal. So Dr. Piyush Bansal, you have become CSC Maharashtra?
Madam, the elections just got over yesterday. So I hope the results would obviously come in at the GBM in the coming week. So that is when we will know, ma'am.
Okay. So you had a very hectic week.
Yes.
So I know. So over to you.
Somehow. Oh, yes. Are my slides visible? Some problem. Just 1 second. I think it should be sorted. Am I audible and are my slides visible?
हाँ ये बंसल आई विजन दिख रहा है कुछ.
Okay, great. So first of all, thank you very much, Dr. Bharti Kashyap. JHOS, it's one of my favorite societies in the country. It's one of my my best friends in ophthalmology are from Jharkhand. So thank you so much for this opportunity to all the executive. It was wonderful to listen to Dr. Patkya, Dr. Roop, and some of the excellent speakers, the students as well. So with this, I'll begin my presentation. So I'll essentially be talking about advances in vitreoretinal surgery. Now, vitreoretinal surgery has advanced more as compared to any other specialty in ophthalmology. And it's seen a pretty long evolution. Now, the transition that we have seen is from the first picture that you see over here, where multiple punctures would be made on the sclera, hypertonic saline would be used, to visualizing the retina today and operating. Now, before 1920, it was the pre-Gonin era, where, like I said, there was scleral punctures and trephinations that were being done. Now, Gonin was the first person to actually say that the retinal detachment is because of the hole and it's not the other way around. And he was rightly so called the father of RD surgery. There were other custodians as well who brought new concepts to light. And then we have the present, which is modern vitrectomy, which started in the 70s. And then gradually, vitreoretinal surgery became more safe, more effective, and predictable. And I'm going to be dealing with only some advances. Now, we know that scleral buckling has long been one of the modalities of treatment of retinal detachment. But another advancement over here is using a chandelier light illumination to visualize the retina, the break, while putting the scleral buckle. The advantages are it can be a great teaching tool for residents, for fellows, so that they can actually see it under visualization. The disadvantage, of course, is that it's an additional instrument that goes inside, and the chances of complications are also there. With it. So every advancement need not necessarily be very good. We have to weigh the risks and the benefits. Posterior vitrectomy systems have also evolved significantly. Of course, what you see in the pictures are the Constellation or the Stellaris. Along with these, there are excellent Indian machines as well. The only advantage that some of these important machines that I feel which are offered is excellent IOP control and fluidics. But I think in the coming years, Indian machines are going to just keep getting better and better. Another advancement that was quite, we were anticipating it, was these ultrasonic cutters, which would cut at the rate of million cuts per minute, as compared to the conventional cutters that we have. However, that has not seen the light of commercial day to day. So waiting and watching towards that. Now, the instruments that we use in vitrectomy that have also evolved significantly. Earlier, from using 20 gauge instruments and using a suture technique to now using smaller gauge instruments. from 23 to 25 to now 27 gauge instruments. And these, of course, shorten the surgical time significantly. There are other advantages like giving comparatively less tissue damage. So again, we've seen these advancements predominantly in the last 10 years. So one change that we see from the conventional cutters are these bevel tips that that helps us to go closer to the retina. And as you can see over here, the bevel. So because of this, one can go closer to the retina. It is extremely good in shaving and cutting membranes that are very close to the retina and avoiding tissue damage. Another significant advancement that these guys did were bringing the port closer to the tip. So again, one can go closer to the retina, and the concept of duty cycles, which causes you can control for how long the vitreous cutter is going to remain open or closed. So, of course, the dyes have evolved too. The dyes that we use for visualization, we were earlier using trypan blue and fluorescein, which changed to brilliant blue G, which was much safer for the retina, for the photoreceptors. There were also studies about using lutein and zeaxanthin crystals to protect the photoreceptors. There are various other dyes that are being looked at. These enhance visualization of not just the vitreous, but the internal limiting membrane and epiretinal membranes. Vitreous substitutes have also undergone advancements, typically the silicone oil and the heavy liquids that are available to us now. Now, one of the biggest advancements in terms of surgical instruments is the visualization systems. So not just diagnostics, but even in the operative field. What you see, the first picture over here on the left is how the retina would be visualized during surgery using contact lenses, irrigating contact lenses, and various other contact lenses, which then moved on to the indirect visualization systems, which did not require contact, which also reduced the need for the assistance to be very good. The visualization would be almost up to the periphery. And now what we have is heads-up vitrectomy, wherein you remove the binoculars of the microscope are not required, and you can visualize on the television screen while operating. This is short video of my senior colleague operating. He's doing a live surgery using a heads-up vitrectomy. As you can see over here, he's going to start the procedure, and there is no ocular piece over here. And now visualizing the retina, and this is being telecast to the audience during the conference. And you can see the quality of visualization over here. So this is what we have now. Not just this, there's availability of intraoperative OCT as well. So when one is going close to the retina in cases of macular holes or in fractional cases, you can visualize side by side, similar to our anterior segment colleagues when they operate on are. So what you see over here is whether you can know the status of the surgery then there on the table itself. Anti-VEGF injections have come a long way, as we all know. So the previous availability of just 2 molecules has now changed, and we have not only new innovator molecules, but we have quite a few biosimilars that are available to us, and this trend is only going to increase. Now, another thing that probably many people would not know is the concept of using an endoscopic vitrectomy. Now, I mean, there are many cases like what you see over here, wherein you would question the need whether a surgical intervention would be helpful or not. So my colleagues at LVPI, Dr. Rajiv Reddy was the first one who started doing it, and then you have Dr. Mudit and Dr. Vivek, who are doing excellent work over here with endoscopic vitrectomy. So they essentially use it as a diagnostic tool many times, wherein you go in and you see whether there is any future prospect of vision, and only then perhaps the idea of using a prosthesis and doing a vitrectomy would probably be needed. The other improvement are these microdose injectors that are now commonly available for subretinal hemorrhages. Port delivery systems are undergoing excellent improvements. So coming on to a few surgical cases, now what you see over here is We are commonly doing bimanual vitrectomy for these kind of cases that you see over here. It's a proliferative diabetic retinopathy with extensive membranes, and using a chandelier light, going in and using both your hands to remove all the membranes is a godsend. And what you see over here is the ILM being peeled over here in cases where it is possible. It's a good idea to do that as well, as long as you're not causing any complications, because these retinas are boggy and one can easily cause an iatrogenic break. Excuse me. So again, vitrectomies like these, maybe 10, 15 years, 20 years back, was not a very common thing to do. So you see the visualization is also very good. The recordings, the ability to teach young fellows and even other seniors has improved drastically. As you can see over here, you can even make out that the vitreous is being lifted up. A posterior vitreous detachment is being done in this case of vitreomacular traction secondary to branch retinal vein occlusion over here, and now a macular-centric PVD induction is being done. After cutting a small, leaving a small tuft of vitreous at the macula so as to not de-roof the macula and cause a macular hole on table. And following this, these are practically the only times when I like to go across the macula instead of going around it while peeling the internal limiting membrane. This is so as to make sure that you're not causing undue traction, because there is still a small tuft of posterior cortical vitreous attached at the fovea, and then going all across it and doing an ILM peeling. So again, now the number of surgeons doing internal limiting membrane peeling, ILM peeling in macular hole cases or many other such cases is far more as compared to before. As you can see over here, this is again because of the excellent visualization, the excellent instruments that we have. And what you've seen being done over here is like a macular excess in a fashion similar to a capsular excess. The ILM peeling is done all around. Now this is comparatively a smaller hole, so just an ILM peeling suffices. But then many a times you have these larger holes where we follow a technique called as internal inverted flap technique, wherein we like a flower petal pattern or a 180-degree peel is done so that you don't lose your ILM flap, which you're going to place over the macular hole as a scaffold for the hole closure. As you can see, after 180 degrees, it's being done on the other side, and following this ILM is being tucked into the macular hole. You don't necessarily need to tuck it; it's just placed over the hole. Some surgeons have also started to do just a temporal flap as compared to this inverted flap or 360 degrees peel. Now, this is my colleague's video, Dr. Upakanti. He's done excellent work over here in these failed macular holes, wherein after having even done a free flap or inverted flap, sometimes there are holes that are recurrent. So what he is doing is doing kind of a retinal transplant. So this is his define. What he does is he'll measure the size of the hole approximately, and then he will cut out a piece of the retina from beyond the arcade. And after doing that, as you can see, the piece of retina is now separate, and then lift it up with the forceps, and then place it over the macular hole. As you can see, the tissue being lifted up and being placed over the macular hole. This is all done under air. So this is just something that is not very commonly done. Now, the type of cases that perhaps one would not even touch earlier, one can do with much more ease. As you can see over here, it's a pretty bad retina with a lot of PVR and the nucleus in the posterior in the cavity over there. So after getting the nucleus out, one attempts to clear off the membranes, try to open up this funnel that you see over here. So these kind of surgical procedures were probably not possible with such efficiency earlier. As you can see now, after lifting the membranes and then cutting it, gradually one will be able to see the retina opening up. And PFCL being a godsend over, it's like the third hand that we have. And after putting in PFCL, you have subretinal fluid that is flowing out. and the retina begins to flatten. Obviously, the anterior retina is too stiff, so we will need to do a relaxing retinectomy. And after marking it and cutting the anterior retina, we can achieve flattening of the posterior retina and then lasering it off. So again, it's because of the excellent surgical machines and instruments that we have. Now, this is, we have a lot of work by Dr. Nishikant Borse, Dr. Somil Sheth, and myself now on these patients with the central retinal artery occlusion. And this is something I just wanted to show you all. This is an excellent video by Somil, wherein you can see over here during the vitrectomy, you can see trace the plaque moving ahead into the vessel, and there's a filling of the proximal vessels as the plaque moves forwards. So you can watch it again. It's quite interesting. So of course we do many tricks over here, pinching and pulling of the adventitial sheath, or essentially nudging the blood vessels, doing a low pressure vitrectomy. So we have multiple techniques over here. Another piece of embolus you'll be able to see now, which moves along the superior arcade over here, immediately restoring circulation. Yeah. So in summary, there have been rapid advancements in BR surgery, in vitreoretinal surgery, and this has enhanced the safety and the outcomes of the cases that we attempt. Of course, there is excellent prospect for the future, and we need to have continued innovation and improvements. And so this is to the young residents who can perhaps think beyond cataract also, and perhaps choose vitreoretina as your surgical career plan. Thank you very much.
Any question for him? Anybody, any question? Okay. No question? Okay, next we go to Dr. Anu Malik. Actually, are you here, Dr. Anu Malik?
Yes, sir, I'm here.
Yeah, actually, let me introduce her. Actually, she's assistant professor.
Please show the slide. Please show her intro slide.
Please show. Anybody? Slide. Anu Malik.
Premlata. Anu Malik introduction slide, please show.
Okay, let me talk about her. She's an assistant professor, cornea, cataract, refractive surgery services, RP Center, AIMS.
अरे 2 मिनट रुको भाई, अन्नू मलिक का शो करो भाई, इंट्रोडक्शन स्लाइड. थोड़ा स्लाइड दिखता है तो अच्छा लगता है. 2 मिनट रुक जाओ प्लीज डॉक्टर अभिषेक. इंट्रोडक्शन स्लाइड शेयर करो जहां से भी हो. आओ यहाँ. इंट्रोडक्शन स्लाइड के बिना डोंट इंट्रोड्यूस प्लीज. प्लीज वेट 2 minutes. She is faculty with Namrata Sharma in RP Center, and she looked after the most of the program of JHOS, and she is looking after most of the program of midterm conference also. She's a very important person, a very young, enthusiastic eye surgeon from RP Center, AIMS, New Delhi. So many faculties were this time from RPC.
Thank you, ma'am.
But there is no match of Shweta Walia. Shweta Walia is just fantastic. I have yet to see someone who's like Shweta Walia.
True, ma'am.
Explored her in 2016 when we were together. I was chief instructor, and for 3 long years I was heading a TSTC, and she was with me. Long back 2016, 8 years back. Since then we are always together.
Slide का क्या मतलब slide?
अरे स्लाइड के लिए प्रेमलता नीचे आ रही है ना, ऊपर नीचे कर रही है. 2 मिनट रुको. 2 मिनट रुको भाई.
कॉल किया है वो अभी दूसरे कॉल.
Okay, finally we have the slide now. Okay, let me come. Dr. Andu Malik, she is Assistant Professor, Cornea Cataract Refractive Services in RP Center AIMS. She is Executive Member of JHOS. She is also Associate Professor LLRM Meerut. She is ex-member of Executive Committee UPSOS. He is a principal investigator in some clinical trial. He got a prize of Dr. Mohan Lal Gold Medal Awardee, Retina session. He was a free paper and Colonel Ranga Chari Award evaluator in 2016. He was ex-member of UP State Action Plan for Blindness Control on Diabetic Retinopathy and Awareness. He is an organizational experience in ARC PG teaching program. She has worked as a senior research officer in prevalence and rapid assessment of blindness program, strategy and epidemiology research studies on blindness and visual impairment. She is a reviewer of a reputed international and national journal and invited as chairperson, judges, resource faculty in national conferences. So let's start with Dr. Anu Malik.
Thank you so much, sir.
We'll be talking about a topic of application of artificial intelligence in corneal disorder. Now next to Dr. Anu Malik.
Good afternoon, everyone. I would like to extend my heartfelt thanks to Jharkhand Ophthalmological Society for the kind invitation, and especially Dr. Bharti Kashyap ma'am. I will be presenting on the applications of artificial intelligence in corneal disorder. So I'll be talking on everything real about the unreal intelligence in ophthalm. Artificial intelligence is basically a software that mimics the human cognitive functions, and by processing and recognizing the patterns in the large amount of data sets. It basically shows the intersection of technology and healthcare. Thus, it has revolutionized ophthalmology by improving the diagnostics, personalized the treatments, enhanced the monitoring, and definitely has increased the operational efficiency of patient care. The term was coined in 1950s, and it was the first scientific step towards the intelligent machines. So its relevance is proven that it enhances the precision of diagnosis. It allows for tailored treatment applications. It definitely facilitates the proactive management in corneal health and definitely improves the workflow in our clinical settings. So coming to hierarchy of the artificial intelligence, we have machine learning, which is a subset of AI, which allows the machine to learn and adapt. Then we have deep learning modalities, which use neural networks for in-depth data processing and leverage the multiple layers of artificial neural networks to extract higher level features. Then comes the generative AI, which is trained on the vast data sets without any explicit instructions. So the key components of AI involve machine learning and deep learning. The machine learning is basically capable of analyzing the images, scans, and the other ocular data that can predict the disease progression and treatment outcomes. The deep learning algorithm excel in tasks like identifying the abnormalities which help in the
Can you see the slides? I am unable to see the slide. Can you see the slides? The conference hall people?
Yes, madam. Yes, madam.
Okay.
Okay, can I continue?
Yes.
Deep learning automatically identifies the key features that are set in the images and reduces the need for manual analysis by the specialist. So the capabilities of AI in corneal disease range from analyzing the data from corneal topography and patient history to detecting the early diseases and potentially preserving the vision. The ML model, they use a patient history to predict the likelihood of successful outcomes of the various treatments. Moreover, we can personalize the treatment options leading to improved patient satisfaction. The deep learning algorithms, they can detect features with high sensitivity and specificity, which are comparable to the human opinions. And they process the data from the wearable devices or smartphones that indicate the timely interventions if complications arise, and thus enhancing the patient safety. So this is how the deep learning works in AI. We have data acquisition, then data cleaning, then we develop a training set, we develop then a model. These models are evaluated and deployed consequently. So coming to applications of AI in corneal diseases, AI is very useful in cases of keratoconus, infectious keratitis, corneal transplants, and in diseases like dry eye disease, dystrophies, dysplasias, and degenerations. So let's see, can the human mind combine all of these? Yes, perhaps, but we often tend to concentrate on the aspects which are very apparent. Like if we are diagnosing a patient of keratoconus with the help of pentacam, we'll focus either on the Kmax, K1, K2, or the pachymetry. We can't focus on each and every number that is shown on a pentacam report. So this AI approaches like feed-forward neural network, CNN, SVM, and other automated decision trees, they help us predict the keratoconus management outcomes. We can detect early keratoconus, moreover, the post-operative keratosis. These are the machine learning algorithms which are most commonly used for the early detection of keratoconus. So AI algorithm basically analyze the topography maps, the ASOCT images, and increase the accuracy and early detection compared to the traditional clinical methods. For example, an AI model trained on a large database accurately classifies the patient into keratoconus patient or a non-keratoconus patient, aiding the clinician in the decision-making. Similarly, an AI tool can forecast the likelihood of progression to advancement in patient with early signs of keratoconus, because AI also analyzes the patient demographics, family history, and environmental factors that assess the risk of developing keratoconus. So here we are with the optimized treatment and improved patient outcome. For example, a patient undergoing the cross-linking is monitored through AI system. We can easily track the corneal thickness and the curvatural changes, thus facilitating the timely adjustment of the treatment plans. Moreover, we can early detect the complications leading to prompt management and improve patient safety. Coming to another use of AI is infectious keratitis. So in a study by Seni et al., it was seen that the ANN can classify fungal and bacterial keratitis, and the system scored much better than the clinicians. That is 90% versus 62.8%. The specificity in the fungal keratitis was 76.5%, and in bacterial was almost 100%. This ANN analyzed the corneal ulcer photographs and performed the semi-automated segmentation. So they could standardize the corneal epithelial defect size as well as the infiltrate measurement, thus reducing the variability between the examiners. So there are various studies that are done in the cases of infectious keratitis based on deep learning algorithms, where using more than 5,000 ocular surface images from a retrospective database set, it was identified. Moreover, deep learning models for extensive smartphone-based diagnosis and the triage of the cataract and multiple corneal diseases was done. Deep learning algorithms could easily discriminate between fungal keratitis and bacterial keratitis, and they could diagnose fungal keratitis based on the corneal photographs of laboratory-confirmed microbial keratitis. This is a video of a Corny AI app, and it shows how we collect photographs of the various corneal disorders. We can take the pictures of normal cornea, scarred cornea, lens opacity, deposit scars, pseudophakic bullous keratopathy, aphakic bullous keratopathy. And then this database set is used to analyze with the help of deep learning algorithms. These deep learning based algorithms help us differentiate between the normal cornea from the edematous cornea. So AI can detect early cases of Fuchs endothelial corneal dystrophy using high definition images. AI algorithm, they segment the corneal layers, so there is high precision in distinguishing the affected areas. These subtle changes in the corneal epithelium are detected with the help of thickness variations as well as the irregularities. So these AI findings versus human assessment findings are usually comparable, and these AI can identify these changes which are usually undetectable by the human eye. In cases of corneal transplantation, DL algorithm can tell us the graft detachment chances, the need for rebubbling after DMEC, the corneal endothelial parameters after the ultra-thin DSEC. This is based on endothelial cell density, coefficient of variation, and the hexagonicity of the cells. So there are various studies based on deep learning algorithms which can predict graft detachment, rebubbling, big bubble formation, predicting the success of DALC, and predicting the need of future keratoplasty surgeries using various AI algorithms like EfficientNet, ResetNet, UNet models. Pentacam Random Forest Index is a machine learning algorithm which is much better than Berlin-Ambrosio map in detection of post-LASIK keratosis. Coming to detection of dry eye disease, a CNN algorithm using ASOCT images has shown superior accuracy compared to corneal staining, conjunctival staining, and Schirmer staining. Similarly, in cases of meibomian gland dysfunction, using the confocal images, the model performance was seen. Area under the curve was 0.966 and the ensemble model area under the curve was 0.981. We can also quantify dry eye syndrome features with the help of CNN models for automatic quantification and staging of the disease. And we can correlate the keratopathy with clinical grades. AI is also helpful in cases of degenerative diseases like pterygium, which help in the automatic detection methods using ANN, SVM, and CNN based on the anterior segment photograph, similarly to distinguish between pterygium from the normal cases. We can also grade the pterygium with the FN score of 0.91 and sensitivity and specificity of more than 90%. So AI can help us improve the diagnostic accuracy and reduce the human error. So here we are left with enhanced diagnostic accuracy, tailor-made treatment approaches. AI-powered tools can also track the patient progress and monitor for the complications so that we can act timely. Coming to the most important challenge we have with AI is data privacy concern and importance of patient data protection. We have biases with using AI, and the risk of this biased database even affects the outcome of the results. As we know, in corneal imaging, there are few hurdles to build a very large database set, making it very difficult for us to assemble such large data. So the high cost of devices like tomographies make their availability relatively lower than the other machines. So the technical challenge to acquire the images with these devices, like confocal microscopy, it requires trained operators, which is also a challenge. Another limitation is the difference between the devices, even those of the same technology, they also differ. For instance, with Chimflex imaging, the scans obtained from the same patient with different devices are not interchangeable. So this is a risk of using the biased database sets. Moreover, it is difficult to integrate into clinical practice. It is much easier said than done. And the barriers to adoption in existing healthcare are also there. So considering the current trends and the ongoing studies and innovation, though AI can prove to be useful in predicting the disease progression and outcome. We have several AI-based smartphone apps which are exhaustively used for screening programs in remote areas. Everyone is aware of these AI apps which are used as IOL calculators, low vision aids, color vision test, eye exercises, and moreover patient education apps. We have many validated and endorsed apps with all these features. So these apps are widely used for screening to risk stratification, and the preferred AI algorithm is CNN that is designed for the healthcare professionals. So these apps are dedicated to professional use, but they are seldom peer reviewed, and studies are definitely needed to understand the readiness and concern of adopting these apps. So we need guidelines to choose an appropriate app that can be used, and the importance of interdisciplinary collaboration is very important in the design, development, and validation of these apps. So while acknowledging the advancement in the AI, I firmly believe that the clinical knowledge and expertise are paramount, and though AI can be a transformative tool, but definitely clinical judgment is essential. That's all. Thank you.
full of knowledge about corneal move and artificial intelligence. So, okay, anybody, any question about it? Any question to her?
My only concern with the AI people is they take our data, and we only analyze it. They take it and they make it and they sell it and crores. ये हम अपने आप को गरीब बना रहे हैं.
Yes, sir, raw data. Raw data privacy is a concern for AI apps.
Yeah.
See, Google will allow this. Okay, now next, our next speaker is Dr. Shweta Walia. She's talking about tips and tricks of for pediatric spectacles prescription. Dr. Shweta, are you there?
Yeah.
Good afternoon, everyone. Am I audible and my screen visible?
Yes, very clear.
So after such fancy talks, back to the basics. So my talk is on tips and tricks for pediatric spectacle prescription. Refractive error is the most common cause for reduced vision in the children, and many times children are unaware of severe visual problems, especially if an isometropia is present. And giving children the best vision when needed allows them to succeed scholastically. Visual deficits can also affect child daily function, normal play, which may decrease his or her confidence. Hence, prescription of glasses to pediatric population is very important skill that an ophthalmologist needs to master. So we all know that pediatric refraction has unique challenges. It is different from normal refraction, and it must be done meticulously and accurately. And we must keep in mind the concept of emmetropization, and we must know the technique, especially the retinoscopy. Cycloplegic refraction is the rule. Cyclopentolate 1% eye drops along with tropicamide can be used, and we must perform retinoscopy after 45 minutes after first drop instillation. We can also use hometropine 2% eye drops, and in selected cases, atropine 1%. So retinoscopy is the gold standard. Children usually are small and can't sit on autorefractometers. The autorefractometers can act as an aid, but prescription has to be based on retinoscopy. So this is for the residents. All of you must be aware of the streak retinoscope. This is the on button, and this is the light that you see. This is the forehead rest, the peephole, and this is the cross-linear polarizing filter, and this is the focusing sleeve. You can raise and above to set the lens. So it is done from an arm's distance, and you can use
ध्यान से सुनो.
neutralizing.
पर भी एक marks मिलेगा.
So this is how you see the glow in the pupil, and you have to see whether it is moving along the movement or it is moving against the movement, and you have to neutralize this glow. So the key points when you are doing refraction, you need to take into consideration that the trial frame should properly fit on the face of the child. If there is prismatic effect, especially if they are not looking through the center of the trial lens, the vision will not be 6x6 even with the best lens you have put. So the lens should be, the frame should be properly fitting, and prismatic effect should be avoided. You should match the axis binocularly, and you should compare it with the old spectacles. Now the 4 points you must take into consideration when prescribing spectacles to the children is their age, their presenting complaints, whether the child has strabismus and amblyopia. You must also know the concept of emmetropization. So we all know that the 3 factors that interplay for any refraction is the corneal curvature, axial length, and the lens power. And emmetropization is the process occurring during the normal growth period by which eyes move from a state of ametropia to emmetropia. So at birth, the eye is hyperopic, and with age, the hyperopia reduces. And by the age of 6 to 7 years, the child usually becomes emmetropic, and then the myopic shift starts. Now, you need to see whether the refractive error that is coming, whether it is normal for the child's age, and will this particular refractive error emmetropize? Will this error of refractive error, if you prescribe, disrupt the normal visual development or the functional vision? And if uncorrected high refractive error is left, whether it will lead to amblyopia and strabismus. So this is the chart which you should everyone put in your OPD, and this acts as a very good guide when to prescribe and how much to prescribe to the child of myopia, hyperopia, and astigmatism, whether the child is anisometropic, and this must be put in your OPD. Now, how much refractive error to be corrected without hampering the normal emetropization and inducing amblyopia? This is a very important thing, and we'll take a few cases to understand it. Now, let's see this case of a child who doesn't have any squint, no complaints, and is come for a routine examination, and you find that the vision is 6/9. And on cycloplegic refraction, it comes up to be +4 diopter spherical. Now, whether to prescribe or not to prescribe. So what is your consensus? Definitely, you will ask me what is the age of the child, whether he is less than 4 years of age or he is more than 4 years of age, and whether to prescribe the uncorrected portion equal to average for the age. Now, this is a very important chart which will act as a guide for the previous case. Now, if the refractive error lies between this inner two graph, then we should not prescribe. And if the refraction lies outside these two lines, then action should be taken. And if it is between the outer line and the inner line, then action must be taken to move it toward the center. Now, this child who has no squint, no complaints, routine eye examination, vision 6/9, cycloplegic refraction +4, and age is more than 4, then it will come in the outer layers. So you have to prescribe glasses so that amblyopia doesn't set in. Now so just because you measured it, it doesn't mean you need to prescribe. And prescribe the full refraction earlier on often gets in the way of emetropization and its active tuning process. So care must be taken to how much to prescribe to a child. Now let's take another case. This is a 5-year-old child who is asymptomatic, vision is 6/6, AR is giving astigmatism, and on retinoscopy also you are getting a bit of astigmatism. You will prescribe or not? Definitely no. You will keep this child under observation since he is asymptomatic and vision is 6/6. Now let's see another case. This is a 9-year-old child with a vision of 6/12, no symptoms, no complaints. He is ortho for distance and near. And on retinoscopy, it is giving +4 in both the horizontal and the vertical meridian. Now, cycloplegic refraction comes out to be +2.5 diopter spherical. Since he is having no symptoms and no complaints, and 9 years when the emetropization has completed, on PMT, he's accepting +1.5 and improving to 6/6, and so you will prescribe 1.5 diopter spherical to this patient. But what if the patient had complaints of headaches and vision was not improving to 6/6? Then definitely you will prescribe the full cycloplegic refraction, that is plus of 2.5 diopter spherical. Now let's take another case of a child who presents with an inward deviation of the eye, uncorrected visual acuity in the right eye 6/18, in left eye it is 6/60, and on cycloplegic refraction with atropine 1% ointment, in right eye with +2 it is improving to 6/12, and in left eye +7 it is improving to 6/18. Ocular movements are full, and prism bar cover test for distance gives 30 prism diopter base out esotropia and near 50 prism base out esotropia, and with correction both the eyes are ortho, and ACA by ratio with heterophoria method comes out to be 3:1. So this child is a case of refractive accommodative esotropia, and full cycloplegic refraction needs to be given with occlusion therapy. Now, this is a very good case for a 5-year-old child who had a vision of 6/60, and parents said that the child looked in a different manner. He was ortho for both near and distance. Ocular movements were full. On AR was giving a reading of +0.5 with a +3.5 diopter cylinder at 110, and in left eye +0.75 diopter spherical with +3.7 diopter cylinder at 90 degree. Retinoscopy were comparable, and on PMT, the vision with full cycloplegic refraction was improving to 6/24 only. So what you will do? Will you prescribe the full correction? Yes, you need to prescribe full to the child so that there is stimulation of the retina and amblyopia improves soon. This is a meridional amblyopia, and care must be taken that full correction needs to be given so that the amblyopia is treated. But many ophthalmologists feel that under correction should be given because the child will not accept this amount of cylinder. But this is a wrong concept, and full correction must be prescribed.
Now, this is a 4-year-old child who presents with a recent onset deviation in the left eye, and parents give history that child watches TV at a close distance. Uncorrected visual acuity was 6/6, ocular movements were full, and there was intermittent exotropia for distance of 16 prism diopter and exophoria for near of 10 prism diopter. After patch test for distance, the squint was 12 prism diopter and for near it was 10 prism. ACA by ratio was 5:1. And on cycloplegic refraction, right eye plus 0.75 diopter spherical with minus 0.5 diopter cylinder at 180 degree, and in left eye it came out to be plus 7.5 diopter spherical. So this was exotropia, and the child was coming out to be slightly hypermetropic in the left eye and mixed astigmatism in the right eye. So what will you do? So this was a case of true divergence excess type intermittent exotropia, and for this trial of over minus lens of -2 diopter spherical was given, and which came out to be minus 1.25 diopter spherical, and the vision in both the eyes was, for distance it was 6/6 -2 letters, and for near it was n/6. And with this refraction, he was ortho for both near and distance. So for such cases of intermittent exotropia, a trial of over minus lens, in this case of -1 point diopter spherical, gave us a good result, and this can be tried. Now, this is an 8-year-old child complaining of blurring of vision since 1 week. On right eye, vision was 6/36 and left eye 6/18. What will you do? Dry acceptance was minus 4.5 diopter spherical 6/12, and in left eye minus 2.5 diopter spherical 6/9. So when we did cycloplegic refraction, it came out to be plus 2.5 diopter spherical. So this was a pseudo-accommodative spasm of accommodation, and this doesn't need any prescription. We can just wait and watch. And so each child deserves your best. The art of prescribing spectacles in children is ruled by several considerations and should be done with due care. Thank you so much. Vision is first. Everything is after it. Thank you so much.
This is very informative, and I'm going to make a small video of your talk and will share with my optometrist. It's very useful. And thank you so much. Dr. Shweta Walia does cornea, she does cataract, she does pediatric ophthalmology, she does some plasty also. She is the professor in MGM Medical College, Indore. So thank you so much, Dr. Shweta Walia. So should we announce the result or should we wait for the session 4 and then announce the result? Session coordinators, बताइए क्या करें? Result announce कर दें? कि फोर्थ सेशन में बस एक ही टॉक है डॉक्टर श्वेता वालिया का, तो डॉक्टर श्वेता वालिया का टॉक के बाद हम अनाउंस कर देंगे रिजल्ट. डॉक्टर श्वेता वालिया, वी हैव द फोर्थ सेशन कोऑर्डिनेटर इज डॉक्टर बीपी कश्यप, चेयरपर्सन इज डॉक्टर विनय गुप्ता, डॉक्टर अनिंद्या अनुराधा, डॉक्टर रत्नेश and Dr. Rajmohan sir. We have already introduced them earlier. So she is going, this is a sponsored talk. She's going to give Ajanta ka sponsored talk hai. Ajanta is giving the mementos, beautiful mementos to all the PGs who have participated.
Share करनी है.
Educe ocular discomfort due to free radical damage resulting from digital screen. Slide share करिए.
जाओ ना, क्या कर रहे हो? कहाँ है आपका?
मैडम एंड्रॉइड है ना, क्या अजंता है?
अजंता का है.
माइक्रोसॉफ्ट.
अच्छा.
So is my screen visible?
It is visible.
So battling the effect of blue light on eye health. So we all know that the visible light spectrum lies between 380 nanometers to 780 nanometers, and it is detected by the human eye. And what is high energy blue light? It lies between 380 to 500 nanometers. High energy blue light, in layman language, we call it to be blue light. So now blue light is everywhere in this, it's in the sunlight, it is through the mobiles, desktops, laptops, palm pads, and the CFL bulbs. So it is coming from everywhere, and its overexposure is causing effect to our eyes. It is causing ocular surface disorders, pterygium, cataracts, and macular degeneration. So the short-term effects are digital eye strains. We have headaches, blurred vision, dry eye strain, and eye fatigue. And long-term effects are on retinal damage. There is poor glare recover and reduced visuals and age-related eye conditions. So now also this blue lights, it disrupts the natural circadian rhythm, and it creates haze, reduces the contrast sensitivity, and there is glare recovery from the glare is reduced. So circadian rhythm, the range of the blue light is from 460 to 480 nanometers. The LCD peak is at 440 nanometers, and most damaging is the 380 to 440 nanometers range. So now when we are looking at the screen in the night, it definitely has a bad effect on our eyes, and also it disrupts our sleep pattern. So what circadian rhythm is controlled by the melatonin, and blue light is a powerful suppressor of melatonin. And once the melatonin is suppressed, our natural sleep rhythm is disrupted. Also, the American Medical Association has shown that the extended use of electronic devices can disrupt our sleep or exacerbate the sleep disorders, especially in the children and adolescents. Also, the American Optometric Association has linked blue light to the computer vision syndrome, also called as a digital eye strain. Now, what are the various effects of computer vision syndrome? In the eye, it causes tearing, dryness, redness, burning sensation. Along with it, there was various musculoskeletal side effects also of looking so much into the screen. We have visual headaches, we have neck pain and back pain. Now, when you are in the straight head, there is no pressure on your neck. But as your neck is bent down, the effect on the pressure on the neck is increased. When you are at 60 degree, it causes 60-pound pressure on your neck. And this is the reason why neck pain is so common amongst the adolescent age children. Also, this blue light causes dry eye and irritation. When you're looking into screen, there is decreased blink rate. There is partial closure of the eyes, and hence there is no massage of the meibomian glands, and so there is dry eye. Also, due to continuous opening of the eye, staring look, the tear films are dried and it leads to dry eye. Common and essential practice of digital displays in daily lives has been shown to alter the oxidative stress markers, leading to increased inflammatory mediators and tear osmolarity of the computer users. Now, because of increased exposure to this blue light, there is release of various reactive oxygen species, which causes oxidative stress, leading to ocular surface disorders, hyperosmolarity, apoptosis of the corneal and conjunctival cells, which leads to inflammation and hence tear film instability. So the use of smartphones leads to excessive reactive oxygen species production, damages the corneal epithelial cells, leads to apoptosis, inflammation of the ocular surface, and resulting in dry eye. Also, overuse of these digital devices leads to damage to the lens, also leads to early cataract, and also damages the retina, leading to age-related macular degeneration. Also, there is eye strain, and also the patients also have complaints of double vision. So reduction of blue light will improve the contrast and sharpness. And however, there is no proven link between the reduction of blue light and alleviation of symptoms due to digital eye syndrome. So because of this blue rays, the macular pigments, the lutein, melanin, and the ocular lens pigments, which are antioxidants, are damaged, and hence it leads to ARMD. These reactive oxygen species, they degenerate the retinal pigment epithelial cells and the photoreceptors, and hence the age-related macular degeneration sets in. This is supported by the Beaver Dam eye study. And how can you prevent this overexposure to blue light? So very important thing is to go for a 20-20-20 rule. Every 20 minutes, take a break and look something at 20 feet away. This is very simple and everyone can do it. We can take vision breaks. We can gaze into the darkness. We can do side-to-side eye movements, closing movements, eyelid massage, and upper eyelid relaxation by putting 3 fingers of each hand on your upper eyelid. Also, there are reports which say that the antioxidants, if we take, it will reduce the oxidative stress which occurs in dry eye diseases. So there has been role of N-acetylcysteine, which is an antioxidant and is seen in various eye drop formulations also. To conclude, oxidative stress resulting from the imbalance between the reactive oxygen species production and the antioxidant defense contributes to tear film instability, ocular surface damage, inflammation in the dry eye patients. And various factors contribute to the development of dry eye disease, primarily including the lifestyle issues like overexposure to the digital gadgets, aging, and hormonal changes. Furthermore, raising awareness about the role of oxidative stress in dry eye disease among healthcare providers and the patient is crucial for promoting early diagnosis and effective management strategies. And by addressing oxidative stress pathways, we can pave the way for improved therapeutic outcomes and enhanced quality of life for individuals affected by dry eye disease. So we need some formulation which will have, along with the carboxymethyl cellulose, it has antioxidants, it has nutrients. So there are many eye drops which are available, which have antioxidants like the N-acetylcysteines, along with the carboxymethyl cellulose, electrolytes, and the various nutrients like vitamin A and vitamin E, which can give a relief in dry eye disease. Thank you so much.
Thank you, Dr. Shweta Walia, for being with us till end. I can see you are here till from the case presentation time. And thank you so much. And I'm going to announce result after vote of thanks. And vote of thanks will be by our ex-president, Jharkhand Ophthalmological Society, Dr. B.P. Kashyap, because our secretary is Bengali and he has gone for Sindur Khela. There is some function in his society. So over to Dr. B.P. Kashyap for vote of thanks. After that, I will declare result.
खड़ा होके vote of thanks नहीं कि बैठ के
बैठ के ही दीजिए.
Let me thank all our delegates who are indirectly.
आगे आइए.
Focus कर. Faster. इसीलिए मैं वॉश में नहीं आता हूँ. घर में भी हुकुम, बाहर भी हुकुम, आगे आइए, पीछे आइए.
ये देखिए डॉक्टर जगदीप ककड़िया को जगे हुए हैं. 4 बजे भोर में, 5 बजे भोर में.
So let me thank all the delegates who are directly or indirectly, attending this midterm conference. And I must thank Dr. Bharti, the chairman Scientific Committee, who has worked day and night, leaving all the works of hospital and house, and then into the making this conference a successful conference. She has talked almost everybody on telephone, whether it's a JHOS member or DOS member or ISOP member or RNA members. And I must thank all these guest faculties from all over India, our local faculties, and stalwarts of Jharkhand like Dr. Sunil, Dr. Deepak, Dr. Rahul Prasad, and so many of them are there. I'm sorry if I'm skipping their names because it is not possible to take everybody's name. And I must thank all my staff who have helped us to look after everything, the broadcast, the coordination, the off and on tea and coffee and water and lunch and breakfast and everything. I must thank the entire people who have, as usual, they have contributed their part for all the webinars they have been doing. So this time also they have done a wonderful job.
And Ajanta also? Ajanta also for sponsoring the mementos for all the PGs.
And Ajanta also because his name was hidden. So I must expose their name also, that Ajanta also helped us a lot. They have promised good mementos for all the people who have taken part, who have participated in this webinar. I must thank the faculties from AIMS who have either they have allowed their junior colleagues to attend, or they have attended. It was so nice of them. Thank you very much. And I must thank all those delegates who are who were with us throughout the day. I could see the number increasing to almost 60, 70. It's a very high number in a small state like Jharkhand, where in an annual conference, the attendance is almost 60, 70, 80. It's a mid-conference, on a webinar. If 50, 60 people are attending, it's just a tremendous job. Thank you very, very much from the core of my heart. And I must thank Dr. Shweta Walia especially. Madam, you're superb. Anu Malik, you're superb. Why I'm saying superb? Because I feel you're superb. Thank you so much to have been attached to us. And stalwarts like, the Arvind, the innovators, they are really innovators. We are no less than anybody. And it is so nice of them. So I thank them that they came to our state webinar, very small state. We don't stand anywhere. We are one of the small states in India to have contributed to the AIOS and to National Society in a very big way, and will continue doing it with the help of all our people who are attached to us, whether it's a pharma company or faculties. Thank you very much, and all the people who have helped us in having a good lunch and dinner and breakfast. And I'm sorry if I'm missing anybody's name. Thank you very much. And I do expect the same kind of participation in the next whatever conference or whatever meeting.
It is on 28th. It is International Hero Session.
Yeah.
So a lot of European Society Conference and American Society Conference winners, they will be presenting on 28th. All the winners and the latest winners. I have taken the 22, 23rd winners. They are going to present, and they have been awarded also in. They are going to be awarded in midterm conference, in the forthcoming midterm conference in Dehradun. So now I am going to announce the result. For the first position, there is a tie between Dr. Ashi Sabha. She is from senior resident from Bokaro General Hospital, and Dr. Anamika Chaudhary. She is the first year Rio RIMS student. The second position is for Vatsala Kumari.
Thank you so
Ashi,
much, ma'am.
you
Yes, ma'am.
won.
Thank you so much.
And Anamika Chaudhary. Varsha Kumar is second, Anamika Chaudhary first. There is a tie between two of you.
Thank you so much.
And there is the Vatsala Kumari, first year MS Rio RIMS. She is the second winner. And the third winner is Dr. Nitish Kumar Marshall. आज सुबह इसको मिला है faculty link. Dr. Nitish Kumar Marshall, where is he? Dr. Nitish Marshall?
Yes, ma'am.
तुम भी winner हो, third position, and you will be getting, all of you will be getting beautiful mementos, and all the presenters, whoever has presented, they are all going to get beautiful mementos delivered to you at your footstep by Ajanta Pharmaceutical. We have selected very nice pieces. So once again, congratulations to Arshi, congratulations to Vatsala, congratulations to Anamika Chaudhary, and congratulations to Nitish Marshall.
Thank you so much.
With this, we end the midterm conference, and I am coming upstairs to the conference hall for the group photo with the people who have who are with us till the last. Bye.